Good morning, everybody. I hope everybody will start a nice Toronto. And you are attending the first session of a week-long series of events, webinars, and discussions about living kidney donation and living organ donation. This is the Living Donation Week, organized by the Center for Living Organ Donation at the University Health Network in Toronto. Health equity, access and equity in living kidney donation and living kidney transplantation. We have a series of international speakers who are international leaders in both research and clinical change implementation in this area. And the events that we are living through, this is a very timely session, and it's important for us to reflect on these essential questions that we face in our everyday practice. The session, a perspective from the United Kingdom, then we'll jump over to the United States, and then review some of these questions that are the way they are seen from Canada, and we eventually practice from that perspective. At this point, we plan to have a question and answer session at the end. Please use slido.com with the code AM1. AM1A is the code actually for Slido to send in your questions. If there are pertinent questions at the end of that individual presentation, and have a brief question and answer there, but at this point we plan that all the questions will be asked at the end of the 4 presentations. As a reminder, this session will be recorded. It will be available for subsequent views on the YouTube channel of the Center for Living Organ Donation, A.C.T.I.O.N. I guess the next step is that I will introduce our speakers. And again, just keep on reminding everybody that if you have questions, please send it in using the Slido platform, which is at slido.com. And the code for this presentation, this session is AM1A. So let me first introduce our speakers, and then I can pass on the microphone, and we can start this important session. The first speaker will be Professor Kurt Randhawa from the United Kingdom, who is a professor of diversity in public health, and he's the director of the Institute for Health Research at the University of Bedfordshire. He is also the director of the UK Organ Donation and Transplant Research Centre. His research is focused on the development of patient-centered care pathways in chronic conditions, including diabetes, chronic kidney disease, transplantations, and also end-of-life care. And he has been specifically focusing on these issues in diverse communities. He has been working with many colleagues internationally, including colleagues in the UK, European Union, Middle East, Qatar, Australia, Pakistan, and India. The UK Organ Donation and Transplant Research Centre has carried out extensive research examining variations in organ donation rates among different ethnic and faith communities. And currently it is carrying out a feasibility study to look at whether primary care physicians can play a role in organ donation, donor registration, and improving transplant rates and potential living donor transplant rates. Dr. Randhawa was recently commissioned by the National Health Service Blood and Transplant to develop the Faith Engagement and Organ Donation Action Plan, which was published in partnership with faith leaders. And he also, importantly, holds a number of policy and practice positions, such as he's the co-chair of the European Working Party on Public Issues in Organ Donation and Transplantation. He's the chairman of the Transplant 2020 stakeholder group, He's a national member of the National Black and Minority Ethnic Transplant Alliance. And finally, he's a national member, organ donation and transplant strategy steering group with the National Health Service Blood and Transplant in the UK. So obviously, he's very well positioned to share his perspectives and perspectives in general from the UK. The second speaker in the series will be Dr. Amit Garg from Canada, from London, Ontario. He is a professor of medicine, epidemiology, and biostatistics at Western University in London, Ontario. He's also the site director of the Institute for Clinical Evaluative Sciences, the Western facility, and he's the provincial lead for the ICES dialysis, kidney, and transplantation program. He practices general nephrology, and he's also, importantly, the director of the Living Kidney Donation Program at the London Health Sciences Centre. Dr. Garg has been extremely active and successful in clinical health services and population health kidney research with probably close to 400 peer-reviewed publications, very impactful ones, including research that included the introduction of new information for living kidney donor candidates as part of the informed consent process, and also other areas of chronic kidney disease, such as the impact of specific E. coli infections that made to the courts and had an important impact there. Also, he has been writing about drug prescribing, safe and unsafe prescribing practices, potentially causing acute kidney injury. And certainly, again, the impact of that research was indicated by label changes by the US Food and Drug Administration. He has also served on the board of the Canadian Society of Nephrology. He was the president of the society. He co-chaired the International Kidney Disease Improving Global Outcomes KDIGO clinical practice guideline process, and co-chaired the Living Kidney Donation Committee. And he is serving on the Living Kidney Donor Advisory Committee of the Canadian Blood Services, and also he is the medical lead for the Ontario Renal Network, that is the main funding and directing body for kidney care in Ontario, and he's the provincial lead for kidney transplant. And in that capacity, he's leading an important provincial quality improvement process, the ENACT project that is aiming to improve kidney transplant, access to kidney transplant, and specifically access to living donor kidney transplant in Ontario. He has received numerous grants and awards, and he's also sitting on numerous committees. He's on the editorial boards of American Journal of Kidney Diseases and JASN. He received the National Kidney Foundation International Distinguished Medal for his research contribution, and multiple other awards. So he will be talking about overall systemic approaches to equity in living kidney donor transplant. And I just realized that he will be actually speaking third, because the second speaker in the series will be Dr. Tanyala Purnell, who is an epidemiologist and health services researcher with more than a decade experience related to identifying and addressing patient, family, healthcare system, and community factors influencing health and healthcare disparities for adults with cardiovascular disease, risk factors including hypertension, chronic kidney disease, and diabetes. She's an assistant professor at the Cardiovascular Disease and Clinical Epidemiology at Johns Hopkins Bloomberg School of Public Health. She holds joint faculty appointments at the Johns Hopkins Departments of Surgery, Health Policy and Management, and Health Behavior and Society. She has multiple other roles, including an associate director position at the Johns Hopkins Urban Health Institute, where she co-leads the Institute's efforts to facilitate and recognize collaborations between communities, universities, healthcare delivery systems, government, and the private sector to build a collective capacity for achieving health equity in Baltimore, but also in a broader society in the United States. She's also the Associate Director for Education and Training at the Johns Hopkins Center for Health Equity, where she leads the center's award-winning education and training programs for public health, nursing, and medical scholars working to advance health equity. In addition, she is the Director of Community and Stakeholder Engagement for the Hopkins Epidemiology Research Group in Organ Transplantation, core faculty at the Raj Center for Prevention, Epidemiology, and Clinical Research, and an affiliated faculty with the Bloomberg American Health Initiative at the Center for Health Services and Outcomes Research. She is one of the lead researchers working on health equity in transplantation and other chronic conditions. She is a native of the Mississippi Delta and a proud alumna of the Tougaloo College, where she obtained her bachelor's degree in computer science. She has received several national and international research honors and has published findings from her work in leading medical and public health journals, including the JAMA, Health Affairs Journal of the American Society of Nephrology, American Journal of Hypertension, and so on. She has certainly published many of the key pieces that inform us about health equity and equitable access or inequitable access to transplantation and living donation. She is deeply committed to community service, teaching, and mentoring, and she is a recipient of multiple teaching excellence awards from Johns Hopkins. Again, I think she's in an excellent position to share her research and also her perspective on the issues that we try to have a better understanding on. And the series of talks will be concluded by a talk by Dr. Amy Waterman, who is a transplant innovator and a professor in residence at the University of California, Los Angeles, within the Division of Nephrology. She is the Director of Transplant Research and Educational Center and the Deputy Director of the Terasaki Research Institute. In addition to many national transplant leadership positions, Dr. Waterman is a Fellow of the American Society of Transplantation and serves as a Research Committee Chair for the National Kidney Registry, a exchange program. In 2019, she received the American Society of Transplantation Clinician of Distinction Award. In 2018, she received the Claremont Award for Distinction from the Center for Plain Language for Interactive Digital Applications. That is called My Transplant Coach, as well as the National Health Information Merit Award for 2 educational initiatives developed by Explore Transplant, a nonprofit consortium that Dr. Waterman had founded. Through her research and educational initiatives, Dr. Waterman seeks to understand the critical modifiable patient, provider, and systems barrier to kidney donation and the living donor transplant. She also designs interventions to overcome these barriers. The mission of her laboratory at the Transplant Research Education Center is to inspire and educate people about kidney transplantation and living donation and reduce racial, socioeconomic disparities in transplant. Its vision is to increase transplant and living donation rates and solve the kidney donor shortage. The center focuses on translating the findings from effective clinical trials into everyday practice through collaboration with healthcare providers, transplant leaders, and policymakers. Dr. Waterman is driven by 3 core beliefs. One is that transplant-eligible kidney patients deserve to make informed choices about their treatment options, especially disease or living donor kidney transplant. Second, there are many generous people who may become deceased and living kidney donors, but they need to learn what donation involves. And finally, if we all work together, kidney patients, their families and communities, and kidney healthcare professionals, our collaborative efforts can reduce the national kidney donor shortage and increase the number of people living longer with the benefit of kidney transplant. Similar to the other speakers, she received a PhD during her studies. Her degree is in social psychology with an emphasis on patient education and behavior change from Washington University's St. Louis where she was a faculty member until she moved to Los Angeles. So before moving in, I think just to summarize what we heard from the bios of the speakers, we will be talking about broad systemic issues that are very relevant and sometimes painful in the current times. But the systemic approach and the deep understanding will need to be intertwined, and it is intertwined in the work of the presenters with personal beliefs and personal action, so that some of the inequities and injustices that we will be discussing will be overcome, hopefully in the not too distant future. So at this point, without further ado, I will hand over the microphone to Dr. Gert Randava to start his talk. And again, to remind everybody, if you have questions, please submit it through Slido. The code is AM1A.
Thank you very much. And good morning to those of you in Canada. It's a lovely and unusual sunny afternoon in England at the moment. And it's an absolute pleasure to join you at the beginning of your donation week in Canada. We've just had our donation week in the UK, ended yesterday. So I'm going to spend the next 15 to 20 minutes discussing some of the progress we've made in the UK, but also some of our candid lessons in the spirit of sharing and openness and transparency. So just sort of thinking this through, the journey to access and equity is really a story that's ongoing. It's not a static process. It's actually a very dynamic process. So this is just an image of Europe, and it just shows, here's the UK, it just shows the percentage of foreign-born people in the UK, but also here's France, Spain, Germany, etc. Here's Italy. And I've just put this up here just to show you that sort of immigration is a global phenomenon. And what's improved is because our ability to collect data is improving, the debates we're having now around access and equity, they're able to take place in a more nuanced and evidence-based and sophisticated way. But the point is, access and equity needs to be an ongoing challenge. It's not something that's ever going to be solved overnight. And we all need to work together, which is why I'm so pleased that we've got this webinar today. And this, just to give you a bit more granularity, shows you across Europe the countries from which the main immigrant communities reside. So again, in England, the majority of the foreign-born immigrants are like my parents, who came to England in the 1960s from India. In Ireland, they're from the UK. In France, they're from Algeria. In Spain, they're mainly from Morocco. In Italy, it's mainly from Romania. In Germany, it's Poland. And I just show this because it gives you a bit more texture about the kind of globalization we're seeing. And it's important to think about this as we develop health and social care and start to think about the challenges around kidney donation and kidney health more generally. So here, when you look at population projections, I'm sure you've all seen very different versions of this. The blue line is the UK. It's predicted that by 2050, if you compare the UK, the Netherlands, the US, Germany, and Denmark, the UK has a trajectory of being one of the most, if not the most, diverse populations in the world. And as I said, in parallel with that, it therefore impacts upon the planning and commissioning of our healthcare, and really makes it really important for us to start thinking about culturally competent care and planning for issues like access and equity. So in terms of my research, what I've been looking at is, as a public health professor, I'm quite interested in the whole pathway. So in an ideal world, I'm quite interested in people not becoming ill in the first place. You know, that would be utopia. But we know that our rates of diabetes, high blood pressure, kidney disease are much higher in our South Asian communities, those from in the Indian subcontinent, much higher in our African Caribbean communities, and also now growing in our next biggest growing community now in the UK is actually from Poland. And they're also beginning to see high rates of diabetes and blood pressure. What's happening now is we're beginning to see a higher proportion of dialysis patients from those communities. And then on a human level, what do those people do? So if they don't get a transplant in the UK, and I'll explain why they may not in a bit, some of them understandably look for alternative options. So some of them go overseas for a transplant, many of whom, for example, go to their countries that they originally arrived from. Others, quite sadly, engage in transplant tourism. And although we know it's illegal, the harsh fact is some people feel they have no alternative. And we need to obviously support them to make a different choice if we can. But also in the UK, there is this issue that there are reduced opportunities for transplantation, especially amongst our minority communities. And overlaid on that is the fact that there's much worse end-of-life care, if any end-of-life care, for those people who are now too ill to receive a transplant. So a whole host of issues, all the way from prevention to management and treatment of kidney health. So if we look at living donation in the UK, we can see that they make up about 40% of our total donor pool. And in the last financial year, 14% of all living donors were from our non-white communities, which is not bad. And 18% of our living donor transplants were with BAME patients, which is pretty good. And as you'd expect, most of our living donation is mainly of the kidney, so 98%. And in the UK, 80% of those waiting for a transplant are actually waiting for a kidney. And living donors make up 40% of all kidney donors and 28% of our transplant program. So it's quite a sizable program. But as I suspect we'd say in all countries, if we could really bolster our living kidney donors, we could have a huge impact on reducing the transplant waiting list. And these are just figures for the last 5 years. And essentially what these show are that there's a 4% fall in our waiting list, which is good news. There's nearly a 30% increase in our transplants, which is also pretty good news. But there has been a decline in our living donors, but there has been a massive increase in our deceased organ donors. So like all countries, we're making some progress in some areas, but less so in others. And clearly living donation is something we want to improve. Now, thinking specifically about our Black and minority ethnic communities, I think this for me is my most interesting slide, which is available from the NHS Blood and Transplant website if you want to get more details. So roughly speaking, in the UK, 11% of our population is non-white, i.e. Black and minority ethnic communities. And this slide eloquently paints the conundrum of the UK donation and transplant issue. However, although we make up 11% of the population, we only make up 7% of the people registered on the organ donor register. Now, there are caveats to this data because this is only 7% of the people who've declared their ethnicity. So it could be higher than this. However, when you look at the opt-outs, nearly 80% of opt-outs on the UK. In the UK, we are in an unusual position. We have an opt-in register and an opt-out register. There's a much higher proportion of Black and minority ethnic communities on the opt-out register. And disproportionately, you can see that although we only make up 11% of the population, we make up nearly a third of the transplant waiting list. And that's all to do with higher rates of diabetes and kidney disease. and high blood pressure, hence the need for a pathway approach to kidney health. We make up just under 10% of eligible deceased donors and just over 7% of actual deceased donors. And as I said, we're doing quite well in terms of living donation, doing quite well in terms of transplants, both deceased and living. But in a sense, here's our conundrum. We're doing well on living donors, well on deceased donor transplants and living donor transplants, but not so well on deceased donors, eligible deceased donors, not so well on waiting lists, not so well on opt-out, and not so well on opt-in. Hence, I think our challenge is, how do we take a systems approach to solving these issues rather than only focusing on either transplantation or donation or on prevention and management? It really needs to be the whole pathway, which is what I'll describe about some of our work now on community engagement. So this is essentially my work. So I've been working for the last 20 years with communities of different ethnic groups. And essentially, although, and I mean this in the politest way, most governments and healthcare services are very focused on organ donation, when you actually speak to public and communities, and I guess, September 2020 is a good time to have this conversation, countries are actually, communities are really interested in the issue of trust, because unless they trust the government and they trust the service providers, they're never ever going to entertain the idea of donating organs, donating blood, donating stem cell, etc. And the only way they're going to build trust is if you start to tell the story about how organs are retrieved. So what's the process and where do these organs go? And this is all part and parcel of building trust. And most importantly, it's about who is conveying these stories. Because with all due respect, not just to myself, but many of the people who run these campaigns, they tend to be either clinicians or academics. And although we are fairly well trusted amongst the community, the people who are most authentic are the people from that community who've actually gone through the lived experience of either being a living kidney donor or being a donor family member of a deceased donor, who can only openly and honestly talk about their experiences of how those organs were retrieved, how their life was impacted. So essentially that model I've loosely translated into something what I now call messages and messengers. And I'm just going to very quickly run through this. So essentially this gentleman here, he's a gentleman who's actually donated one of his kidneys. So when we run community events, he's able to talk vividly, honestly, about the highs and lows of being a living kidney donor, and about his honest experience about how he's struggled with his diet and lifestyle since being a donor, but he's so pleased he's done it. And I think that really does build trust and engages communities. Here's a recipient. Here is another donor. This gentleman is the brother of a deceased donor. This lady is a recipient of a kidney. And other people on these slides are either clinicians or even community leaders. But essentially what I'm trying to convey here is that we've got to really take a multifaceted approach to building a dialogue with our communities. And only if we do so, and not just talk about donation, but also talk about improving kidney health, preventing kidney disease, are we really going to develop long-term sustainable systems-wide solutions to these issues. So just an example I want to share with you, and this has been led by NHS Blood and Transplant and the National BME Transplant Alliance. They, in the last 4 years, have been running something called the Living Transplant Initiative. And it's been a wonderful pilot scheme where they've been trying to now increase living donation amongst our Black and minority ethnic communities. And it's all community-led. So these are projects led by community groups here listed on the left, 4 different demographics, So it recognizes the heterogeneity amongst our different minority communities. It also recognizes the different locations in the UK, but most importantly, it recognizes the community-based assets that we have, and we should never within these communities. And there's been some more recent projects. Again, this one's in London, another one in Leeds, another one in Birmingham, all to do with different communities within our Black and minority ethnic communities. And as I said, all mainly to do with building community awareness. And also we've been piloting a peer volunteer home education program. But essentially, it's all focused on this whole idea of having different messages and different messengers suited to the communities. And how these projects are being measured. So we're looking at the number of people who've now expressed an interest in being a living donor, number of people who started the donor assessment process, and ultimately the number of people who donate a kidney. So what's been learned, there's again a report that you can access from this website at the bottom. What we know is, which has been a fantastic outcome of these projects, is that if you have tailored faith-based educational materials, then people are far more likely to engage. And as I said, this is all going back to building trust in the communities. Community events are really good in terms of raising awareness. However, as I said, in the spirit of sharing, of those who expressed an interest in donating a kidney, very few have proceeded to assessment or donation within the lifetime of these projects. Now, that's not to say it won't happen. It's just in this time frame that hasn't happened so far. But it has fostered very positive collaborations between the community leaders and transplant professionals. And ultimately, the key learning has been that if you have targeted community-tailored education led by the communities themselves, it's going to be far more likely in increasing living donation amongst these communities. So the current plans now are to really focus on increasing living donation amongst the Black and minority communities, especially in the lower socioeconomic groups. So the plan is to run a few more projects and then report back next year. But as I said, this is all about building trust and about focusing on different communities. And here are a summary of those projects. So this one's in Scotland. Here's one in the south of England. This is in London. Unfortunately, and I suspect this is true globally, a lot of these community projects are being affected by COVID-19. But the key point is the learning will be very important as we start to plan, hopefully, once we come out of the COVID pandemic. So the next steps are to obviously produce a report to share with people, and then think about longer term investment, targeting particular communities, so we really do get living donation embedded into our society and really focus on reducing health inequalities in our different programs. Just some reflections from me, which I think is important to share really, is, and this goes back to where I started off from, if we're going to think about equity and access, we really do need to think about collating and using data. And although in the UK we're doing our best to collect data on ethnicity and issues like religion, we're not really good at it. We're not brilliant at it. We need to be better. And the only way we're going to get better is if we do genuinely start to build trust within these communities. And I'm sure you've probably seen on the news, and I'm sure it's been an issue in many other countries, we haven't really covered ourselves with glory in the way we've handled COVID-19 with our different ethnic communities. And all of these issues impact upon each other. So you can't think about kidney donation in isolation to other issues. So we've really got to think about how we collate data. And therefore, there is this debate, which I'm sure many countries are having, about how immigration is described and talked about. And in the UK, as you'll probably know, we're going through something called Brexit, which again doesn't really portray immigration in a positive way and doesn't really make people feel valued. And therefore, we need to consider how these politics impact upon issues like donation and transplantation. It would be really naive to think they don't impact upon donation and transplantation. So we have to be mindful of this political debate. And some of the standard solutions I would argue for is we need to have cultural competency embedded in national policy making. It needs to be embedded in organ donation campaigns. And ultimately, we need to be able to measure it. We need equality impact assessments of all transplant waiting lists and organ allocation programs. And we need to ensure that the debate and dialogue of organ donation is ongoing with all communities if we want transplantation to be sustainable. So that's been a really quick canter through. The person I'd like to thank the most, and I think every person in the country needs someone like this. So we have a wonderful person called Lisa Burnap, who works at NHS Blood and Transplant, who leads our living donation work. And she's got one of those unique talents that she's able to straddle both the policy making, but also the community engagement work. So if you're able to, contact Lisa. And, if we could, I would advocate cloning her, but I'm sure we can't. But thank you so much for giving me this wonderful opportunity, and look forward to the questions.
Thank you very much for this presentation and providing important material for thought and for discussion at the end. At this point, I don't see any specific questions that would require immediate attention. So we'll save the questions to the end of the 4 presentations. So the next talk will be presented by Dr. Tanyala Purnell from Johns Hopkins University from Baltimore. And I just passed the microphone on to Tanyala, who will talk about living donor kidney transplantation and the African American communities in the US. And thank you very much, Tanyala, for saving the time for us, and looking forward to your talk.
So thank you so much for the warm introduction and for the invitation to talk to you today. This is a very important event, and I will say hello to everyone. It is also morning here in Baltimore, and it is a beautiful morning. So I'm thankful for that. And so we will get started. So I like to just jump right into it. So what is the problem? We know that we're talking about perspectives from different countries. And we know that, in terms of kidney failure and the national burden, this is also a major issue here in the United States. In particular, as with many chronic conditions, we see a disproportionate burden in the southeastern United States, but also in other parts of the country, including California, and in particular, the lower part of California. And so when I show this slide, I often ask people to weigh in on, what could be going on. And, people talk about the different policies at the state level, thinking about things like expansions of Medicaid, but in particular, just thinking about the burden of the major risk factors for kidney disease, which, as you know, are diabetes and hypertension. And so unfortunately, many of the same areas where we see a large burden of kidney failure are those same areas where we see major risk factors for kidney disease, and for which we know that it is harder to find living donors because, of course, we want people to be healthy. So these are, just some of the trends coming from our USRDS, so United States Renal Data System, annual registry analyses. And so in terms of looking by race within the US population, we see, in terms of the prevalence of ESRD, we see a disproportionate burden among Native Hawaiian Pacific Islanders, Black African Americans, then followed by American Indian, Alaska Native, Asian, and then white, non-Hispanic white Americans at the very bottom. Also, when we look by ethnicity, which is defined in this country essentially as Hispanic or not Hispanic, we see that there is a larger burden among the Hispanic as compared to the non-Hispanic ethnicity. However, when we look at our rates of living donor kidney transplants, we see almost the exact opposite of what we just saw in the previous slides in terms of who is most likely to experience end-stage kidney disease. And so, as you can see here, non-Hispanic white Americans have the highest rates of living donor kidney transplants, followed by Asian Americans, and then sort of mixed in between, we have Native Hawaiian, Pacific Islander, American Indian, Alaska Native, and at the very bottom, we see Black African Americans. And so we know that this that something doesn't quite seem right with this, and we've known this for a while. We've seen this in many other conditions, and what we are generally describing, is really something that falls under this broader umbrella called health disparities. And so, one definition of health disparities, according to the WHO, is that we can really define these as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And where we truly want to go is a state of health equity, where every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this because of social position or other socially determined circumstances. And so that is also something that is very relevant for this issue of living donor kidney transplants or just living donor transplants in general. And so again, when we don't have a healthy population and when the burden of chronic illnesses repeatedly fall upon certain groups, then this again impacts our pool of potential donors. And it reflects what happens in terms of disparities in actual rates of living donor transplants. So one thing that I found recently that is important to talk about is what is the definition of race as it relates to how we measure race and how we interpret and how we should interpret the findings here in the United States. And so what we do know is here in the US, most of what we generate regarding differences by race is essentially an attempt to collect data that's usually self-reported or provider-reported within either surveys, within national registries, or within some other large data set. And again, this is self-identified. So this is not to be confused with true basic science studies that do genetic ancestry analyses, which, as we know, based upon the results of the human genome, is that there's lots of variations across these so-called racial and ethnic categories, and there's no clear distinction among a particular group of people under a particular label. And so I went to the US Census website because many of the categories we use really adhere to these same 1997 US Office of Management and Budget standards on race and ethnicity. And what they say is that the racial categories included in the census questionnaire, which is what we typically use as the basis for our categories, generally reflect a social definition of race recognized in this country and not an attempt to define race biologically, anthropologically, or genetically. And so I think that that's important to really think about when we are interpreting the findings and thinking about the why, how do we get here? And in particular, again, when we're using these self-identified or provider-reported categories, what is truly going on? We also have a consensus report that came out about 2 years ago in JAMA from several leaders of NIH institutes, really where they brought together lots of experts who basically said that there's a lot of confusion about how findings are interpreted within biomedical research. But one of the things, which as you'll see is highlighted in red here on the slide, is that they really warned investigators against reporting information that could perpetuate the myth that race, as we typically use it here, is a biological fact. So again, just being mindful of how we interpret these findings and what could truly be going on. So in light of this, we then think about, well, what could be driving these factors, right? So this is not new information. We've known that there are disparities in living donor kidney transplant for as long as we've been collecting data about it. So what, could be happening here? A few years ago in 2012, we published a paper where we essentially wanted to document what all of the reported barriers were to living kidney donation within the published literature. We used as a basis for this the social ecological model, which is a major model that we use in public health. And essentially, what we know is that many of the same barriers that potential living kidney donors who are African American or Black, Hispanic, and other groups typically report experiencing are many of the exact same factors that are driving disparities in other chronic illnesses, to be frank. Also, we know that these factors are not functioning within a bubble. We cannot say that if we develop interventions that solely target individual patient factors or individual family factors, that we should then automatically see changes. Because as you can see reflected on the slide, there are multiple factors that are all happening at the same time at multiple levels of influence, and they interact with each other. So for example, yes, if we focus on the potential recipient or potential donor level, we know there are differences in clinical suitability because there are differences in chronic disease burden, which means that for some groups, including Black and African Americans, it's harder to find living donors who are clinically suitable within families and close social networks if we have many of the same shared risk factors and many of the same experiences of disease. We also know that there are concerns. People want to know what happens to living donors long term after this surgery. So, for example, we've experienced people who are considering whether or not to pursue a living donor kidney transplant or whether or not to even talk about it with their family members. And one of the first things that they say, in particular among the Black and African American community, is, if I ask my son to donate to me, even if we are able to convince them that transplant is the best option for them, the first question they say will be, will this make my son end up on dialysis just like me? Will this make my brother on dialysis just like me? And if it will, then many times people are not willing to move forward with that conversation. Or if we are not able to convince them that the best available evidence really applies to that particular group, then they're also concerned. So thinking about informed consent, thinking about things like, some of the recent projections about who is most at risk for graft failure or rejection, or even thinking about, the things like long-term expenses related to the immunosuppressant drugs for transplant recipients. So here in the US, Medicare is a primary payer for end-stage kidney disease. However, if you receive a transplant, and if you do not otherwise qualify for Medicare, typically being age 65 or older, your eligibility for Medicare ends 3 years after the transplant, which makes absolutely no sense. Because as we know, we often see around that 5-year mark, 10-year mark, we often start to see graft failure rates. So it doesn't make sense to then end coverage for this life-saving treatment. But we also know that things happen in terms of the individual encounters that people have with their providers in the healthcare system. I know Dr. Waterman is coming later today, but we think about things like a communication and education about transplant, the timing of it, the quality of it. How are those conversations influencing what happens in terms of moving forward? And even when people present, including both potential donors and potential recipients, there are many barriers that people often face while trying to get through the evaluation process. And so here in the US, the experience, even for people who make it to the door of a transplant center and attempt to start the evaluation process, often there are very low rates in terms of who completes that evaluation process. And over the last few years, I've been investigating some of the reasons why. And part of the reason is because it is a very convoluted process. Many times, both the transplant coordinators and also the potential donors or recipients themselves have no idea where people are in the process. There are lots of lapses in communication. There are lots of things that can cause confusion. And to be frank, many times this process can be dragged out much longer than it has to be. For some people, this process could last for a month. For others, it may take up to 1 year to get through this process. So, how does that influence what eventually happens as well? And so, thinking about, again, all of these factors and how they play a role. Also, as I mentioned earlier, this is not new information, which means that there have been very smart people who've also been working on this topic for a very long time. And we have seen, some promising evidence, even if it's just at the center level or local level, for some of the different trials and programs that have been tried. In particular, we know that there has been a very heavy emphasis on education targeting donors and, potential donors and patients. So this includes home, community, and clinic-based programs. But we now also see an increased initiatives to extend this to social networks using social media, for example, to identify living donors. What we don't often talk about is the fact that we know that there are major cultural differences in terms of who is willing to share their medical information with the broader public. Typically, that is not something that is as widely acceptable within the Black African American community and Hispanic community as it is among the non-Hispanic white community. And that also has implications. So if our focus is on trying to convince patients to then share their experiences with strangers in hopes that people will show up, and if patients have reservations about using that, then there's also, a potential to help widen the disparities if that's something that is truly helpful for only a few groups. But then again, as our prior speaker said, we know we need to have culturally appropriate and culturally sensitive education and behavioral programs. Communication matters. Trustworthiness matters. So relationship building between providers and others with potential families, with potential donors, with potential patients, with actual patients matter in terms of whether or not people are willing to listen, to trust the information that's being provided to them, and to move forward with what is a very complex process, to be quite frank, especially for patients who are already trying to stay alive. Trying to stay alive on dialysis while also trying to maintain your life as a human being is complex within itself. And now the added burden of trying to identify a donor and trying to get through this evaluation process, that's a lot. And we need to be mindful of that. And we need to be able to provide more support for our patients, for our potential donors, outside of just what they encounter within transplant centers. We also need to help galvanize communities. We need to help galvanize the people who they interact with on a day-to-day basis to make this something that the general public knows about, is aware about, and is ready and activated to help our patients and help our potential donors. And so, this slide just talks about also other initiatives we know targeting the healthcare system, and then also the general population and trying to alleviate the chronic disease burden. We also know here in the US, there's been multiple federal and state pieces of legislation to support living donation in general. We know that most of this is focused on protected time away from work, or, for example, tax benefits. We now have a national program to provide some reimbursement for potential donors, for example, costs that they would not otherwise incur and that are not being covered by insurance. And so we know that this has happened. And I believe at last count, every single state has at least one piece of legislation that has been designed to support living donation. And so one of the things that we did a couple of years ago is really try to investigate, well, collectively, have we made any difference in these existing disparities in living donor kidney transplantation in the US? And so, we published our findings in 2018 in JAMA. And what we essentially found was that not only have we not made improvements in the disparity, we were, initially hypothesizing that worst case, they would remain the same. And I know that this is a busy slide, but I encourage you to read the broader paper. But I use this version of the slide so that you can see that we adjusted for several factors, including several confounders or healthcare system factors or SES data that was available at the neighborhood level and other factors. And here in panel D is the fully adjusted model. And so, the 1.0, the line is our reference group, non-Hispanic whites. And if a group or in particular, a point estimate is above this line, we know that that particular group at that particular time period experienced essentially better access to a transplant. And we also accounted for competing risks, is what we call them in epidemiology. So we accounted for the fact that we know that there are also differences by race and ethnicity in terms of who receives a deceased donor kidney transplant and who dies while on the waiting list. And even after accounting for all of these things, we essentially saw that for Black, African American, and Hispanic patients, the disparities actually got worse over time, unfortunately. So as you can see, these point estimates are moving further away from the reference line, closer to zero. And what we found is that essentially for the Asian American population, it got, essentially a little worse, but also sort of remained the same. And so what it says to us is that we need to think about ways to scale up the programs that we see at the center level that are potentially effective, that could be programs that could be beneficial in other centers. We need to think about ways that we can get sustained funding at the national level to roll up these factors, to tailor them at the community level. We know that not every single program will work as is in every single population or every single clinic in actual clinical practice. And so that requires resources. That requires relationship building. That requires a long-term commitment to sustain changes. And that needs to happen at the national level. And so, as you know, we're also in the middle of a pandemic, right? So we already had these existing issues and then COVID hit, right? And so now, not only are our patients dealing with the fact that they're trying to stay alive, trying to identify a potential donor, trying to get through the evaluation process, but now COVID hits. And now staying alive has absolutely become the priority for all of us, right? But in particular for patients who are already very sick. We also know at the very beginning of this pandemic, many of the transplant centers here shut down their transplant programs and other, non-urgent, non-critical surgeries because everyone was trying to figure out how to best deal with this COVID-19 pandemic while staying alive, while not causing further harm to patients. And that's sort of where we still are now. So one of my nephrology colleagues and I, Dr. Deidre Cruz, published a perspective recently in JASN, where we talked about this idea of the nexus of dealing with COVID-19, dealing with overt acts of racism that are also very pervasive here in the United States, and people are aware of it worldwide, and also these existing racial disparities in kidney disease. And this is really trying to galvanize the kidney community and professionals to help to come together and really provide the types of support that our patients really need in this time, and at all times, to be quite frank, but in particular now. And so as you can see here in the box highlighted in red, there are many multiple consequences going on. For example, we know that the Black and African American community here has been one of the hardest hit in terms of the number of deaths, in terms of the number of severe hospitalizations, in terms of risk of transmission. People are dealing with that. People are dealing with grief. People are dealing with being socially isolated. So we think about older adults and others who are essentially just staying at home now. People are not seeing their family members in person. People are worried. I am worried. I have had multiple family members who have been impacted by COVID-19. I have had multiple family members who have died due to COVID-19. We are all dealing with this, and we're not all dealing with this across the board in the same manner. And we have to think about what that means. We also have to think about the fact that many communities were already food insecure before this pandemic. And now many families are devastated by this. If people are being laid off from work or are not consistently working, they then don't have access to food. We have not received appropriate benefits here in terms of making sure that people are able to meet their day-to-day needs. So thinking about food scarcity, thinking about worries about loss of employment, or thinking about the fact that many of the so-called essential workers, even outside of the healthcare encounter, including people who work at our grocery stores, including people who drive our buses and taxi systems, are disproportionately Black, African American, and Hispanic. So what does that mean if we're not providing appropriate protection for people? It means that they are at higher risk of transmitting these illnesses and also giving it to their families. So if we have patients who are living in multi-generational homes, and even if they aren't leaving the house, but if they have relatives who have to go out and work to stay alive and are coming back into the homes, what does that mean? And then thinking about the fact that we've really translated our care to healthcare, telecare, really across the board when appropriate here. So think about things like people who don't have a steady access to the internet. Thinking about things like people who are so afraid of leaving their homes or so afraid of coming to the hospitals that then they now are essentially allowing their existing chronic illnesses to get worse because they aren't receiving appropriate care. So we have to think about, really what all of this means in terms of now still being able to identify living donors and still be able to get through the evaluation process. We also have to think about structural racism and what that means in all of our countries. We have to think about how these systems of how neighborhoods were formed, how educational, in particular, public education systems are funded, how, these policy decisions, thinking about employment and who makes a livable wage, who doesn't. We have to think about things like the media and how certain groups are portrayed. And we have to think about criminal justice, essentially, and how these reinforce discriminatory beliefs. As our prior speaker said, trust is very important. If people feel discriminated against, or as many people often tell us, I'm afraid to sign up to be a donor because I'm afraid that if something happens to me, the hospital and the doctors won't do all they can to save me. And so if that's what is in the forefront of people's minds, then we know trust is an important thing that we have to build. And so, let's think about potential solutions just in the last couple of minutes. And so here at the Center for Health Equity, we try to think holistically about what it takes to really promote equity in health for socially at-risk populations across the board. We do this by conducting research studies to help advance scientific knowledge. But as the initiatives that I lead are sort of focused on, we help to train the next generation of scholars. We know that many of these problems did not develop in a single generation, and it will take multiple generations to address them. We partner with patients. We partner with community leaders and community organizations and faith leaders to try and tackle these issues. And then we also actively try to promote changes in clinical practice and policy. And we think that this is needed across the board, in particular for this topic. Some of the specific projects that I focus on are really engaging actual patients, their family members, faith leaders, community members, and trying to think about what are the barriers that people are encountering as they try to get through the evaluation process, or what are the barriers at the community level, and trying to bridge the gap. There are many community members and faith leaders who, once they figure out that there's a problem, they want to help. So it's our job to help them figure out how to help. I'm also partnering with faith leaders here, in particular among African American churches in Baltimore, to help address their stated COVID-19 and racism concerns. It's important for us to also ask community members what's important to them. And so we're developing a health equity educational curriculum about lowering our risk of COVID-19 transmission. We're also working, again, holistically on trying to educate the population and trying to educate trainees. And so if you're interested, this is our email address, healthequitytraining@jhmi.edu, and our website, healthequityhub.com. And you can read more about some of our existing initiatives. But I would like to point out to you just two things. One, we have monthly research seminars, all focused on health equity, timely topics in health equity research. These are open to the public. Currently, we are doing them by Zoom. We normally do them in person, but the university is closed for in-person learning. And so we're doing it by Zoom. And so if you're interested, we're happy to add you to our email list. We also have 2 courses that are freely available on Coursera. They are MOOCs. One is called Foundations for Health Equity Research. The other is called Applications of Health Equity Research Methods for Practice and Policy. We currently have over 1,200 learners, and we believe that this will also just help to talk about and share what are some of the methods that we've learned in other topics, for example, diabetes, cardiovascular disease, cancer, and other areas, and how do we learn from each other to really tackle these issues more holistically. And so that's all that I have. But because, right now we're talking about such heavy topics, especially here in the US, I am often being asked, how do you even remain optimistic at all? How do you keep going when things seem to be getting worse, when things are, just so dire? And so I look to our civil rights leaders, including Dr. King, and this was one quote that I will leave you with. Dr. King said when he was asked, how do you keep going? How do you stay optimistic? How do you push forward? And he essentially said, while fighting for civil rights here in the US, I refuse to give up. I refuse to despair in this moment. I refuse to allow myself to fall into the dark chambers of pessimism, because I think that in any social revolution, the one thing that keeps it going is hope. And that's what, I hope to leave you with here today. The hope and the desire and the reminder that this is something we all have to commit to doing long term. We have to commit to making sure there are others coming behind us and that we leave a blueprint for them to keep fighting for our patients, for our communities, for each other. We have an obligation as human beings, and we all have an important voice, an important thing that we can do. So thank you for listening. And I think that's it.
Thank you very much, Tanyala, for this presentation, and I think these are Gorch's and your presentation have already brought up a number of issues that hopefully we will have time at the end to discuss. These are very timely, very important presentations and thoughts. And just to mention and provide a plug-in for our next session, which starts at 11:10. Just wanted to kind of give a quick advertising here about the next session of this Living Donation Week, which will be about our national action project that looks at equitable access to living donor kidney transplant for South Asian and African Caribbean and Black communities in Canada. And we struggle with many of the same issues that both Gorch and yourself, Daniela, brought up. And I think it will be quite interesting to discuss some of these topics that are essential, very heavy, very difficult. And we need to figure out some of the answers as we go, and it's very difficult conditions overall. So I just ask the team if there's any urgent question. I don't see any message, but Courtney or Matt, if there's anything from the Slido coming in.
There is one question that came in during Chandrala's presentation. I can read it out now.
Yes, okay.
How can transplant centers support patients whose cultural norms are against sharing their need for a living donor with family/friends/community in a culturally appropriate manner to enable them to access to LDKT?
Okay, so I think that you were asking how can transplant centers work with patients who are culturally concerned about this? Was that the question? I think that something happened with my question.
Yes, sorry. So patients whose cultural norms are against sharing their need for living donation with,
Gotcha.
outside their circles. Yeah.
So awesome. So that is a wonderful question. So first of all, I think that, one, that's an excellent question, but that also is something that I've had to deal with in terms of thinking about patients who are absolutely terrified to sign up to be donors because they truly are concerned. And so one of the things that I've tried to sort of do is really just kind of work to build a trusting relationship in general. And that takes time, right? So one of the things I've done is I go out to communities, I go out to churches, sometimes at night, sometimes on weekends. I, over time have helped people to sort of address topics of interest to them, even if it's not this exact topic. And I've also worked very closely with other trusted agents in those communities so that when we have difficult conversations like this, then it helps to really start the conversation. One of the things that I've learned that many patients and many family members don't quite understand is that even if they hear language like, oh, well, in general, African Americans do well on dialysis, or in general, whatever, what does that mean? And if you look at our national reports, that still means an average life expectancy of 9.5 to 10 years. It still means a reduced quality of life. And so sometimes when I reframe it in a way to remind people that doing well on one option, yeah, it's great. We're glad you're still alive, but there are real consequences to not having timely conversations about the need. The other thing is sort of so that we don't put the full burden on the patient. We've been sort of focusing on helping to activate what we call champions. So other people who are willing to learn about these topics and help to speak on behalf of patients about the broader needs for more donors and who may be willing to help share stories even if it's not that patient's direct medical experience while we're sort of working with them to feel more comfortable. And then finally, I've learned it's important to really activate the broader community itself. People know when we say cancer, people go, oh my God, that's a very serious topic because they've done an amazing job of making sure the public knows. But when we think about it, in many ways, kidney failure has a higher death rate than certain types of cancer. But people don't have that same, oh my God, reaction. And so really, again, speaking to communities to talk about, well, almost everyone in certain communities knows at least one person on dialysis. And what they don't know is that their life expectancy and quality of life have been greatly diminished. And when they find out, they often say, well, what can I do? Even if it means that they then start to approach the patients themselves. And so these are just some of the types of things that we've tried to do to try and be respectful of people's concerns, but also trying to highlight things for them that they may not truly be aware of in terms of helping them to move forward.
Well, thank you very much. I think these are questions and ideas that will need to be continued at the end, and hopefully we can have some shared understanding about these issues. In the meanwhile, we will continue with the presentations, and I will ask Dr. Amit Garg to start his presentation. And I just remind everybody, if you have questions, and I'm pretty sure there are many thoughts and questions that come to mind, please submit them to slido.com using the code of AM1A. And Dr. Garg, please start your talk.
Well, hi, good morning. Just wanted to make sure I'm getting access here. Just 1 second. Sorry. Okay. Good morning. So I really want to thank the organizers for this opportunity to participate in this excellent session and for their hosting of an entire week focusing on living donor transplant and the opportunity to speak today. In terms of being thankful, I'm also thankful that it's a great day here in London, Ontario. Today's the first day of school. Part of the back of my mind, I'm worried that kids who are at home doing homeschooling are now suddenly going to flood the internet and my bandwidth might go down. I have 3 bars right now. I think I'm okay. but if that does happen during this presentation, I'll come back on quickly. So the focus of this talk particularly is equitable access to living kidney donor transplant. I've taken the position in Ontario. As you heard, I currently have the fortune to be serving in a medical lead role for the Ontario Network, trying to work with partners to increase access to transplant living donations. So in that context, the focus is Ontario, but I'll have some general Canadian comments as well. In terms of land acknowledgement, I want to acknowledge that I'm calling from London, Ontario, which is the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, Muck, and Adano-Ronron peoples, and that's where I'm calling from. And in terms of disclosures, some of the work I've been involved with has been funded by the federal government, with strong support also from Astellas and partnership funds. So for the audience, which I suspect is mainly Canadian, but for our international delegates, here's Ontario. We have about 13 million citizens. 16,000 patients are cared for in advanced chronic kidney disease clinics, sometimes referred to as multi-care kidney clinics. Approximately 11,000 patients on dialysis. We have about 1,100 patients on the kidney transplant waiting list. And unfortunately, over the last decade, we've noticed that the living kidney donor transplant rate has been stagnant at about 220 living donor transplants per year. That's 17 per million. And so the organizations involved in improving access to kidney transplant and living donation, that Trillium Gift of Life and Ontario Renal Network, thought something should be done about this, and particularly to try to improve the status quo. And really, we want to see an annual increase in the rate of living kidney donor transplants in Ontario. The stagnation in Ontario is also common across Canada, and it's not specific to Canada. It's also occurring in many countries. And so we have a strategy right now that we're enacting. It's a quality improvement intervention to enable access to kidney transplant and living kidney donation in patients with chronic kidney disease, ENACT LKD. And in terms of the evaluation of the strategy, it's a 2-arm parallel group, open label, registry-based, cluster randomized clinical trial. And so to orientate you again, I mentioned the number of people with advanced chronic kidney disease or who are receiving dialysis in Ontario, and approximately 10,000 have no recorded contraindication to kidney transplantation. When we look at the large healthcare data sources, we don't have any specific information if they have a correctable cardiac disease, those types of things, but we have some, possible absolute contraindications, like they're on home oxygen, or perhaps they're in a nursing home, or they have a profile where no one in Ontario has ever received a transplant. And so when you apply those exclusions, we have about approximately 10,000 people. And so in terms of our strategy, we randomly allocated half the CKD programs. The care for these patients is organized across 26, now 27 CKD programs. London is one program, Hamilton is another program, etc. To receive usual care, this quality improvement intervention, which is a multi-component strategy. The intervention began in November 2017. We originally planned to follow up to March 2021, which would be a 3.5-year period, but now that's been prolonged because of the COVID pandemic, where for approximately at least 3 months, we had very limited kidney transplant activity in the province. The focus of the intervention is to increase the rate of key steps completed towards receiving a kidney transplant. We've done a lot of work over the last several years trying to improve our data sources and quality of the data to track these things. So we want to see if this intervention increases the number of patients referred to a transplant center for evaluation. And just in terms of context, unlike other countries, particularly the US, here in Canada, most of the workup package is completed by the CKD program, and a complete package is then sent on to the transplant center, unlike other jurisdictions where someone who's interested in transplant gets referred to a transplant center and the package begins. So referred to a transplant center for evaluation. At least one living donor candidate contacts a transplant center for an intended recipient and completes our initial psychosocial questionnaire. A patient is added to the deceased donor transplant list, and a patient receives a kidney transplant. either from a living or deceased donor. We acknowledge the likelihood of increasing deceased donor transplant is probably pretty limited, given the median wait time in Ontario for deceased donor transplant is about 4 years. And so really the focus is living donor transplants. And the historic information pre-2017 is not perfect, but for what it is, it suggests that there are about 22 steps per 100 patient time years completed historically. So if that continues in the usual care group, we would have 80% statistical power to detect 12 more steps. So if the rate increased by 12 more steps, we'd be able to detect it. This intervention has required a number of considerations, which I won't discuss today. And just to give you now some information on the multi-component strategy, which will be germane to when we now try to potentially tailor it to addressing disparities. There are different components of it that are led by different people in the province. I want to acknowledge Dr. Seychelles Johanna, who's provided expertise in quality improvement, Dr. Kyla Naylor in data analytics, and Ms. Sue McKenzie is a transplant recipient who's developed a pretty profound transplant ambassador program, and Dr. Esteban Mutsi, who's provided leadership in the educational aspects of this strategy. And the strategy really has 4 main components. We have local quality improvement teams, which we've enabled, that has key representations from quality improvement experts and leadership, and also patients and providers. Administrative support that's provided centrally from the province, at least 3 full-time FTE are supporting the entire strategy. We have tailored education resources for staff, patients, and living kidney donor candidates. There's a robust transplant ambassador program, as I mentioned, to support where there's support from prior kidney transplant recipients and living donors who can interact now with people who are in their shoes but are going through the process. And also there's accountability, there's program level reports and oversight by program leaders. Dr. Purnell alluded to this, but when we think about health, in terms of the World Health Organization and the dimensions of quality care, one thing we're focused on being effective. And one of the realities of doing evaluations, rigorous evaluations like clinical trials, is you often only have statistical power to look at the overall effect. And so we're looking overall, is this strategy effective? But the focus today is also, is anything we do to improve access equitable? That is, delivering healthcare which does not vary in quality because of personal characteristics such as gender, race, ethnicity, geographical location, or socioeconomic status. And so now let's look at this entire initiative and or future initiatives that we want to launch in Ontario and Canada from that lens. So how can current and future iterations of the strategy reduce barriers which result in equitable access? That's one of the questions I think we all, as people who practice in Ontario, are thinking about. And through initiatives like the one today, we can work together to develop our strategies to address this. And Dr. Purnell also had this nice slide where she described different levels of where these barriers occur. This is not from the lens of disparities, but you can easily start applying it. But when you think about access to transplant, the barriers are at the patient level, the donor level, the healthcare provider level, and the healthcare system level. And for patients, it's knowledge, supports, motivation, logistics, communication. And when you start putting the lens now of equity, it's also trust, as you heard from today from Dr. Radwana, about cultural appropriate support and knowledge, etc., and even communicating appropriately. There's religious context you heard as well. And for the donor candidates, there's similar types of barriers: awareness, knowledge, communication, logistics, cost. Healthcare providers have challenges around the time they have, the records they keep, the accountability they may have to the entire system, and their knowledge. And from a healthcare system perspective, we have considerations around funding, coordination, and accountability. And so which disparities could we think about? So there can be rich work done in Ontario, Canada, and worldwide, focused on understanding these disparities by interacting with patients in patient-oriented studies, et cetera. From a system level, if we want to do something simple, we do have data on these characteristics. And I'm going to give a caveat to that in a moment, but there are, for example, information in which we've used in several prior studies, not only in this space, but in many other spaces around geography, both as a crow's flies, or if you even want to calculate by road distance, how close people are to renal programs, to transplant centers, et cetera. Socioeconomic status, we have information at the neighborhood level. So income quintile, marginalization indexes, ethnic concentration, et cetera. These are some of the characteristics we have there. We do have a sex as organized, as described on the provincial health card. We do have some race information. Ontario Renal Network in the Ontario Renal Reporting System does collect self-reported race. Some of it is absent. And also there is information on First Nation status, which is managed by the Chiefs of Ontario, where there's a steward that can help support this data. The data that I'm referring to here is held at the Institute for Clinical Evaluative Sciences. Some of you may be familiar with it. It has about 80 or 90 linked data sets. Disparities we're not talking about today are things like age, obesity, et cetera. And this is not a new topic. I was one of a few Canadians who participated in this US Consensus Conference in June 2014, where they were trying to advance leading practices in living kidney donation. And this was led by several colleagues, including Jim Rodrigue, who's a prominent person in this space. And in that conference, one of the reports that came out was overcoming disparities in live kidney donation in the US. And if you look at their 4 key recommendations, they apply again today. Remove financial disincentives to living kidney donation. Implement culturally tailored, community-based living kidney donor transplant, living kidney donor educational programming at multiple stages of the transplant referral process. And I see this being encompassing everything from public awareness. We have like public education awareness around deceased donor transplantation, but really we still lack a really cohesive, prominent approach to living kidney donor transplant awareness. There's cultural safety training and other training for health professionals that operate in these spaces. There's education towards patients and their families, et cetera. It's all aspects of this thing, and including faith-based considerations. They also recommended engaging a transplant liaison who had this expertise in community nephrology practice and dialysis clinics, and develop a research strategy to better understand the disparities and address them. Dr. Purnell alluded to this, and I just wanted to give this also some attention. We have to be very careful when we use these labels. When we talk about any of these labels I just described, they're so, it's hard to put like sometimes words to something that is so complex, several of these issues. And there's a dialogue occurring about many of these things in society today. For example, even when any of us do research now, we almost all applications now have to describe sex, gender-based analyses. And if you go through that training, like I and several has done, it's quite complex. Are you talking about like biological considerations? Are you talking about socially constructed roles, et cetera? And in terms of race, there's a dialogue going on, even like very fundamental things like how we assess kidney function. This estimating glomerular filtration rate, which has a Black race term within it, is now coming into question about what the appropriateness of that is. There are very important considerations around First Nations and Indigenous peoples in Canada and how that intersects with what we're discussing today. And also a lot of these things aren't in isolation. When we talk about geography, that also can overlap with, First Nation status. And when you talk about several other of these things, they overlap. So when I present the next few slides, I'm overly simplifying many of the deep concepts that are here. So let's first focus on geography. So what do we know in Canada? There's been very nice leadership work done by colleagues in Alberta. This is Cello Tonelli and John Gill and others' work, where they first looked at the US system, and they, at least in one prominent study, they said remote or rural access versus urban residence was not associated with a time to receive a living kidney donor transplant. Canada is a much bigger country, larger distance to travel, and when we look at the Canadian data that they've also published, that distance was associated with a lower chance of receiving a living kidney donor transplant in non-white Canadian children. Dr. Samuels published that, but not associated with the likelihood of receiving a transplant when both living and deceased donor transplant were combined. We heard in Dr. Purnell's talk about the challenges that COVID is presenting, but now when we think about solutions provincially, the teleconsults that we've now been used to doing is actually creating an opportunity, isn't it? Particularly when it comes to geography. I'm originally born and raised in Sudbury, and when you go travel in my current role to our northern communities, one of the difficulties they have is having their patients and families come down south for their evaluations and staying here, both pre-donation and post-donation. And I personally have now become much more comfortable as a nephrologist who does living kidney donor evaluations, delivering those through telemedicine. I don't like when I don't see the person, so that's very important to me. But I've now gotten very used to this, and so I see this now extending in the coming years to evaluating living kidney donors in places who have geographical barriers. Our social worker also feels comfortable doing this. When I talk to our surgeons, they are less comfortable. They still want to see the patient beforehand, but many patients, unless they have intra-abdominal considerations, can be kept later in their evaluation phase to see the surgeon. So that's also still an opportunity here. So overall, I've been pleasantly surprised at how COVID has made us now do these evaluations online for telemedicine, and that I think is working really well. And I see that there's an opportunity there to extend that, and including intended recipient evaluations as well, in many aspects. The other thing I wanted to highlight now in terms of accountability, if we're trying to address disparities, I talked about geography, but this could apply to any disparity. This is an example of a report that goes to each chronic kidney disease program approximately every 4 months. So now, unlike before, we give a program reports on how well they're doing in helping their patients access kidney transplant. We give them things like, how many preemptive kidney transplants have you done in this quarter? So to orientate you, here are some measures: living donor transplants, deceased donor transplants, total kidney transplants. And I don't have another slide, but we also look at how much education they receive, et cetera, et cetera. And we say per quarter, here are the quarters, how have you been done in this regard? So all the programs are starting to receive that, and have been receiving it for several years. But what you could do, and this is the opportunity perhaps for the discussion period, is you could start now presenting some of the disparities in these reports. This would be not something to be done lightly, but you could show like how people of a certain, some disparity characteristic, acknowledging all the limitations of these labels, and have access to transplant. Now, this has been done in other, and is being done in other settings. This is some nice work done by Dr. Rachel Pasner, who's done a lot of leading work in access to kidney transplant. And they have an A.C.T.I.O.N trial going on, allocation system changes for equity in kidney transplant, which has many components, of which one of the components is a dialysis facility-based performance feedback report. When I was looking at this online, like the reports now have like some racial information on it. So the unit doesn't only see the results overall, but see it now based on how patients of certain race in their units are doing. And that's something we could consider in the Ontario context in our reports. Also, to address these disparities, I think extra emphasis on transplant center outreach, education, and support is particularly important. This has to happen all the time, but particularly important for sites that are geographically far away. And then also the reduction in financial risk we've heard, and particularly for people from far away, travel and accommodation costs are a consideration. And so that kind of gets into the next stage of the socioeconomic. We know there's a health wealth gradient in many aspects of medicine, and wouldn't surprise you, I think, to find that it occurs also in this context here, both in Canada and abroad. And reducing, we can't address this entirely, but reducing the costs incurred by going through the process is something we can do. And then so just to orientate you, there's costs borne by the recipient and the donor. When we look at the donor's costs, the donor candidate's costs, they have to go through many aspects of a process, don't they? Where they get evaluated, go through testing, come down to the transplant center, ultimately donate or off for a few days, back to full function in 6 weeks. And so they incur costs of travel and accommodation, lost income, dependent care, some post-discharge medication, and support persons. So over the last, 15 years, we've been working in this space trying to quantify these costs and advocating for sound reimbursement programs. And when we quantified some of these costs in the Canadian setting, 15% of donors were incurring over $8,000 of Canadian expenses. And donors that did incur higher expenses, at least post-donation, were demonstrating higher anxiety and lower quality of life. The development of reimbursement programs that are present in Ontario, like the preload program from TGLN and other programs across the country, have certainly been a welcome addition. When we've looked at now the gap that still some patients face, even when those programs exist, there is still a gap. So there's an opportunity further to tweak these programs to really make sure donors are not disadvantaged to the process, and similarly, recipients are not disadvantaged to the process and the cost they incur. This will not by any means address all the disparity when it comes to health and wealth, but certainly is one positive step forward. When we look at sex/gender, my interpretation of the literature is generally the rates of living kidney donor transplants are similar in men and women, but the chance of becoming a living kidney donor is much higher in women versus men, in mothers compared to fathers, and in wives compared to husbands. The considerations in this space is that treated kidney failure is more common in men versus women. Perhaps some of the contraindications to donation are more prominent in men versus women, but that's not always consistent. As someone who evaluates living donors, often when we see benign asymptomatic microscopic hematuria, we see that more commonly in women, and that also sometimes complicates the evaluation process. Female recipients may be sensitized from prior pregnancies, and there's a body of literature to support that kidney pair donation has helped reduce that issue to some degree in terms of access. There are, of course, social and cultural reasons that underpin all this, and even possibly the amount of altruism that different people have. There are employment and financial considerations for donors. So if there is a large financial loss from an income earner, that could possibly be playing a role in this space. Now, you heard from Dr. Purnell this concept also, like who's willing to put their health out there in their request for living donor. And in fact, there is some literature in this space that suggests that although we see some differences in who becomes a living donor, in terms of men and women, there's, again, literature suggests that women are more likely to be more sharing of their health considerations and need compared to men. Also, I'm mindful that when we talk about living donation and we're trying to increase living donation, we're part of a system where we're also subjecting donors to risk. And There will be some donors who have poor outcomes post-donation. That will happen. We want those to be minimal. When they do occur, we want to make sure we're practicing in a system where we were very responsible around this entire practice, so that when we do have these events, at the end of the day, we feel still we've been doing the right thing as people enabling this. And so some of the risks, particularly to women, as you know, are pregnancy-related risks if they donate early. There's also some information on psychosocial risks post-donation, fatigue and mental health related quality of life that suggests, based on the labels again of men and women in those studies, that there was differences between the two groups. So what are the solutions here? This is not comprehensive by any means, but should our education materials be representative? In preparation of this talk, started looking at all the materials we created for the Ontario setting, and the ones that we curated and present on our government websites. And how many times are different types of men and women being presented even visually on these materials? That got me thinking. I started looking at that quite carefully. You could create specific education materials that address this issue if we felt that that was important and specifically focused on this. I think there's a real opportunity for all these disparities to engage social work much more in CKD programs. In truth, my perception has been social work in our programs, not on the transplant side, on the CKD programs, haven't been as involved in much in this space as they could be. It's a part because they also have so many competing demands. But some of these working with families and discussing and addressing these disparities, I feel they have a very important role to play. And that's an opportunity, I think. And again, financial support may help some of the considerations on employment barriers. And so here's just an example of some of the information materials. I talk about education materials, but even when we talk about support, like our Transplant Ambassador program, that's nicely patient-led. When I look at the materials there, like, is it presenting all these disparities in the right way? So we have representative individuals from all aspects so that people can relate to it. I knew race was being discussed in the other two talks, so I don't really spend much time on this, but I know there are many active interventions to address racial barriers in living kidney donor transplant. I'm most aware of several ongoing initiatives in the US, including web modules and communication and financial barriers that are ethnic-centric to address disparities. The one published report that many of us are very familiar with is this nice study by Rachel Pasner. Was published in JASN in 2016. It's called the Radiant Trial. And the motivation here was, when I talked to her, is that in Georgia, it had some of the lowest rates of transplant in the United States. And so there was a strong impetus to want to do something. The rainbow part of the slide here presents the different aspects of their multi-component strategy. This ran in 134 dialysis centers in Georgia. And baseline, about 11% of patients were referred for transplant evaluation the year after dialysis initiation. And the intervention resulted in a 6% increase in this referral after the start. And it seemed to be differentially better in reducing disparities. This is one of the main goals, to reduce disparities in access amongst Black compared to white patients. But again, you again heard from Dr. Purnell, when you have intended recipients ask when their younger family members, including their children, are going to be accessing transplant, and particularly becoming living kidney donors, there is this tension because we know that the risks potentially are not also the same across all different ethnic groups. Again, same with all the caveats that ethnic group is a very blanket statement. It has to be much more precise than that. Is it, for example, in in Black Americans is related to APOL, A1, et cetera. So all that notwithstanding, this is a study we did as a part of our work in doing the KDIGO International Clinical Practice Guidelines on living kidney donation. And we tried to project the risk to the living donor candidate in terms of their development of end-stage kidney disease. And there's several now other calculators that do this. This is one example of this. And you see that the estimates show, unfortunately, that, again, using these labels of black and white in the US data, young Black men particularly, in terms of living donors, had the highest absolute lifetime chance projected of end-stage renal disease. So not everyone might have the same safety profiles around becoming a donor, and that complicates this entire situation. The other area, finally, in terms of race that we in Canada need to address is the issues around Indigenous peoples and First Nations, Inuit, and Métis peoples and their access to kidney transplantation. There's been some nice work, again, done by colleagues in Alberta, Brenda Hemmelgarn and Cheltenham, that show quite clearly that there's less access to kidney transplantation amongst First Nations individuals in Canada. There actually is a large initiative being undertaken in BC, being led by Jag Gill, to try to address some of these concerns in a federal government-funded study. Whenever you work in this space, you have to, the members have to all undertake appropriate training and sensitivity and cultural awareness. There's issues, something called OCAP, ownership, possession, access, and control considerations around the data and who owns it. And so in Ontario, we've been having a dialogue with the Chiefs of Ontario now for 2 years. And when I say we, this includes a partnership of several people, including patients of First Nations background who have kidney disease, administrators, et cetera, trying to advance a strategy where we can use the data source we have to give better insight into the disparities faced, and then ideally develop solutions to address it. And again, we have this consideration then about the risks. Whenever we evaluate people with kidney failure who have a First Nations background, and then they have living donors come forward, the study from Manitoba by Dr. Leroy Storsley and colleagues does catch our attention, where 18 years after donation, the risks of hypertension and diabetes in First Nation donors was substantially higher than Caucasian donors. Again, this issue, this complex issue where the risks to the donors also may differ by race, ethnicity, and how do we account for that in this consideration? We're trying to enable and enhance access to living kidney donor transplant. So I think I'm out of time, but I just wanted to raise some of the considerations around how we want to take, I think, a full system level consideration and approach that future iterations and current iterations of any strategies to improve access in Ontario or Canada address the barriers which result in equitable access. And with this, hopefully, the bottom line is we'll help more of our patients receive living kidney donor transplants and the benefits those entail. Thank you very much.
Thank you very much, Amit, for this presentation. And I think it, again, provided a lot of information, a lot of relevant information to the discussions, both before and what's coming. And I just wanted to, again, provide some plug-in for the upcoming sessions of this Living Donation Week. As all of the previous talks presented and illustrated, this is a very complex area, very difficult tasks ahead of us. And this is why the Center for Living Organ Donation at UHN dedicated a whole week for these events. We will have actually a specific session designed and dedicated to Indigenous issues that is coming up Friday morning. And many of the initiatives you mentioned and others will be discussed there. And I think it is quite essential for various reasons. And we also have another session coming up towards the end of the week, Thursday, about where we include the perspectives of various faith communities, because as both Gertch and Tanyala brought that up, it is essential for many of the communities that experience different barriers, and involving faith communities and faith leaders may be one way to potentially reduce the barriers. And certainly there are successful and efficient initiatives within several faith communities that are able to address some of the issues brought up. And finally, just the final plug-in for the upcoming session at 11:10 today, which will discuss our ongoing government-based or government-funded initiative to assess barriers and reduce barriers both in South Asian and the African American and Black communities in Canada. And that might be something that both can inform some of the audience that are present today, and also can learn from many of the thoughts of the current speakers. So hopefully that will be another session that can bring together a lot of thoughts. Before going back, I know it's a bit late, but there might be a comment that was sent in. Courtney, is that something that you want to read it now?
Sure, yeah, it was just a comment for Dr. Purnell. So thank you very much, Dr. Purnell, for that empowering talk. I really appreciated how you highlighted the impacts of systemic racism and the COVID-19 pandemic on access to healthcare and kidney transplant specifically.
Oh, wow. Thank you. I genuinely appreciate all of your support, all of your help. As I stated previously, this is a difficult time for all of us. I think if we learn nothing else, we have to learn that it's important to call out the truth at all times, and to speak our truth, and to listen when others share their truths, so that we can really build a better world. So thank you for your kind comments.
Yeah, thank you very much. So we will be moving on. If you have additional comments and questions, please submit through slido.com using the code AM1A. And I'm pretty sure that the next speaker will also motivate a lot of thoughts. As you remember from the initial introduction, the next and last speaker in this session will be Dr. Amy Waterman from UCLA, who will also bring a systemic perspective, but something that can be combined on an individual action level. Thank you very much for your time, Amy, please.
Thank you. Thank you. Can you hear me okay?
Yes.
Great. I am so happy to be here. The sun is rising in Los Angeles. I'm unable to leave the home due to fires, so you can't go outside, and inside due to COVID. So I'm happy to be sharing with the community. So let me make sure I can drive. All right, great. I also wanted to, 1 second, sorry. If you could back it up, Matt, 1 second. So I just want to also say that I'm here representing UCLA and the Terasaki Research Institute. And I will never be touching these people again. That's what I think, but we are still working for the good of this cause. Okay, so we know living donor transplant rates are declining in Canada. We're concerned that they're going to decline after COVID in the US. That data is still coming in. But we also know that the disparities continue to be true, no matter what we're all doing, okay? And I have had the honor of working with Dr. Mushi for years. I've also had the honor of speaking at the center, and I really admire what's happening. And I think no matter who's speaking, whether it's me or other researchers in the US or anywhere, it feels like we're all approaching this challenge of how do we support and increase living donation from a multi-level perspective. So I think about this like an onion. You have the patient in the center. I need a kidney. I would love to live longer. I would be open potentially to a living donor. But then you have these series of slices of the onion, the potential living donors, the support network, the family and friends who are supporting both of those, the providers, the organization, and the community. And I think what Tangela really highlighted is the external parts of this onion have just changed with COVID. So we were in a system that was difficult before, but now we have community challenges that have risen and been made worse. So the other piece I want to say, though, that I think is even more sensitive, and I've started to think about this in a different way, is that I think the onion's two parts. I think you've got the onion for the patient, but I think you have the same multi-level challenges for the donor. And often we say, well, the patient just needs to handle what they need to do on their side, and then the donor will just come forward, right? But as we're seeing, potential living donors are in our community, are facing every level of challenge, are making different decisions. And the work on living donors is potentially a little less advanced in some different ways, because we have a lot more ability to talk to the patient in our transplant centers than the donors. So if we say, okay, how do we increase the number of living donors, especially from diverse communities? It's a great question. People have been studying it. And I want to say we could possibly do it in two ways, okay? So how do we find more potential donors out of transplant centers? So this is important. We need to extend our reach. We need to be changing messaging, public health messaging, culturally tailored messaging, all of these things I know that different groups are doing. And that's been exciting. One of the initiatives I spoke at the center last year on was the Living Donation Storytelling Project, which is available to explore livingdonation.org. This is a program where you can meet people who look like you, who have gone through this, who have information to impart. So it's about like making living donation normalized. That's people do it, and people who look normal, not a perfectly made up person, right? But just an average good person who is in the world. But I want to shift now for this talk to talk about the second part. How do we help more potential donors who begin evaluation actually donate? And this is a really interesting thing, because these people are all initially expressing interest in this, and there's variability. So I run the Transplant Research and Education Center at UCLA, and the purpose of this center is to understand and overcome the critical modifiable barriers affecting transplant rates and outcomes. And the key word that I love is modifiable. One of the pieces that I feel when we talk about reducing disparities in access is often we say, well, they're racial disparities or they're socioeconomic disparities. And now we know that. So where I'm looking is, where can we move the needle? What is it that we can do something about? How do we not give up, right, as a community? And I want to talk about a model of a way to think about this that I started doing in 2013 with a paper that I published. So we looked at the other half of the onion, the patients. So we measured patients walking in the door who were white and African American, because I was living in St. Louis at the time, and 700 people. And then we followed them till they were finished. And we asked them questions about all sorts of things. Things that were fixed or less modifiable, like demographics and comprehensiveness of healthcare coverage. But then as you move to the middle and the end, you start to see some of the other things. There could be interventions that are planned, ways of interacting, overcoming practical barriers that could make a difference. And maybe there's something that we can do that would matter. And what we found when we did this study, you can go and read the paper if you'd like, but the piece to me that was exciting at the time that we found that people who walked in the door on day one more ready to pursue living donation and with better knowledge ultimately became auto living donor transplant. They came in more prepared, they came in more knowledgeable. Now, this launched 1,000 ships, and one of them Emmett just talked about ENACT, where we really said, okay, we need to prepare people better, right? So they're walking in the door, and Dr. Mucci and I have been working together in terms of the ENACT intervention that you were talking about to make sure through education into the Transplant Ambassadors Program that people are having what they need so when they begin, in hopes that this will increase living donations. So I wasn't the cause of the ENACT intervention. I was just one of the papers used to design it, but I want to acknowledge everything that's happening in Ontario, because to have a multi-level intervention that's touching many different things that includes this is really exciting. So what affects potential donors' behavior? We play the same game of less and more. So yes, the same kind of less, the things that we can't do a lot about, that we talk a lot about, are socio-demographic factors, medical contraindications, who they're donating to. It's interesting, spirituality, maybe you can change spirituality. We can talk about that. And it's interesting that what goes in the middle, right? So people say, can you change medical mistrust? Is it a fixed thing? Health insurance status, caregiver, access to transplantation, health literacy. And then if you move over to the more, you have, what are they doing to prepare? What is their knowledge? What actions are they taking ahead of coming to a transplant center? What costs are they incurring? So you can see, like, again, same model. We have to really carefully choose where these things fit along a continuum, but we could definitely study them. So I was able to get a grant in partnership with St. Barnabas through the National Institute on Minority Health and Health Disparities. And this has been a labor of love. It's been really hard to do because we approached this in a way that other people didn't. I also want to thank all of these different transplant centers who partnered with me to collect data, because the big issue is we do not have a lot. We need a large data set of potential living donors of various races and ethnicities so that we can watch what's happening. It's not, we can't just say 100 people went through. So what we did was we said, okay, we want to study people on many levels of things, and we want to look at their, we want to see where they are when they start, and we want to see ultimately who ends up donating, right? So we want to follow them over time. And what we found in this data set that I have now is we have 2,576 potential living donors. And this is the part to me that's exciting. These are people who came to the center for whatever reason, were touched by the cause. We have someone in need of a transplant. And at the end of the day, they either, there's probably three outcomes. They either were medically ruled out as not healthy enough to be able to donate. They themselves chose not to continue, or they donated, right? So the thing that's really interesting, if you just stop and look at this for a second, is that, wow, there are a lot of good people who came forward in these centers, and wow, few of them actually get to the finish line. So it's important to really understand whether we're part of the problem, whether there are things we can do to better support people who can't continue due to challenges that they're facing. This is where I'm looking as a modifiable factors person. So the thing I also want you to know is we worked extremely hard to capture potential donors who were the races of the United States that are common. It was really, we were so excited to have people to be able to compare and look at these kind of issues. So let me just show you some data to get you thinking. So we've been talking about these challenges. We've been feeling like, this is, we're up against, an unmovable rock here. And I'm like, let's look where we can move the rock. Let's be hopeful. That's me. I stand in hope. I actually got a mask and I had them embroider hope on the side of the mask. So I wear that around now. But the thing I want to say is, this is fascinating. Okay, who did these people, these potential living donors, come in to support? And what you can see is, first of all, everyone. They came in to support all sorts of different people. But then if you look at the larger bars that are at the top, the white bar, the Asian bar, and the black bar, you can see that the white patients were more likely to come in for a friend or an acquaintance. Then you have the blue bar. Asian individuals came in for their spouse. Black patients were more likely to come in for their parent. So that's a really interesting thing. I think we could even get more data to see, but if we're seeing that there's a pull for certain communities to come forward, what does this mean? We can talk about it afterwards. Okay, so let's talk about preparedness to donate. People spent time beforehand educating themselves about living donation. And if you look, first, let's just look down the all column. You have people who are reading brochures and websites. You can see talking to people that they trust about the risks and benefits, talking to medical professionals, and thinking through their family and work responsibilities. I'd like these numbers to be higher. It's hard that if 70% or less of the people are not doing these things, we got a lot of work to do at the center, and there could be people who discover things at the center that aren't right. You see that white patients are more likely to be doing these things. Black patients are significantly less likely. All of the circles are showing the significant differences. To go to knowledge, same thing. This is interesting. At the pre-time, we didn't want to quiz them yet. We just wanted to see their perception of their own knowledge. So we quizzed them later in the survey process. But we said, how much do you feel that you know enough about expected recovery, about risks, about tests, and about what donation-related costs that I may have? And what you can see here is they're feeling pretty good. They are scared. They know less about the costs in general, the people walking in the door of these 6 different centers. And we find that Asians feel that they know more, and Black patients feel that they know significantly less. Okay, so motivation. Why did they walk in the door? I love this. And there's many reasons why somebody wants to do something. This is interesting. First of all, the beautiful thing I want to say is that no matter what race you are, you come in because you want to help someone live longer. You want to help make someone's life better. And you want to believe that this will actually help everybody, the whole family. That's beautiful. No differences, irrespective of race. This is just why they're walking in the door. Now, the interesting thing, if you look at the bottom though, the donation will make me feel proud of myself. There's most people say, no, that's not why I'm motivated. There's a higher likelihood though of Asian and Black patients feeling good, that this makes them feel proud. And I think this is important if you're sending messages to these communities, that there is a reason that they're coming forward. It'd be fun to explore why they're feeling differently than others. The other part is spirituality. So, you know, they talk about how blood donors, people in the military, and people who are from faith-based communities or have a spirituality are more likely to come forward. We saw this in our data that, and we saw this more commonly in the non-white communities, that people from these communities, they were talked about how important religion and spirituality is important in their lives, more likely to believe in God or a universal spirit, and believe that their personal or spiritual beliefs suggest that they should be helping others. Again, a place where you guys, what we're saying about faith-based communities, I think that definitely this is a way to go in terms of intervening. All right, resistance to donation. So 10% of the donors wish their recipient would get a transplant from someone else. Just to pause on this, these are the people coming into the transplant center being enrolled into being a potential donor. So I want to be sensitive as a person who leads education efforts within a transplant center. There are people that are there that potentially are coming in due to family pressure, due to worrying, with a lot of anxiety. So it's interesting to know that 10% of the sample was there. And more likely to be, of the people who would like to pass on this opportunity, more likely to be Asian, less likely to be Black. And what we found though, that this is fascinating. So the other part is we said, okay, do you have someone important in your life that doesn't want you to donate? So this goes to social support, it goes to, you know, advocacy and in the home. We have, again, 10 to 17% of racial communities are saying, yes, I have somebody important in my life that doesn't want me to do this. So then you go to financial risks. Okay, so what we have in America are these things. We have almost 90% do have a financial impact from donating. On average, $5,000 in donation-related costs. You might lose a month of household income. 1 in 5 lack insurance to cover the costs. So we've got in the United States a big issue with financial challenges due to donation. And again, non-white donors and donors with low income and low education levels are more impacted by these. And then you add COVID on top of this. So this is where I think it's really interesting and how this all comes together. So you have, so these are the kind of common data that non-white potential donors are more likely in our sample to report basically financial stability for only 3 months, no insurance, lower incomes, and lower education. And again, that's a non-modifiable thing unless they can get a different job. That's not something for the transplant center to intervene with anyway, but this is where I think it's fascinating. So remember the question where we said potential donors reported that they wish somebody else would donate, right? 10% with variation by race. If you cross this with race and concerns about incurring donation costs and incurring loss of income over time, this is a big issue here for certain communities. And overall, almost 20% for our patients. So I think this is actually something you all can handle differently than we handle in the United States, but it's really critical because the unwilling people, the people who might drop out, are people who are facing concerns about this. And it's more common in the Asian community. Okay, so I have been collecting data for 5 years, and I've been dying to see who actually donated of all the people that we saw at the beginning. So we're beginning to explore this, but let me show you the feel of it. So who ended up donating? So, and what were their races? So this is a little different in the percentages, but of the people who came forward, we did have people who ended up donating that were of all races. And one of the things I'm asked commonly as a transplant professional is, well, you know, there's no donors who are all of these races. They face higher risk of the disease anyway. There's no one who's going to come forward. So I really feel there's a message to be made in our community that good people of all races and ethnicities donate all the time. And we see this here. Now, of each of these groups, so we have more white people donating, sure, but we have everybody. But then if you look at how of the people who started of each race, who actually finished, you see between 10 and 20% of people ended up donating depending on the different race. More females, more educated, and more financially well off, as other studies have shown. We're going to do a lot of modeling of this at a higher level, but I want to show you some of the interesting things. So, of the people who walked in the door perceiving that their knowledge about living donation was acceptable, the people with higher knowledge were more likely to donate. In terms of people who were motivated, remember we talked about, do people in their community support them in donating? People who agreed that they had people supporting them in their community were more likely to donate. Okay, remember we talked about the financial risk? The people who disagreed that the possibility of having to pay for some donation-related costs makes it hard for me to donate, and taking time off work for testing and surgery were more likely to donate. Okay, so I want to stop there to allow for dialogue about this, but the feeling to me here is we need to still look at the people who stopped because they were medically ineligible against these other two, this collapsed this, and we're going to look at this as a, in terms of regression. But I see a few key conclusions. First, 10 to 20% of potential donors of different races actually became donors. And it wasn't that the white community was more likely to have more of those people. You had this amount across all of the different racial groups. While different racial and ethnic individuals volunteer for different types of people in their family and friend communities, all came forward to help improve someone's health and life. But there's a lot of variability between racial groups and how much they know and are prepared to be a donor, how well they're supported by others in their community, the importance of spirituality as influencing motivation to donate, and their concerns about costs and impact of donation. So going back to what might move the needle. So let's think about, where do we go in? So years ago, we said education and knowledge for recipients. We're seeing the same thing for donors. Preparing and educating potential donors better is a way through that is showing differences in donation. Ensuring family and community support for donors. If that's not there, how are they going to get to the center? How are they going to face the recovery? How are they going to face the financial impact on the family if there's no support internally? And finally, how do we make sure the costs are as minimal as possible? Great. I'll take time for questions.
Thank you very much. It was an excellent talk, very relevant, timely, interesting new data. And I guess more to come there. And I think there's a lot of things to discuss. So I invite Daniela, Gorch, Amit back to the table, the virtual table that we have. It's a transatlantic table that we have, which is great to have. And we may actually try to continue this transatlantic table, because although many of you emphasize the importance of local initiative, I think it is also important for us to realize that there are some common themes here, and maybe combining the approaches and the knowledges, looking at the differences and looking at the commonalities may help the advance the needle. So I think it has been, certainly I learned a lot, and it has been an excellent experience to listen to the speakers. And we have a number of questions, and I will ask Courtney to read out the questions, and I will have some additional questions at the end if we have time, but if not, then we'll continue the discussion at a different location. And just want to point out, I keep on plugging this next session, which is on the ACT-ION project that looks at South Asian and Black patients and communities in Canada. If you have the time and interest, please log back in on a different Zoom account, and I'll let Courtney ask the questions.
Sure, thank you. So our first question here is, what is the biggest challenge in ensuring equity when it comes to living donor kidney transplantation?
So I guess maybe a quick round. So who says which one is the big one, the one shot, or the kind of we can go in the
My answer would be all of them, like the multi-level factorial nature of this challenge. I don't feel there's a silver bullet. We all want there to be. We want there to be a single powerful intervention that'll clear this all out. I think it's about honoring the fact that this needs lots of levels of intervention at the same time. And if we aren't responsible for that, I think we're just naive.
Okay, so all of them, which is E in the multiple choice question. Gorge, Daniela, what's your take?
So to sort of follow up on Amy's comment about the fact that essentially all of these barriers, are challenges that we have to address. I think from my perspective, the broader real issue at the root of all of this is convincing the broader field and convincing the general public that this is not like promoting equity is not something that should fall on the burden of the few. That's not something that just a handful of people need to be committed to doing, meaning not just a handful of researchers or not just a handful of patients or communities. This is something that we need to realize is our responsibility and obligation as human beings to ensure that we address challenges that are being systematically experienced by subpopulations. And once we truly get the general public and the general broader community to understand that there's a role that we all have to play in this, then I think that getting all of those stakeholders to the table is the only way that we can truly address all of these multi-level barriers. So I think the biggest challenge is really convincing people that this is a problem that all of us have an obligation to tackle.
Thank you. Gorge, how does that look from the UK?
Yeah, I mean, I'd agree with all of that. I guess the only thing I'd add is I think it's about saying that this should be business as usual. So if we're not doing equity, why are we here? And I guess, I think all the speakers have shown this in slightly different ways, but I think ultimately in the UK, we've always seen equity as an add-on, which, I mean, that's a failure of systems working when we see it as an add-on. And I think we've got to see this as being the foundations by which we do everything. And if we don't do that, I think we're failing in our duty.
Yeah, thank you. That's quite important. Amit, from you're kind of siding with Amy because you're putting pretty much everything in that quality improvement initiative. Do you have one favorite?
I'm not sure what a favorite, but in terms of the question, I'm still not sure what is exactly the thing that should be prioritized to be done first or given the most attention, and is it sustainable, and is it really effective? Like as someone who's called with other partners to try to minimize this concern, let's say in Ontario. Okay, so one of my challenges after I review this space is, okay, what do we do next then? What is the really thing that we should invest time, money, energy, resources into that we know is going to give us the biggest bang? That's what I see as the biggest challenge.
I guess in a reflection of that, to what Gertz mentioned about the equity as business as usual, and I think it is an interesting and perhaps a more kind of general issue, but many of the medical students who come to medicine and many of the other health professionals come through vocation to this job with the aim of helping others. And it is interesting that the healthcare system that is being formed from the people who come with those true intentions will become a system which helps, or at least inadvertently maintains some of those structural biases and inequities. So I don't know whether that speaks to education and training in the healthcare system, whether that's the structure, the funding.
Yeah, I mean, I think there's also something about how do we decolonize the curriculum. So we have, I'm sure you have the same in many countries, but a lot of our clinical case studies tend to focus on mainly white Caucasian patients. So we don't tend to think about, for example, diabetes or kidney health in the context of diversity. So I think only if we have a culturally competent curriculum are we going to produce professionals who are going to be able to deal with this in a holistic way in the future. But then that's also incumbent upon us all as professionals, because we're part of the system that's delivering the current curriculum. So we've got to call it out. And there are power structures involved in calling these things out.
I'd like to add something, if I could, on this one. So one of the things that I feel, so we're also having a transformation in healthcare right now due to COVID, where telehealth has become the way to connect. And we always talk about the challenges of it, and we're definitely in transition at UCLA, but I see there's an opportunity here from an equity standpoint, because in the past, we could not have family come to a session. You know what I mean? There's a lot of like, okay, so my mom and dad are in St. Louis and I'm in LA and I need a kidney and they're never going to come. So there's a feeling right now of using this as an opportunity to build in better care for people, and potentially also patients are exhausted, families are exhausted coming to our center for 1 or 2 days of evaluation. So telehealth also gives the ability to not only engage a larger community, but second, to have the pieces of learning and the pieces of empowerment occur in different time points without causing a burden on them. And so I'm in a place of being hopeful. I'm like, let's use this moment of destruction and recreation of care to include equity decisions in it.
Yeah. Tanyala, do you have perspective on the virtualization of care? Is that going to help or potentially broaden disparities?
I think I side with Amy on this one and trying to be optimistic, because otherwise if we lose all hope, then why even be here? But and I think that truly it depends on the players. It depends on the system, it depends on the providers and whether or not they see this as an opportunity to rectify challenges for groups of people, whether or not they even recognize what the barriers are. For example, if a barrier is, we all know that it's very exhausting for patients to have to keep coming in person. It's very hard at times for patients to start these conversations with their family members. But then we also need the other players across the board to know this, so that they can know that, okay, this is an opportunity for us to address some of these things, versus just solely focusing on what is of most importance at the time, I guess. So just the typical disease management and other things. And so I think that, it is truly an opportunity for us to, again, get everybody on board and understanding there's a role that we all should be playing, from primary care providers across the board. And once we do that, I think that we can truly maximize this experience to help to truly alleviate some of these barriers.
Just to add and also feed it back to many of the talks or many of the thoughts in the talks and before, I think it is very important to do this, whatever change it's happening to the healthcare system, to do this together with the people who are affected with it or by it, because I think in the past and currently frequently what's happening, that things are created even with the best intention without really asking and relying on people who are going to use it, and that this is potentially exceptionally or especially important for culturally or financially disadvantaged and people who may have special needs in this change, and those needs may not be addressed if you don't ask them. Before just coming back to the theme, I want to read the Slido things here, and one comment is calling attention to the Kidney Foundation of Canada, which is available in the COVID period, and they have organized webinars and information sessions for patients and partners. They also run peer support networks, and they are a tremendous help for patients who need support with kidney disease. So we did not mention the Kidney Foundation here, but clearly there are services available through them, and they are present in this field. And the other point by someone who wanted to emphasize the need for mental health support. And again, we didn't really speak too much about the role of mental health, although I think in some of the talks it was mentioned that both donation and being on dialysis or having chronic kidney disease has a major impact on mental health and well-being. And certainly that is something that needs to be focused on and supporting both recipients and donors through this journey. I guess there is a critique here that UHN may not does enough, and I just wanted to mention that the Department of Psychiatry has a transplant psychiatry section at UHN, and also there are a number of initiatives trying to help patients with chronic kidney disease who have mental health issues and support them. There is a question here, how does the different health systems affect living donation? Okay, just in the US, health system is not free. Do less people donate because they have to pay for it? I guess that's for Tanyala and Amy.
Well, I can certainly start. First by, really, again, just directly addressing this issue of mental health. We know that there are very high rates of depression. There are also high rates of cognitive decline for people who have experienced kidney failure for a number of years. And we know that this often impacts other things like their abilities to manage complex conditions, or even, in terms of thinking about talking to others about something if you're already severely depressed. And so one of the things, that we really try to do, and this, I think also, I saw a question about reaching out to other organizations. I think it really would serve us well to understand that, just across the board, we may not be the best primary stakeholder for every single issue. It's important to recognize our strengths, our limitations, and it's important to really build sustained relationships with other groups that already have these existing relationships within communities. So, for example, NAMI is one of the national organizations in the United States that really focuses on mental health in, the general population and also in the severely ill. We also have local initiatives as well. So yes, we need additional support. We need better access to specialty care for people who need true clinicians to help them. It's very hard here to get people connected to systems, even people who have private health insurance, because we don't have appropriate access in the US to mental health services. With this, on top of these very life-threatening challenges, then we, I think, have to be creative and thinking about, well, how can we help to bridge some of these gaps and really close and narrow some of the, asking ourselves, who are the other stakeholders who need to be at the table here? And how can we kind of partner together and support each other in trying to really give the best? And Amy can, I'm sure, speak even much more eloquently about this than I can. But I know that people have concerns about, if they develop experiencing issues related to getting life insurance coverage or health insurance coverage, because living donation was considered a pre-existing condition. And so, I really don't know what's going to continue to happen as our policies keep changing. But I do know they won't themselves end up developing illnesses that then lead to end-stage organ failure, and then also just really protecting them and their abilities to be insured in the future.
Flying out to other countries for a kidney, because waiting time is that long here in Canada. And I think many people from the audience may have similar thoughts. Gorge also mentioned that this is happening in the UK as well. We know that it is happening to a small degree in Canada and Ontario, but there is research probably from multiple jurisdictions, but specifically Dr. Prasad at St. Michael's Hospital led a research project looking at patients who left and went overseas to get a kidney, and that study clearly showed that the health outcomes of those international transplants, where people go to different countries to get a kidney, the health outcomes are very poor. Frequently, there are major complications, including death and loss of graft when people are going outside. Nevertheless, if you end up getting a kidney and you come back to Canada, the system will provide you transplant care, but we very strongly discourage this practice because it is very risky. So by that, I don't know if there's any final comment in 1 or 2 sentences from everybody. I would go to Gertch first.
Probably the comment that I've labored the most. I think it's very difficult, but I think especially at this time over COVID, I think we can't overstate the importance of building trust with our diverse communities.
Yeah, thank you. Daniela?
I think that my one comment is that we all have a role to play. We all have important perspectives, and we all have an obligation to work together broadly with stakeholders to make a real difference.
Thank you. Amit?
Yeah, thank you, Esteban. I just wanted to thank everyone for an excellent session, and I have nothing further to add at this time.
Thank you. And Amy?
I have a visual. You put this on, right? Here's my mask, and look right here.
And hope.
We have to have hope. We cannot give up right now. It's, we love our community. We love our kidney patients. We love our donors. We need to make sure everybody's safe. We need to make sure that they can ask the hard questions and we're accessible for them. We need to make sure the patient's voice is amplified so their needs are clear. And we need to work together right now and have hope.
Thank you very much. Yeah, thank you. And exactly that's, I guess, the spirit that we will continue in 5-10 minutes. We will have patients contributing to the next session, and we will talk about our National Action Project. Thank you very much for all the speakers for your time and important essential contribution. Thank you for your friendship and the partnership over the years for many of you. And we're looking forward to the next few years and hopefully better years and success in this field. Thank you very much.
Thank you, everybody.
Thank you for having us.
Good morning, everyone. Welcome back to the second part of this session. As you know, today's session is focused on equity and access to living donor kidney transplantation. So I'll introduce myself. My name is Sunita Singh. I'm the medical director of the UHN Living Kidney Donation Program. And I'm also a transplant nephrologist here at UHN. I'll be moderating today's session. Before we start, I just want to remind everyone that you can submit your questions for today's session on slido.com. Please use the event code #AM1B. And we also are recording today's session live on YouTube on the Center for Living Organ Donations channel. So you'll be able to check out the session there. And for those who tuned in a little bit earlier today, you heard about international perspectives on access and equity to living donor kidney transplantation. So today's session is really focused on improving access to living donor kidney transplantation in the Canadian context. And we have a terrific lineup of speakers specifically to talk about this today. A lot of what you'll hear today also stems from the ACT-I.O.N project, which is a collaboration between the Center for Living Organ Donation here at UHN, as well as the Providence Health Research Institute in BC. And this is led by Dr. Istvan Mucci from UHN, Dr. Jag Gill from BC, both of which you'll be hearing from today. And the aim of this project is really to reduce inequities in access to living kidney donation and transplantation in the South Asian communities, as well as the Black and Caribbean communities in Canada. So we'll be able to hear from those really at the forefront of research in this field in Canada, but are also very fortunate to hear from several patients, donors, and recipients to really share their stories and their lived experiences with living donor kidney transplantation in Canada. I'm going to introduce the panelists as we go through the talk, but we're very thankful and happy to have our patient partners, Rima Garcha, as well as Fadia Jerome-Smith and Winnie Jerome. And then we've got numerous experts in the field of access and equity in living donor kidney transplantation to speak to us today, including Dr. Jag Gill, Dr. Istvan Mucci, Noor El-Dessouky, as well as Lydia Joy Marshall. So welcome, everyone. Thank you for joining us. And before we start, I just want to turn it over to Dr. Atul Kumar, who is the director of the Ajmera Transplant Center here at UHN. And I'll turn it over to him to welcome us and to kick off this session.
Thank you, Sunita. So welcome, everybody. And I'm really excited to launch earlier today and now ongoing this very exciting week focused on living donation and both kidney and liver living donation. It's going to prove to be, I think, a very, very interesting number of sessions. I want to specifically thank all our external speakers and our internal speakers who have contributed to this, as well as our many patient partners who have contributed to this. I also want to give a special shout out to Paula Neves and the whole group from the Center for Living Donation, who really spent an incredible amount of time organizing this in the midst of a pandemic. So I hope you'll all enjoy, and I hope you'll attend many different sessions throughout the week, and I hope we get lots of questions and comments. So I will turn it back over to you, Sunita. Thank you.
Great, thanks, Dr. Kumar. So we're going to kick it off with our patient partner. Rima Garcha has a pre-recorded video for us, but she is present on the call for Q&A. So if there's any questions that you have for Rima, she is here to answer them. So without further ado, here is Rima's story.
Everyone, my name is Rima, and I'm proud to say that I'm a living kidney donor. My journey started several years ago when my sister battled with kidney disease for most of her life. I always knew that I would be, called to the plate, so to speak, and to be able to help her, but just never knew when or how. And it was a very difficult time for my sister to be able to ask family and friends to have this part of a person to be able to donate that to them. But I tried to put my sister at ease. I remember saying to her, "Don't worry, sis, my kidney's your kidney," type of thing. And I was fortunate enough to go through the process of from the questionnaire to all the tests. It was myself, my brother, and my mom that actually had the same blood type. So there was the three of us that sort of started that process at the same time here in British Columbia. And I was the lucky one. I was the chosen one. I often say when I got that call, I felt like I won the lottery. It was just a fantastic relief that at least that I was the best match from a family donation perspective. And you know, we underwent it. So I was able to donate my kidney to her in February 2018. Proud to say that she's doing great, and I'm also doing wonderful. I know, you know, now looking back, I mean, this whole process has given me so much purpose in life, and in words that I can't even really describe. You know, was I scared? I wasn't really scared of undergoing surgery or anything like that. I was more scared of the potential outcome if things didn't go right. You know, for my sister mostly, and you know, so that was my biggest fear, is what if we went through this and things didn't turn out the way that we wanted them to. My family was all quite supportive. My daughter, she was 8 at the time. She was more outwardly, I guess you could say, you know, scared. And I reassured her. I said, listen, I said, I've got an opportunity to save my sister's life. And, you know, she was young at the time, so she, you know, took a little bit of comfort in understanding that, and I took some time with her. But at the end of the day, I was fortunate that my entire family was very supportive of this process and of this journey that my sister and that the entire family has been on. I do realize, though, that within the South Asian community, that there are potential barriers to living kidney donation, and I would say that you know, they could range from communication barriers to cultural issues, perhaps maybe generational issues in terms of perspectives. So I would just, you know, continue to ensure that stories like mine and my sister's are out there, that can be, you know, that can be heard and understood with, like I said, the sense of purpose that I've received in my life, and everyone around me as well. My entire family has felt this, and this incredible gift. Not only is it a gift to my sister, but it's also a gift to all of us that have been a part of this journey. So if there's anything that I can do, is to continue to spread our story and try to help with some of those cultural issues that may be out there. And I'm happy to do that. Thank you.
Thank you very much, Rima, for sharing that story. As I mentioned before, we'll have the opportunity to ask Rima questions in the Q&A. Next, I'd like to introduce Dr. Jag Gill. He will be our next speaker. And Dr. Gill is an associate professor of medicine at UBC. He's also the medical director of the Transplant program at St. Paul's Hospital. Dr. Gill is a CHR-funded investigator, and his research interests are really focused on transplant tourism, transplant opportunities for the elderly, as well as increasing access and equity to living donor kidney transplantation for marginalized communities. So Dr. Gill, looking forward to your talk.
Thanks very much, Sunita. Thanks, Rima, and thanks to the organizers for the opportunity to present here today. I think this has been a great opportunity to kind of just share best practices in terms of what's been going on. What I'm going to talk about a little bit today is some of the experiences we've got in terms of Canada. And so the action project, which Sunita had introduced, is something that has been born of a lot of kind of hard work at both UHN and in BC here. And so we're keen to kind of give you a bit of an outlook of what things look like here. Just going to try to advance my slides here. There we go. So what I'll go through is just very briefly kind of where we are in Canada in terms of the epidemiologic recognition of health inequities, and kind of where we've where we've landed and where we need to go from that perspective, and talk a bit about how we move forward from that standpoint, and then sum up by talking about the action project itself. So as those of you that were part of the session earlier today clearly have heard that health-related disparities are not unique to one community. This is something that we've seen across the board internationally as well as in Canada, and not just in kidney disease and organ donation, but certainly across the board. And so it's something that is key to have us kind of address in our community. If we look at the data within Canada, there's been a number of epidemiologic reports that have looked at the prevalence of kidney disease in and of itself. And so the disease burden is higher in a number of populations based on sociodemographic characteristics. This is some data that's outlined from CAI that's kind of looked at, it's dated a little bit, and you'll notice that trend with some of the epidemiologic data is that it's been a while since there's been a close look at this stuff. But you can see that obviously Aboriginal or Indigenous communities have a higher incidence of a higher prevalence of kidney disease across gender groups, and similar trends are seen in many other subgroups. And so in the South Asian community, and among the East Asian community, among the African community, and amongst, layering on top of that, socioeconomic status is another big factor that also is associated with an increased prevalence of kidney disease. Now, if we look at transplantation and what's been described, again, we have to kind of comb the literature and go back a little bit, but there's been some nice analyses that were conducted using Canadian data. And this is by Dr. Yates and colleagues, and this was looking at the using core data and trying to look at the relative incidence of kidney transplantation broken down by deceased and living donor among Black Canadians relative to white Canadians. And as you can see, Black Canadians are about 40% less likely to undergo transplantation as a whole, but that disparity is certainly more marked when we look at living donor transplantation. So about a 65% less likely to undergo living donor kidney transplantation. If we look at other populations, very similar trends were borne out. And so if you look at what's described here as Indo-Asians or South Asians, in a similar type of analysis using core data, it was found that they were 31% less likely to undergo kidney transplantation. East Asians were found to be about 29% less likely to undergo kidney transplantation. If we look at living donor transplantation, again, that same pattern seems to be borne out, where the disparity seems to be exaggerated, where Indo-Asians are about 58% less likely to undergo living donor transplantation, and East Asians about 70% less likely. So certainly some strong trends noticed in there. Now, a lot of that data is from a while ago, and there has been little data that's been since that time, actually, that's really looked at the experience. So the first question is, do these trends persist today, or have we moved the needle at all in this? And this is an analysis that was done in Ontario by Dr. Mucci and Dr. Kim and colleagues there, trying to replicate again. Let's looking at the incidence of the likelihood of getting a living donor kidney transplant by ethnicity. And again, I'll just direct you to the table on the bottom here. And if you look in the different subgroups here of African Canadian, East Asian, and South Asian, again, we're seeing that there's a significantly reduced odds of getting a living donor kidney transplant, again, along the same lines, right? About 70% less likely. And so this was a slightly more recent cohort. And so it appears that those trends continue to persist. On a national level, there hasn't been a very close look at this, but if we look in general, what's happened in living donation, as we all appreciate, living donation's been pretty flat in this country. If we go back, 10 some odd years, we've been sitting at around the same number of living donor transplants per year in Canada for quite a while now. Now, if we look to the United States, where there's been a retraction in living donation, we haven't seen that to the same extent yet in Canada, but it is still cause for pause when we see that there's a leveling off of living donation rates, even when we've had a number of initiatives during that time period, whether it's kidney pair donation, whether it's trying to work with incompatibility. And despite that, we've kind of had a bit of a leveling. If we look at what's happened in terms of the relative incidence, this is just, again, excludes Quebec, the table there. But basically, if you look at the relative incidence of living donation, which is a slightly different way to look at it, we're not looking at transplant rates, but donation, but really gets you to the same point where you're seeing a very similar disparity where non-Caucasian communities, and here we've got Black, South Asian, and East Asian, are about 60 some odd % less likely to have living kidney donation occur. And so these are cause for concern and do suggest that these trends are not changing and that these trends do persist today. So the big question is, we've had years of really presenting this epidemiological data, and that's something that we do often, and we talk about this issue. And where we tend to get stuck, it appears, is next steps, right? So we've noticed these observations, we know they exist, we appreciate that they're not changing, but we haven't really, as a community, been able to move beyond that and say, well, how do we actually, take the next step? And so why is that? And I think part of it is that it's not a simple fix, right? It's a multi-pronged issue. We have to go a long way to really understand some of the drivers behind this. But if we kind of take a step back and think about what we need to really do, I mean, some of it is, intuitive, but obviously we have to look beyond the individual, and we have to start in our care and in our day-to-day kind of practice, start thinking about the social determinants of health and how that kind of weighs into the interactions we're having with our patients, both on the patient side and on ours. But when we see a patient, we got to think more about what the different aspects are in their life that may be contributing to their ability to access care, their understanding of what's going on, our ability to deliver the care in the manner that it needs to be delivered. All those issues kind of need to be considered. We also need to, quite frankly, acknowledge the role of the healthcare system in contributing to these inequities. And so I'd like to think we're all very well-intentioned in our work, and we want to do the best for everybody, but the system does have flaws in it. And I think we can all appreciate that. And so this notion of, one size fits all doesn't work. And I think we all kind of intuitively know that, but putting that into practice is sometimes challenging when we've got, algorithms and policies and issues in place in each of our respective centers. And so I think that critically evaluating our current model of care is an important first step for us to kind of really think how we can at least start to move the needle on this area. And then specifically, when we're talking about, groups that are marginalized by race or ethnicity, we got to think about what's the cultural sensitivity in our interactions and in terms of our processes, or the cultural safety, and how do we try to move on that and improve that process. We also need to appreciate that some of these factors are modifiable. So if we look at some of the data, if we look at some of the assumptions that may come from that, it's often that once something, I put cultural in quotation marks there, because sometimes once something gets driven or labeled as a cultural barrier, there's a tendency to think that may not be modifiable. And I think that we need to, there's been examples of that, I'm sure, as you heard this morning, that there are opportunities to modify what's happening in terms of access within cultural groups. It also oversimplifies the issue, because within a cultural group, you've got a ton of diversity and tons of issues that need to be considered. And so I think appreciating that there are modifiable things that we can look at, particularly within our health systems, that's an important step to move us forward. An example of that, this is just a study, this is a simple epidemiological analysis that we had done years ago, but it just kind of shows you how simple a simple look at things in a slightly different way can sometimes change the narrative a bit. And so, as we know, in the United States, living kidney donation or access to living donor transplantation is reduced among African Americans. The presumption has always been that living donation, the lack of living donors is a driver of that, which is likely true to some extent. But we had done this analysis where we had simply looked at this interaction between median household income and race, and reported living donation rates after adjusting for various factors, including the incidence of end-stage renal disease in that population and those kinds of issues. And what we actually found is that really you start to see that when you break things down by socioeconomic status, the differences start to dissipate. And so within each category of income group that's laid out here between Q1 to Q5, and you go kind of from the lowest income group to the highest, what you tend to see is that, in fact, you don't see a huge difference. And if anything, you see the difference. The living donation rates were higher in African Americans when you get to the high income groups. Now, a larger proportion of the African American population was within the lower SES subgroup, which is why we see lower overall rates. But it does go to say that perhaps financial barriers and some modifiable factors that we could address in terms of that aspect of it may be useful in trying to reduce some of the disparities that we're seeing in access to transplantation in the US. And so how do we kind of move forward? Well, I think, as I said earlier, it's complicated, and it's partly complicated because the more people that need to be involved and the more engagement that's required, the harder it is to get things done. And that's kind of an essential piece to this work. And so you have to make sure every stakeholder is engaged at a very early phase before we do this. And so institutions, clinicians, but also government and policymakers. So depending on who's going to actually implement the change, we may have a great study that says this works, but you kind of need partners up front to say we need to move this field forward, and how are we going to actually implement those changes so they're sustainable. And of course, most importantly, we need patients and also community partners, and community members need to be a key part of the process so that we can really make sure that the change that's being implemented is not a top-down kind of approach. It is much more collaborative in nature. Now, some kind of key considerations or challenges as we kind of look at this work. First of all, I think when we talk about work, we have a tendency, and some of this is pragmatic, right? We have to lump groups together. We have to say South Asian. We have to say, East Asian. We have to kind of say Indigenous and lump a fairly diverse population into one lump. And I think that makes it challenging, but we need to be mindful of that throughout the entire time. And so there's a significant amount of diversity within each target population that we're looking at. And then on top of that, we got to think about the geographical considerations. And so if we're looking at health services interventions, obviously there's generic things that we could do that could help, but the specifics when we're looking at the difference in the target populations can vary quite significantly, whether we're talking about Vancouver versus Winnipeg versus Toronto. And so the generalizability can be a bit limited when we're doing some of this work. The other thing that's important from a research standpoint is mixed methods are often required. So I'm primarily a quantitative researcher. So quantitative methods will only get you so far in this area. You need qualitative input. You need some in-depth feedback on where we're heading, and then we can weave that into some sort of a measurable quantitative study thereafter. Funding opportunities are certainly improving, and I'm thankful to the organizations that have given us some funding to lead this work. But traditionally, that's been a challenge and a barrier to kind of try to get some of this work addressed. And as I said earlier, partnerships are key, and not just the partnerships I mentioned earlier, but I think as a country, it's important that, that we're not a huge country. And so people that are interested in this area, people that are working in this area, it's been important to come together. And so the collaboration between UHN and UBC has been important in terms of driving some of this work and really making it happen. So I'll talk a bit about the ACT-IO-N project. The formal name of the project is Improving Access to Living Donor Kidney Transplantation in Ethno-Racial Minority Communities in Canada. And Dr. Singh kindly gave a bit of a brief introduction to this, but I'll just talk you through a little bit more of the specific initiatives that are embedded within this. And so our overarching goal, as you heard, really was to aim towards equitable access to living donor transplantation. irrespective of race or ethnicity. And so the goal here is to focus on living donor transplantation as a first phase of this work, and really look at some few target communities to really try to address this issue. Now, the specific goals of this project and our aim really was to, as I said earlier, the geographic considerations, the target population considerations are variable. And so when we thought about putting this together, the thought was to apply a standardized approach. So if our goal here is we will provide a framework of how to address this issue, or how we think we could address this issue. And we could apply that and develop that in 2 different provinces that have different considerations, and in 2 different target populations that are based on the demographic considerations within each of those provinces. And so that's what we did. And the process that we're embarking on, or have embarked on, is to engage patients and community members right at the outset, as part of developing the program, as well as gaining the data and have a better understanding of what the barriers are to living donor transplantation, so that we can kind of move forward and develop solutions in partnership. Leading from that would be a series of interventions that would from a health services perspective, but also from a community perspective, that could then be evaluated and implemented. And we develop and lay out those plans and pilot some of that in each of our provinces and our target population. And the hope is that through this, what we'd have nationally is a bit of a template, as I said earlier, to say, okay, well, if the same basic bones can be used to apply this kind of approach in 2 provinces, then that should be applied in other communities. And so, we've started with a few key target populations, but the intent here really is to have a much broader study that's going to go to spread throughout the country in other regions as well. Another important part of this was to update the epidemiological data that we have. And so, as I showed you earlier, much of the data is, over 10 years old now, in terms of looking with, save a few studies that have been done within individual provinces. But from a national perspective, as many of you appreciate, there's certainly this is an important time in terms of data in our field in Canada. We're on the kind of precipice of building a national data system that hopefully will be something that can lead us forward. And so I think it's timely now for us to kind of work and create some new data on this issue, and also work with our patient partners and with our community partners to understand how best that data should be captured, how best that data should be evaluated, and how it should be reported. And so moving forward, we'd like to inform measures to track and report some of these inequities, and also our successes as we move forward in the field. So these are the target populations in the 2 provinces, as I've said. So in BC, we've targeted the South Asian population, and in Ontario, the target population has been the African, Caribbean, and Black community. This was based, as I said, on some of the work that's been done in the past in our respective provinces, and also the population demographics that exist in those areas. And so we thought this was a reasonable approach to begin. But as I say, the hope is to really branch this out to other communities. And I'll talk a bit about some of the background piece in BC in terms of the landscape and how we kind of came to be. So as I had said, there's obviously different considerations in each province in terms of where we're starting from. And so in BC, there's a few unique things that we do. So one is there's a provincial approach to both renal care and transplantation care. And so we've got the BC Renal Agency, which coordinates and funds a lot of the work that's done on the general nephrology side, including some standardized algorithms of care, standardized funding streams for chronic kidney disease clinics, and so on and there forth. And that offers us an opportunity to really tap into a bit of a standardized system to do some implementation work there. On the transplantation side, we're also provincially organized. And so we've got 2 transplant programs based in Vancouver. Those are both sitting in Vancouver, but we do serve the entire province. And so we have a provincial mandate, and that's facilitated by BC Transplant, which is our funding body. And that again allows us to standardize some things province-wide and in a rather quick fashion. We've also had a bit of a history of a culture of living donation in this province, and that's been fortunate for our patient population that have had improved access to living donor transplantation as a result. And so that's the figure on the right, simply just looking at the data from our annual report at BC Transplant. And as you can see, the living donor rate per million population is generally hovered between 20 to 25 over the years, and that's higher than the national average by a decent margin. And so that can springboard us, we hope, to additional initiatives. The other key piece, there's been a few big initiatives that we've been undertaking in recent years to try to expand living donation further, and really with a focus around preemptive living donor transplantation. And so I just wanted to take a few moments to outline a couple of those because they do dovetail importantly with this initiative. The Transplant First initiative is something that we've undertaken in partnership with BC Transplant and BC Renal Agency. And that's very much the mandate there is to target chronic kidney disease clinics around the province. And the idea being that we've got a new clinical pathway there that really divorces this idea of dialysis from kidney transplantation. And so kidney transplantation is considered at an earlier stage in the disease process. Active work to try to identify potential living donors and work towards that area has been something that's been key there, and an important level of education. So that's an ongoing initiative in the background that is provincial in scope and is continuing to evolve. That's happening here. The other important initiative in play is the Bridge study, and so this is a project I'm leading. It's funded by CIHR's SPORE program. And we were fortunate to kind of develop this. And so it's very similar in principle to what we're doing here. So basically, it's looking at access to living donor transplantation in Indigenous populations in our province. I'll be speaking about this in a bit more detail on a session on Friday, so I won't get into that too much right now. But basically, the premise was similar. When we started that project, the disparities are stark in that community. And so the thought in our province was to use this funding opportunity that we had to develop a bit of a standardized approach where we will use qualitative data and quantitative data to gather the feedback, partner with patients, partner with elders, partner with communities, so that we can actually develop a bit of an algorithm and in terms of our clinical care pathways. And that's been the key, right, with that project. The real focus has been on, yes, there's community-based interventions that are required, but from a health services perspective, in terms of how we're delivering the education, that's something we could control and modify. And so let's really focus in on that piece. And when this opportunity for action came along, really, I think when we had discussed this at a very early stage, the thought was to apply that type of a model to other populations here. So it is, working towards what I said earlier, kind of developing a template and then generalizing that to other subpopulations in other regions. And that's how we're moving forward. And then, of course, as many of you appreciate, we do have a large South Asian patient population. And when we've looked at the demographics of our South Asian population in BC, it is predominantly, although not exclusively, it's still diverse in terms of the population, but there is a larger subset of North Indian, Punjabi-speaking individuals. And so a lot of our work has been focused on that subgroup as an initial phase here. So some background data that we also had in BC leading into this, we had done some survey work with end-stage renal disease patients in British Columbia, trying to get their sense of, what's their willingness to discuss living donor transplantation, that's their approach or perspective, how willing are they to talk to prospective donors in terms of living donation. And not surprisingly, Noor is going to present after me and present some of the similar data that's been accrued in Ontario. But really, I think a similar message has emerged, which is there is certainly a lower willingness among some groups, South Asians and East Asians, is what we found, that had a lower willingness to discuss the need for living donor transplantation. But importantly, and the figure in the bottom, don't bother trying to work your way through it, but basically what that's looking at is we presented a series of scenarios and said, okay, what if we did this? And what if you felt confident that your donor is actually engaged in this process, or the risk and benefits were better explained, and if we gave you more education and all that. clearly it's modifiable, right? So that point I made earlier to say something's cultural and therefore not modifiable is obviously a fallacy. And so there is certainly a significant, over 40% of people would modify their thinking around approaching and accessing living donation if under certain conditions were met or certain information was provided. Sorry, there we go. Oops. So the key elements really of the project then, as I've outlined, I just want to give you an update on where we're at right now. And so we're just, under a year into this, and obviously truncated by COVID, which is, for all of our work thrown a wrench into everything. But, we're working on updating the Canadian epidemiologic analyses. And so I've been working with CORE and CII, and we're replicating some of the analyses that were done in the past, but more importantly, we're working we're on kind of looking at all the data holdings within CII to merge some of those data and have linkages so that we can get some new data and look at some more nuanced analyses with this. And that's been a bit of a challenge, quite frankly, simply because of the degree of missingness that occurs in terms of ethnicity and race variables. And so we're working to try to supplement that so that we can actually do some of these analyses. But I think there's going to be some important work there in terms of, as I say, not just producing the new data, but also identifying the gaps in the data and where we need to move forward from a data perspective in terms of this. In terms of the core project itself, a lot of the work that's being done in both provinces in the last year have been around engagement of community and patients, building on the relationships that already existed, but then actually expanding that to include new groups. In British Columbia, there wasn't the same degree of network in terms of kidney disease and health with the South Asian community. So we put a lot of work, and I really commend our community engagement partners, who I'll outline in the last slide here, to really do a lot of this work and bring together a group of individuals that are keen to kind of move forward and help us plan this project. We've engaged with policymakers and funders already in our province so that they know this is coming, they know this is happening, and we've already worked with the individuals on the other projects that are ongoing in the Transplant First initiative so that this can be kind of, melded in as part of that depending on our findings from this. And then the bulk has really been around trying to collect some of the core data through these partnerships with the individuals. I just wanted to identify some of the partners. This is not an exhaustive list of partners, but PICS, or the Progressive Intercultural Services in Surrey, British Columbia, has been one of our major key partner organizations. There's a number of other ones listed there. There's also, you'll notice, not just organizations restricted to British Columbia, but we wanted to leverage the work that's been done, the hard work that's been done in Ontario by the U.H.N. group in developing some relationships with the South Asian community in Ontario. And so we're working with those individuals as well, and those groups as well. And that's really been a great experience. In terms of where we are in terms of the recipient and donor data, Noor is going to review kind of some of the preliminary data we have, but to date, really what's happened is a lot of qualitative work's been done. So in-depth interviews with donors, previous donors, transplant recipients, both who had a living donor transplant and transplant recipients who were unsuccessful in achieving a living donor transplant have been conducted. And the types of data and kind of that we've acquired there in the conversations have been around understanding their South Asian identity, their thoughts on that, and really been a good chunk has been focused on what's been their experiences through healthcare, specifically through the kidney transplant experience, feedback on specific elements of the clinical pathway that we deliver to see if there's areas that were lacking and how we could modify that from a culturally tailored perspective. And also, of course, a broader sense of what the barriers have been to accessing living donor transplantation for the recipients and considering donation and perhaps going through the process of donation among the potential donors. We've also obtained broad community perceptions in terms of what about living donation and transplantation and where that sits. And there's been some interesting data largely around communication, around community engagement. And one message we've heard very clearly is that certainly the clinical pathway needs to be modified, but we also need to start thinking about how we're going to engage with the community on a longitudinal basis to make sure there's very targeted educational events that are occurring there. But I'll leave that to Noor to discuss some of the highlights of that in the next talk. In terms of next steps, we're currently in the process of evaluating that data in a more detailed manner. We've got a group of an advisory council in British Columbia that we'll be reviewing the data with, as well, going back to community leaders and conducting some focus groups to round out our potential proposals for what the interventions would be. And the interventions are really targeted in two streams, right? So clearly from a clinical pathways perspective, there's going to be some changes that we can make, whether it's new educational tools, whether it's more navigators, that's yet to be determined based on the data. But that's one aspect of it. And then the other aspect is going to be more a broad-based, community-based interventions that would supplement the work that's being done in the programs to address some of these disparities. And then we'd be developing a pilot to pilot some of these interventions, and then a longitudinal kind of evaluation and implementation strategy around that. So I just wanted to end by thanking all the individuals that have come together for this work in a very short period of time, so I really do appreciate these individuals coming forward. And I have to say, all of us have been through a tough time through COVID, and all of us have been kind of learned how to adapt. And I personally have been very impressed by all the individuals here that have kind of really not missed a beat in terms of their commitment to this project and their engagement in this work. And so I've listed, you've met Rima, who's one of our patient partners, but also the other patient partners, Jesse, Gil, Renita Singh, Dale Bad, and Gurbinder Bad are all individuals that we're working with. From a community engagement perspective, I'd like to certainly highlight that. That's been a significant work that's done by Ratinder, who's been our community engagement specialist, as well as Raj Handel from PICS, who's been really helpful in terms of this. We've got a fantastic advisory council made up of physicians, made up of nephrologists, made up of community members, patients that are really helpful. And then, of course, none of this is possible without our project management team led by Jamie Schick and our qualitative team outlined below. So I'll stop there, Sunita, and thank you very much for your attention.
Great, thanks very much, Jag. That was a terrific overview of the Action project and where things stand. It's a really exciting project, and I think it'll be really great to hear Noor talk about some of the early data coming out of that initiative, as well as some of the barriers. Next to speak on that is Noor Al-Dasuki. Noor Al-Dasuki is a research associate with the Kidney Health, Kidney Health and Education and Research Group at the University Health Network. She does have a background in biomedical science, and she actually has completed a Master of Science in Global Health from McMaster. She works within the UHN group, managing various kidney health and education and research projects, and she works with marginalized communities to improve equitable access to living organ donation. So it'd be great to hear from Noor on some of the early data. So Noor, over to you.
Hi, everyone. Thank you, Dr. Singh, for that introduction. Can you hear me okay? Okay. So as was mentioned, I am a research associate with the Kidney Health Education and Research Group, and not a telemarketer, as one might think with this headset. So today I'll be building off of Dr. Gill's presentation and talking a little bit about some of the barriers to living donor kidney transplant in South Asian communities across the country that we've identified as part of the Action project. Before we start, I just wanted to mention that I don't have any conflicts of interest to disclose, but I do just want to note that this presentation provides a research perspective on the topic and not a community perspective. All right, so I just wanted to start with a brief introduction to the community. So South Asian communities actually represent about 6% of the country's population, according to the 2016 census. The South Asian community is actually very diverse, which is why I try to use the terminology of communities. Although the majority of South Asian Canadians are first generation, there is also a growing proportion of second and third generation individuals who have ancestral origins in India, Pakistan, Pakistan, Sri Lanka, Bangladesh, and many other countries as well. And as Dr. Gill mentioned, research across the country has shown that South Asian patients experience inequitable access to living donor kidney transplant. And I think now that we kind of have identified the disparity, we have a responsibility to act on it and to understand why that is. So our team has undertaken research as part of the Action Project to understand the barriers that South Asian patients experience in accessing living donor kidney transplant. And I'm going to go over some of those findings with you now. So I'm going to start off with some of the research that was done in Ontario. As Dr. Gill mentioned, we've had some research done in Ontario and some in British Columbia. So in Ontario, over the last 5 years, actually, we've asked adult patients who were potential kidney transplant candidates across the Greater Toronto Area to complete an electronic survey on their knowledge about and their readiness to pursue living donation. It's important to note that these questionnaires were only available in English, so we were unfortunately not able to engage patients who couldn't read English at a grade 5 level or higher, which is an important limitation of this work. And these findings might also not necessarily be applicable to South Asian communities outside of the Greater Toronto Area. But within those considerations, we did have 18% of participants who participated in our study identified as South Asian, and a majority of those were male and had at least a high school education. So we asked patients if they would be willing to accept an offer of living donation and found that South Asian patients were as likely as other groups to say yes. However, when we asked patients if they've talked to others about their interest in living donation, only a quarter of South Asian patients had done this compared to about half of white patients, as you can see in this graph. Similarly, South Asian patients were less likely than white patients to have shared educational materials about living donation with others, or to have allowed others to tell people about their interest in pursuing living donation. And this indicates that there might be some specific factors which influence South Asian patients' ability or willingness to communicate and share their interest in living donation with others. Sorry, just switching slides. There you go. We also asked patients what factors were important to them when making a decision about transplant, and we found that South Asian patients were more likely than white patients to say that the pain associated with transplant surgery, concerns about being able to pay for drugs to prevent transplant rejection, and having to take a lot of medication after transplant would be very important to them in making their decision about transplant. And what this tells us is that patients may have some serious kind of practical concerns around pain and medication and kind of financial implications of transplant, which need to be examined further and addressed. We also asked patients if they thought that rich patients were more likely to get a kidney from the waiting list than poor patients. And we found that South Asian patients were more likely than white patients to say yes to that question. So while wealth doesn't factor into your position on the wait list, the fact that many patients think that's the case indicates a serious level of mistrust in the equity of the transplant system, which I think is a concern that needs to be addressed from its roots. So we also asked patients to complete a questionnaire testing their knowledge about kidney transplant. And we saw that South Asian patients were less likely than white patients to receive the highest score on this questionnaire, which is indicated in the gray bars. And they were more likely to receive the lowest score on the questionnaire, which is indicated in the yellow bars. So while this might suggest some potential differences in overall knowledge about kidney transplant, I think it's important to note that patients from all groups actually answered key knowledge questions correctly. So that kind of indicates that patients understand the key benefits of kidney transplant, but there might still be some gaps in patient education around the transplant process, and we'll have to do some more work to understand the specific support needs of patients from South Asian communities. And lastly, from the research in Ontario, we asked patients what factors were important to them when making a decision about living donation, and we found that patients from all racial and ethnic groups often said that they would feel guilty having someone donate to them, that they were worried about harming their relationship with their donor or their potential donor, and that they were concerned about the potential health problems that a living donor could have going through donation. So concerns about the potential negative effects of living donation are clearly common. And I think it'll be important for us to implement practices to comprehensively and efficiently discuss the risks of living donation with potential donors and recipients as well. So to switch gears a little bit, I'm going to kind of take the rest of the time to discuss some of the findings of the research that was conducted in British Columbia by the team there, and Dr. Gill introduced everyone there. So the team conducted research with South Asian communities in BC between January and March of this year, pre-COVID, and they conducted interviews with a variety of South Asian individuals from Vancouver-based kidney transplant clinics who had donated or received a kidney. Interviews were conducted in English or in the participants' preferred language. But since this research was only conducted with South Asians in the greater Vancouver area, we do need to note that the findings might not be applicable to individuals living in other areas of the country. Also, the team had only been able to interview individuals who had gone through the kidney transplant process and haven't yet been able to connect with community members who might not have felt comfortable donating, which might provide a different perspective on barriers to living donation. So that's just something to keep in mind as we go through this data. So we were able to engage 20 kidney transplant recipients, the majority of whom were male, and 10 living donors, the majority of whom were females, in interviews for this project. So a substantial proportion of participants were born in India, and about 30 to 40% had undergone their transplant or donation within the past year. So in analyzing the data, we found three main themes that impacted or that represented kind of factors that impacted access to living donation. And those were cultural dimensions, sociocultural systems, and clinical pathways. And I just wanted to start off talking about some of the cultural dimensions that were identified as part of this work. So viewing kidney disease as a natural and inevitable part of life was seen by some participants to prevent patients from considering living donation. And this was especially relevant amongst older participants. Younger generations were seen to be a little bit more open to learning about and considering Western approaches to health, including kidney transplant. Specifically looking at younger women, they often shared how kidney disease was a source of shame for them, and that disclosing their disease was thought to potentially hurt their marriage prospects by family. And younger women also, or younger women specifically who were considering donating, shared how they were warned not to donate for fear of being seen as incomplete or because of potential pregnancy complications that could occur or that were thought to potentially occur as a result of donating. On the other hand, men tended to express worries that donating a kidney could affect their ability to work and provide for their family. So that was an important consideration. When looking at the theme of sociocultural systems, a really big, finding that came out is around the secrecy surrounding disease, and the fact that that was actually a very common sentiment. So participants shared how they felt the need to hide health issues in order to be able to meet South Asian societal expectations. And secrecy was sometimes related to a feeling of shame that was associated with the disease, which limited patients from discussing their disease with others or seeking support. And some recipients shared how they found it difficult to ask distant friends or family members to consider donating because of the stigma and guilt, as well as concerns about donation negatively affecting the donor, which is something that we also found in the Ontario context. And participants also shared how a lack of awareness around kidney donation and the short and long-term impacts was something that they felt led to fear around the topic in the community. And some participants felt that there were common misconceptions within the community, especially the fear that kidney donation would lead to permanent health complications for the donor. So moving on to the last theme around clinical pathways, participants expressed the need to more clearly communicate information about kidney transplant and donation within the clinical pathway, and specifically around the topics of the long-term health effects of donation, the side effects of transplant medication, and expectations after donating or receiving a kidney. Participants also shared how there is a need to provide more support and more understandable information for kidney patients, especially non-English speaking patients who experience language barriers, as was common. And recipients also tended to note that the testing process was felt to be long and inefficient, although it was important to conduct thorough testing, but there was a clear need to streamline the testing process. So overall, I think that this research gives a really important first glimpse at some of the barriers that South Asian patients may be facing in accessing living donation, both in the Ontario and British Columbia context, but there is still a lot more work to be done around this. So going forward, we will be continuing to partner with community organizations to conduct focus groups and interviews with South Asian patients, families, and community members to gain a deeper understanding of the barriers that communities face in accessing living donation and analyzing that data, so that we can have a better understanding of the root causes of these barriers, and then be able to partner with patients and communities to determine the best ways to address those barriers, and then hopefully test those strategies to reduce and eventually remove barriers to living donation for patients from the South Asian communities across Canada. So I hope that by working in collaboration with patients and communities, we can work to make effective and appropriate and sustainable changes to make sure that individuals from South Asian communities and other racialized communities have equitable access to living donation. And I guess I'll end there. Just wanted to thank everybody for listening in today and joining the Living Donation Week events. And yeah, that's it from me.
Thanks very much, Nora. That was a terrific presentation. A lot of really interesting and very fascinating data. I'm sure lots of people will be having questions for you and for Dr. Gill about what you've just presented. So just a reminder to everyone that we will be waiting till the end of the session for questions, but please do submit them on slido.com. Again, it's hashtag AM1B to submit your questions on Slido, and we'll have the opportunity to pose them to the panel at the end. So now we'll be moving forward with hearing another patient story, and this time we'll be hearing from Fadia Jerome Smith. And Fadia received a kidney transplant. Her story is recorded as well, but she is going to be available for Q&A as well. So, moving on now to Fadia's story.
Hello, my name is Fadia, and I am a kidney transplant recipient. Here's a little bit of my story. So in 2008, I want to say that's when all the alarms went off for me. I had really severe back pains. I'd like to say severe, but because I'm an athlete and I played lots of sports and I have a lot of energy, I thought, let me just take Advil and go to sleep, take a nap. I do that and I wake up worse. So I go to the hospital and we do ultrasounds, we do all the tests, blood work, and so on and so forth, to tell me now that I have really small kidneys and I have high blood pressure. So then starts my internet search, and that's when I really start kind of getting interested in finding out, okay, well, how is my body getting to this point? And I never really thought that something was wrong with me. And then I started looking back, and I did have signs. Vertigo was one of the signs that I had when I was in my undergrad, that I did speak to, a doctor about, and kind of just drink water, go to sleep, you'll be fine type of thing. I had really bad migraines in high school. Same type of situation, not really giving much reassurance that everything was okay. But because they brushed it off, I brushed it off. So now fast forward to the time when I was referred to a nephrologist after all these new discoveries about my body. The nephrologist that I had in my hometown did not, to put it plainly, did not take me seriously, if I can put it that way. I'm a young Black professional. I'm, well-spoken, and I don't want to say that's the reason why he didn't take me seriously, but maybe the signs weren't, as alarming to him. He just kind of gave me some blood pressure medication and just sent me on my way. I did not feel cared for at that point. And again, if the doctor doesn't seem alarmed, then I'm not going to be alarmed. So 2008 now, 2009, I just kind of brush it off. I'm just like, I'll be okay. I get married. I have my first child in 2010. 2010. That's when, the doctors were like, why are you high risk? You shouldn't be high risk. And how come no one told you that you would be in a high risk situation if you fell pregnant? I'm like, well, the last doctor didn't care, so I just assumed that I was okay. We unfortunately lose the baby at that time in 2010, and then we try again for another child. My beautiful son was born in 2012, and then my kidney said, no mas, no more. We don't want to work anymore. You need to figure something out, body. So then my prenatal team referred me to another nephrologist, and she was a godsend. And she was the one who was literally on me every day to make sure that I was doing my blood work, that I was watching what I was eating. The nutritionist that I had at that point as well took the time to really look at my diet and what I could change to, make myself feel better, and so on and so forth. Now, fast forward to when they told me I had to start dialysis. It was a couple months or a couple weeks, I want to say, after I discovered that I had focal segmental glomerulosclerosis. I memorized that. And at that point, trying to figure out, okay, do I want to do dialysis at the hospital or do I want to do dialysis at home? That's the only time that I had a person look like me. And I'm saying all of this to say that representation is not just important in the workforce, knowing that, oh, okay, well, we have a South Asian person, or we have an African American person, or we have a Caribbean person, or an African person, or someone from the LGBTQ community. It's not just having those token people there, but it's for the patients, right? It's for the guests that come in looking for reassurance, looking for support and help. So on that journey, having someone that looked like me at that point made me feel like, okay, here's someone that I can literally let my hair loose and just be completely 100% frank without having to change my language or change the lingo that I use, not knowing what background she was. And mind you, I'm French Canadian. My parents are Haitian. There's not a lot of Haitians. The Haitian community in the GTA is not that large. So having another face that looked like me made me feel like, okay, this is someone that I can be 100% with. I can be 100% myself. And it's sad that it was at that time that I had that face. However, I'm so very thankful that, even the nephrologist that I was referred to after pregnancy, I'm very thankful that she was thorough, right? And the entire team was there to support me through email and phone calls. So I'm saying all this to say that this conversation and the research and the data that you've all worked really hard towards is to continue raising awareness in those communities, to make sure to let them know that, their concerns and their worries are not falling on deaf ears, and that their experiences matter. And, thankfully, my experience was not overly bad, but I'm speaking on behalf of those that may have had bad negative experiences in the healthcare system. So thank you very much for hearing my story. If you have any questions, I'll be right there to answer them and go from there. Thank you.
Thank you, Fredia, for sharing your story. It's really powerful to hear patient stories and really to hear what you have to say. What we also are going to do today is be able to hear from your sister, Winnie, who is a living kidney donor. And so I'll turn it over to Winnie to be able to share her story.
Hello? Can everybody see me and hear me?
Hi, Winnie. Yes, we can.
Okay, awesome. Okay, so just plainly, I guess the story for me really just starts when I found out my sister is sick. You never really plan for these kinds of things. So when I heard of how severe it was, and at the same time, had the verbal concerns of my parents and my family, like my other extended family, my in-laws, tell me that it wasn't a good idea because at that time I had not yet had my child, my son. I just kind of had to quickly just put things into perspective, which for me that meant seeing, like that the sentiment, like what sentiment kind of resonated with me and that was being repeated was that I was doing something great for my sister. And really and truly, not to knock anything to her because I love my sister, obviously. But yes, I was doing it for her, but in part I was really doing it, as she mentioned, for her son. There was no way I was going to let this little guy grow up without a mom because it seemed like that's where things were going for her. Seeing her going through dialysis and so on and so forth was heartbreaking. And she was working full time at the time. And so continuing on to doing dialysis and working and then coming home to a toddler who's full of energy but can't play with his mommy because mommy is sick. That's kind of what put things into perspective for me. So I went through all the necessary steps in order to see if I was indeed the right match, and all of that through in the midst of having my own preemie. I had a son who was premature, and so once he was born and he was stable and he was home, and we were able to participate in the paired exchange program. Like that's when the ball kind of started rolling. So in the midst of this of all of this and trying to find out if I was a match, we were hopeful and excited until I wasn't. And so really and truly, thank goodness for the paired exchange program, which allowed us to find a match. And also thank goodness for very inquisitive hubbies, who was there asking all of the possible questions, as it seems like there is a little bit of mistrust between the Caribbean community and healthcare professionals. It seems like there's often an overload of information, but it's not always the clearest. The way it's communicated is not always in the clearest ways, simply because there are roadblocks when it comes to language and access to programs such as the paired exchange program. And perhaps this is what this panel is trying to change in doing the research and bringing awareness to living donors. Afterwards, I would say I was often asked as well if I suffered from any kind of depression after the surgery, as the attention kind of quickly shifted to Fadia's recovery. But I always made jokes and said that I mostly felt like an imposter. I mostly suffered from the imposter syndrome, as people kind of looked at me as this hero. And really and truly, I just wanted to help my sister. I just wanted to have her be healthy and to have her be there for her son. So all in all, my overall experience with the medical team was great. I don't have any anything to complain about. I was never left wondering what would happen to me or what could happen to me, during the surgery or post-surgery. And again, very grateful for a very talkative husband who thinks of literally all the questions in the world as I was kind of mentally preparing to just have the surgery. And so the only real advice or thing that comes top of mind for me to any potential living donor is to trust that, and I know this sounds corny, and this is the blood donor slogan, I guess, like this gift is in you to give. It's something that you have in your body that you're able to give to someone with no, from my personal experience, with no real repercussions after the surgery. And so why not give that gift to someone who's in need? And also being able to be a living example of what modern medicine can accomplish in itself just reaffirms all of this important work that you guys are doing. So that's my side of things.
Thanks, Winnie, so much for sharing that. I think one of the things that comes out in your story, as well as Rima spoke about this, is how important the people around you who were supporting you were to you. You mentioned it, Rima also mentioned it in her video as donors, and I think that's something that that we'll hopefully be able to talk about in the question period, and something that I know that that some of the objectives of the research going on is looking at is building support around donors. And so I think based on what you said, that's clearly a very important factor. We're going to hear now from two more speakers to discuss more work that's going on within the Action Project. First, Lydia Joy Marshall, and then secondly, Dr. Ishran Mucci. It's my pleasure to introduce Lydia Joy Marshall as our next speaker. Lydia Joy is a research assistant Lydia Joy is a research assistant and a community liaison within the Kidney Health Education and Research Group at UHN. She also has many other roles. She's a tissue coordinator and team lead at Trillium Gift of Life, and she also serves as the vice president of the Black Health Alliance, which is a non-for-profit organization that strives to reduce health disparities in Canada's marginalized populations. So we're looking very forward to hearing Lydia Joy's point of view in terms of speaking of barriers and strategies to improve access to ACB communities in Canada. Lydia Joy?
Good morning. Good morning, everybody. With that introduction, I thought I would be very authentic today, since I'm from the African Caribbean Black community, that I would be in the Caribbean. So I'm greeting you this morning from sunny Barbados, or this afternoon. I've lost track of time. I first just wanted to thank everybody for coming, this morning to speak about this important topic. And we've been doing a lot of work in this, and it's very timely. So I just thought I would disclose, although all these hats have been put forward of where I'm sitting, I'm not sitting here representing any other group other than hopefully my community and putting forward the voices. I think that that's already been done quite well. I don't know how much I can add from that right now, but Fadia and Winnie have really kind of set the tone of what I'm trying to amplify and the voice that we're speaking from. So I'm one person that's representing and trying to amplify some more of those stories that we have already seen and addressed at the beginning of this action project. So whenever I'm speaking, we always like to speak from knowing who are we talking about. So similar to, as Nora said, the Black community in Canada is very diverse. So we're not speaking about one community, one group. We're speaking about a conglomerate of many different communities. So our last census in Canada reported about 3.5% of the population self-identify as Black. But what that means are very many different things to different people. Some people are generational Black Canadian, some are immigrants, some are born here here and associate as another culture or ethnicity. This is just kind of a very high-level overview of the majority of where everybody identifies from. Some are continental Africans, some are Caribbean, some are from various places within Canada. So when we use the terms such as ACB or Black community, it's definitely not speaking from one perspective, and we cannot capture all. We are trying to pull forward the shared experiences. And unfortunately, in the work that we're speaking about, some of the shared experiences happen to be, the disproportionate way in which that we're seeing living organ donation. So, when we use this term identity or ethnicity, it's very varied. I want to, throughout this, kind of, again, amplify the voices of those who we've been speaking with. And we found that these quotes that were from some of our participants in the study kind of emulates what people said. So they said, what does ethnic identity mean to them? It is not only how we see ourselves, but it's also affected by how others see us. And I thought that was a very important way to frame what we're speaking about today. So all of these labels that we use, we can have our own identities, we can see what we are proud of and who we are, but how others perceive us has an impact on the care that we receive and how we move through the world. Another one of our community members in the study also said it's a part of his politics, it's a present part of his life and the way he thinks and the way that he moves. And I thought that was a beautiful way of kind of capturing what does this mean when we talk about these labels of who is Black, who is part of this community, and how it impacts this work. So why are we doing this? There are so many things that I think need to be addressed. It's been quite a journey working on this action project specifically. We started this project last year, and it was just before, what is being called the COVID-19 pandemic. And since then, there has been so much unrest, both in medical community, both in social justice. And I think it's something that, we need to address. So this work has impacted disproportionately members of the Black community, both from a social aspect, from a healthcare aspect. Dr. Purnell spoke about it so eloquently this morning of, that was just one example of the crisis we have already been in. It's one example of the disparities that have been exacerbated, and our work that doesn't change from that. So when we're looking at transplantation, and we're looking at living donor kidney transplantation, the disparities exist here in an alarming rate. So we see 50 to 70% less likely chance of people from these communities and from our community receiving or giving within this. And so it's something that I believe is alarming, and it's why we're speaking about it today, and we're speaking about the contributing factors to that. So, a few of our speakers this morning, we've as we've said, there's no one magic bullet, there's no one answer. I think all of what we're speaking about together are social determinants of health. And unfortunately, all of these things are things in which members of the Black community have seen a disparity that is much different than those of their counterparts. So these are what's listed from Health Canada of what we consider as social determinants of health. I put up this list because I wanted to really also mention that one of the things through Black Health Alliance and some of our other community groups that we really advocated for was having race and racism added as a social determinant of health, and that has just happened recently. And it's something that we need to speak about. Right now, while we've been at home, everybody's speaking about social justice. Everyone has been watching the way Black bodies have been treated in the media, what's happening. Everyone's been in this state, but it's something that has existed and has been systemic in Canada and otherwise for a long time. And so the fact that our government and those are recognizing it, and it's part of the social determinants when we're looking at why do these disparities exist? Yes, there are comorbidities. Yes, there are cultural beliefs. Yes, there are biological reasons that we're seeing higher rates of certain comorbidities or even these diseases in certain cultures. But the reality is all of those things are intertwined with, how are we expressed and how are we treated and how do we navigate the system? And so we have to take a look at all of these things of why we're seeing such a great disparity. Sometimes it's easy to say, why are we seeing a different rate? Is it just cultural? We spoke about it before. We like to say cultural, then say this is not a modifiable thing. But the reality is there are ways in which we can change our comfort levels. We can change how we interact with the system. So those are some of the things that I want to highlight from our study today. And I don't want to speak just from my words. So again, to bring forward some of those who participated in our qualitative analysis, some of the voices and the words that they said helps kind of frame what it is that our community feels are the barriers to access and to transplantation. So one of the first things that I think everybody has touched on is the idea of trust. And this trust is founded in very systemic problems of how people feel that Black bodies are treated going through the system. We've heard examples of multiple times of when experiments were done without consent. We've heard times of when we were looked at as what the test is as opposed to actually trying to treat. And I think this is intergenerationally within our communities that we think, this is not for us. This was not made for us. This is not for our intentions. This was resonated often within our community members said that whether it is based in, current day fact or it's residual, it's something that has to be acknowledged and understood that these bridges of trust need to be remade. I think I really appreciated what Winnie was saying about her pushy husband. This is something that we heard over and over and over, that many people in our community feel that their advocacy and their questioning and speaking up for themselves had to be a little bit harder, a little bit stronger than what they felt from their other counterparts in order to be heard and to be addressed. It's felt that if we don't ask those questions, you won't be taken as seriously. It won't be perceived as your problems are as deep, or that the problems that do occur maybe are something that can't be changed. And so it's always felt that, like, if you don't speak up for yourself, who will? Or that the system is not intended to look out for our best interests. So this was a theme that was, I would say, the most prevalent theme when we were speaking in community of what are some of the barriers or the reasons why we see such a difference in either who's donating, who's able to receive living donations. And this was the one thing that is very prevalent. The next conversation that came up often were the modes of communication. So whether that's communication intraculturally, how we speak to one another about donation, or whether this is how we are spoken to when we're within the healthcare system. So, one of the quotes that one of our community members said is that there's work within the medical institution to ensure that when I go to the hospital to offer that kidney donation, the doctor meets me, that they treat me like a human being and look me in the eye. So often people felt that, the information in a way that we felt related to or felt cared for, or that depending on where you were entering the system, you would actually receive the same amount of care. And so, that's the way in which this information is communicated, and acknowledging oftentimes this phrase culturally appropriate communication or care is used, but what does that actually mean? And what does that mean when we're speaking within Black Canadian context? How do we receive information? Also looking at these other factors of trust and social determinant of health and all of these things together, what do modes of communication look like in that context? And likewise, within the community, we have to look at how do we speak about these things. There's an idea of, there's a sense of pride, similar to what Nora spoke about in the South Asian community, of there's certain topics that are not up for public discussion. How do we share them? How do we speak about this? And some of the foundation of looking at how to receive a living organ donation is based on sharing your personal health information. So it's something that we have to look at, incorporate into the modes of communication of how does this increase how we speak about this and how we're able to connect around this conversation. One of the other very large themes that came out, and again, the sisters spoke to this morning, I feel like they could have done my talk for me, is talking about the idea of representation, and representation at every level. So, we're having this conversation today. We're ensuring that those who are being treated, those from different communities are speaking, but this really matters to those who are going through the system. So whether it's that those who are doing the research, whether the healthcare workers, whether it's when we are communicating and speaking about how do you access care, ensuring that there are people at every level that look like the person being treated, that we represent those who we are caring for. And this doesn't only include language, although that is very important and something that's often excluded. It's language, it's more subtle ways of communicating, it's understanding culture, it's understanding concerns. Just having somebody there who looks like you, that you can feel more comfortable, that when you're expressing your story, that when you are going through these ideas of trust and not feeling judged are addressed by having those who look like you who are present. So both of these quotations from some of our community members spoke to this, I think, in a very real and present way. The first one was actually from a healthcare professional from our community that said, when they started working in this field, it was very evident that she brought a lot of hope to the Black community. It was almost like they were saying, finally, somebody who knows me and understands me is here to take care of me. It can be a huge burden. And I think that they look at me, that this trust that comes, and also an expectation, but at the same time, what I hear their stories stories, I feel obligated to bring a change. And likewise, on the other side, community members validated that, saying that, when you have doctors who don't look like us or who are practitioners, and they challenge them that they're not going to go beyond and up above for what we need for our care. And so this was something that we heard, across generation, across whether people were born here, different geographic areas, that it matters. It matters whether you feel that this is a representation of yourself and you feel comfortable, and that the way in which we express ourselves can be heard and understood. So I think, the other parts, some of those are institutional, some of those are things, again, that we can modify, that we can increase the conversation, that will happen over time. One of the other themes that we heard was an internal conversation from many of our diverse communities about how do we feel about donation? There's some people who are saying, do we really feel that this is, the appropriate approach? And how do we maybe change that conversation because we don't speak about it? So it's kind of like that same idea of not speaking about our personal health has allowed certain cultural narratives to grow and to say, is this good? Is this bad? What will happen to me? And we have to open up that dialogue so that we understand and are able to better advocate for our health, rooted in fact, that also is congruent with what cultural beliefs are. So it's very interesting that, we spoke with maybe 80 or 90 different members of community, and almost in every group, at least one person said, when you go down with it. And what they were saying was, when what you come into this world with, you leave with. And so it was interesting in us trying to, when we speak about community education and increasing that, it's, we have to be aware of, but how is this seen, and how do we respect these type of beliefs, but at the same time ensure that we're getting the best treatment. And there was other people that also said, when it's time to go, it's time to go. And they feel like it could be either a spiritual thing or a religious thing. And that this level of intervention or medical intervention, it seems too much. It seems like maybe enough is enough. So, again, we're listening. This part of our project, in the action project, we're sitting to listen to others to see, well, let's understand how people feel and see and feel about donation. It's not that right away we're trying to say, let's change what they think and let's change what they feel. But if we understand it, we can make sure to empower people with knowledge that is within that system, so that when they make a decision, it is rooted both in all the facts, and we understand that we can encourage conversations within community that are appropriate and respectful, that they can understand and increase that knowledge base. Oops, sorry. So, often, we talk about these problems or these barriers, but it's important to say what can be done, what can we do, what is modifiable. And I think, this is to reiterate a lot of what has come before, but the top things that have come out of our work so far, and from just speaking with community on a broader lens, is we first have to acknowledge the systemic racism that exists even within our field, within, living donor, kidney transplant, and within organ donation on a whole. There are areas that are very susceptible to racism. There's areas that were set up in a way that the way we ask questions, the way we interact, they might seem very inert to other people, but they are triggering, and they cause a way in which feel like you're being judged, or people from communities. I know definitely within the Black community, we've spoken often about questions that are about social status, questions that are asking about support, questions when we talk about how do people comply to this information, they seem like standardized medical information, but actually they have other rooted implications that we need to look at and say, the way in which we ask these questions, the way in which we stream people donation, could people from certain cultures that have certain beliefs or be excluded because it doesn't fit into this box of what is considered normal or what is the majority? And so we need to really sit down and acknowledge that it has not been inclusive for everybody. It has not been equitable. The markers that we use to say who is worthy of getting donation or how we educate others, it has not been accessible to everyone. And it's something that we have to start there in acknowledging that. And going in from that point and saying, how can we be accountable that we change those things that we are aware of, that we are aware within the system that can be changed? So in doing so, one of the things that was requested from a lot of our participants, from our healthcare professionals, were that we as the practitioners, as the researchers, we have to evaluate ourselves. We have to look at and say, reflect and say, well, where do I contribute to these systems of inequality, and how can we change So then once we have done that, we need to, as we keep speaking about over and over, have representation from community. We can, as much as we want, we can educate ourselves, we can change the system, but then we need to create a safe and inclusive environment that reflects those who are being served. So whether we're speaking about Black community or we're speaking about other communities, whatever community that is being served, there should be representation from that community at every level to ensure that this is not an academic exercise of thinking of equity, but it is something that is included with lived experience. And I think once those things are done, then we need to have community-led and partnered programs that then information can be disseminated in a way that is understood, that is received, that is appropriate, so that we can have people make informed decisions about how we share this information, how we prevent having to be on the list to begin with. But if you are there at that point, how do you share this information and allow this to be a normal conversation? How do we change those narratives within the community so that this is not seen as something that is not accessible, that is not healthy for our community? How do we change that we can say, yes, there is a pathway and we are being included and we have been thought of, and the things that we are worried about in terms of racism or we're worried about of being treated differentially has been addressed, and it's an open conversation. And whenever I say all of these things, it has to keep being repeated. It's not a one-time linear thing. It's we have to do all of this and come back around again and continue to evaluate. So, again, I think this echoes a lot of what everybody has said already this morning. And again, when I'm speaking about this is timely, I think it's important that we keep this in the context that we know there's a lot of civil unrest. Anti-Black racism in our community, not just in healthcare, is prevalent right now. I shouldn't say it's prevalent right now. It's prevalent being discussed and visible right now. And it's something that we are not exempt from that in the work that we're doing. And this quote, I just wanted to kind of end on this that I think was relevant, although it's not speaking about living donation. This is a sister of Jacob Blake, was just speaking about what does it mean for her for change. We continuously are having conversations that are looking at disparities, that are looking at racism, that are looking at atrocities that we are all uncomfortable with. So what does change look like other than having these conversations? And so she was speaking about the situation specifically with her brother, but I think it's relevant in how do we address change within what we're looking at? And she said so many people have reached out to her saying that they're sorry this has been happening to her family. Well, don't be sorry, because this has been happening to my family for a long time, longer than I can account for. It happened to Emmett Till. Emmett Till is my family. It happened to Philando, Mike Brown, and Sandra. I don't want your pity. I want change. And I think, I'd like to leave us on that note saying that, we're sitting and we're speaking about what can we do and what is happening. And I think that's what we need to do.
mainly focus on some of the steps that we are planning to do, really building on many of the things that had been said already by patients and by the presenters. So I will probably skip some of the slides that will be shown here. And let's see, how can I? Okay, so to start with, and again, this reflects to some of what Lydia Joy just mentioned. I think we need to reflect on who we are, what we are doing, and why we are doing, and how we are doing. So in talking about racial equity and access to health, I need to acknowledge that I don't have a lived experience of that. I'm a white middle-aged man who has a lot of frequently unacknowledged privilege. Also, it's important to acknowledge that I'm a nephrologist and a transplant nephrologist in that. And so I do probably have some kind of bias in the way I understand kidney health and the role of transplant in that. And finally, I want to say that the data analysis and the collection in action project is still in progress. And some of these results that I will be showing, we have not been fully discussed or completely analyzed. So I guess this slide is not related to the action project, but it hasn't been stated this clearly today yet, and I think it is important to emphasize that really this is the professional point of view where I'm coming from to this point. This is based on American data from many years ago, summarizing the potential advantages of a living donor transplant and kidney transplant compared to dialysis. Orange is the bar that a young person of 30, 40 years of age would have to live if they had a living donor transplant immediately at the time of kidney failure diagnosis, as opposed to staying on dialysis. The difference between living donor transplant and staying on dialysis for a young individual could be more than 20 years. Deceased donor transplant is somewhere in the middle. And this is why we try to emphasize that from a medical perspective, living donor transplant is the best treatment for kidney failure. The lower panel shows that if you have to be on dialysis for years before you get a transplant, even if it's a living donor transplant, the advantages offered early on, some of it is gone. Still, living donor transplant is the best, but the amount of benefit that you can gain may be less. This slide was shown. This is one of our studies indicating that compared to white patients on the top, patients from racialized communities, whether that's East or South Asian or Black communities, they have much less, 50 to 70% less chance to get a living donor transplant. And this is the overall plan in the action project. And just want to emphasize that in addition to understanding these barriers that were discussed already, we try to take the first steps towards action, both trying to inform healthcare professionals about cultural competency and safety in the broad professional community, and also implement some changes in the clinical practice. This is based on our existing research, and just summarize, this is a mixed method study within the action project where we build on qualitative research that Lydia Joy summarized, and also the BC part has been mentioned by Noor as well. And in the quantitative study, Dr. Gill and his group is doing epidemiology analysis for a large-scale data, and we are collecting data from patients and donors and transplant recipients to understand their attitude and knowledge. Of course, as mentioned, non-English speaking patients were excluded, and some limitations to the data collection also need to be acknowledged, that this is not a representative sample. To date, we have more than 500 patients, out of whom about 150 were self-identified African, Caribbean, or Black. And as mentioned before by Dr. Purnell and other speakers, this group, the ACB communities, have more difficulties with the socioeconomic or social determinants of health, both in education, financial deprivation, and a larger proportion of ACB patients were immigrants, which another intersection of determinant of health. This slides kind of conflicts some of the issued around being able to have a living donor identified, and this is Black and other groups who have no living donor identified at the time of assessment, compared to white patients. All the racialized communities had much less chance to have a living donor identified, whereas there was no difference. Everybody would say that if there was a donor, if there was an offer, they would accept it. So this is important because, as mentioned by Noor as well, that really most of the patients whom we asked, regardless of race or ethnicity, they understood that transplant was a better treatment in terms of survival or quality of life. But still, many of the patients who were coming from racialized communities, they were not able to explore the options. They were not able to have a potential donor. So this is a very stark contrast, that they would be able to and willing to accept the transplant. They know it would be better, but for various reasons, they are not able to explore that. And this is, again, something that Noor showed already. pointing to the Black patients here compared to the white patients. Black patients, but other racialized patients as well, were much less likely to have talked to others about their need for transplant or even sharing educational materials. This speaks to the fact that was discussed before, that in the ACB communities, talking about health and illness is not something that is easily done. And of course, this is not necessarily unique for ACB communities, but clearly this is something that we need to address in our work. Lydia Joy mentioned about the trust issues, which are fundamental. Representation, that we need people who look like the patients in order to have that trust. And this graph illustrates the complexity of these issues where we are. And I just wanted to show this to emphasize that race here in the structure of basic social, economic causes of ill health at the other end here. We try to improve health, but we do need to, under the fundamental foundations, the socioeconomic determinants of health, of which this racialized status is one. And there are many intervening factors that will determine health outcomes. So what can we do here? As I said, we will try to make available for the nephrology professional community culture, competency, information, and training programs. But importantly, we try to work with community partners to co-develop education and clinical pathways about transplantation. And so we try to kind of create this patient-centered, culturally safe kidney space, which is kind of indicated with the blue here in the center, where we work with community health centers that serve mainly or exclusively Black patients. Also, we try to partner with the community organizations like Black Health Alliance and provide the professional support from the transplant program and the renal programs to create a space where patients would be able to meet with other patients or with professionals who are from their community. And we would support those pathways with the highly specialized transplant or nephrology knowledge or tools, but building on both prevention of chronic kidney disease and the best treatments for that. And as I said, we would do that in partnership with many community organizations. The Taibu Community Health Center is one, and Black Health Alliance has been instrumental in moving the project as we are. And we do have additional partners from within the community, hopefully enabling us to achieve what we did. And at the end, I just wanted to acknowledge that the Toronto arm of the Action Project has been working hard. Noor, Beth Edwards, who is one of our qualitative researchers, Lydia Joy, and Paula Neves, who are helping this project to continue. And this is some of our team members who have been helping with the data collection. Thank you very much for the attention.
Thank you very much, Ishvan. That was a terrific overview. Before we move on to the question period, I just want to give a few moments to Dr. Humar to make a few comments about today's session, and then we'll be moving on to questions, so please do submit them on Slido if you have any burning questions. Dr. Humar?
Yeah, thank you, Sunita. I'm just going to turn up my volume here. So I think I'll be brief. I just thought the talks were just amazing, and I think our patient partners especially spoke very eloquently, and it was very moving to hear that. So I think we all realize, but it's worth stating that we as a transplant program and transplant physicians and surgeons take issues of equity and racial disparities in access to transplant very seriously, and I think, in fact, that's true for all programs across the country. But I think we all realize that we can do better, and we have to do better, and we are very open to all the patients who are on this presentation right now, and all the patients out there, and all the community folks out there. We are very open to all the feedback and suggestions you give that will allow us to do better in this area. So, so thank you very much. And with that, I'll turn it over to you, Sunita, to guide the questions.
Thanks very much, Atul. I'll just want to echo Dr. Humar mentioned how important it is to kind of hear from our patients. It is very, very powerful, and I definitely feel like there's a lot of value to hearing what you have to say. And to that end, I'd like to pose some of the questions that's come in on Slido. I'd like to pose some of these questions to our patients. There are a lot of them that are coming to you and to get your thoughts. And so the first one, to the patients, if you can suggest one thing to improve the experience of exploring living donor kidney transplantation for future patients, what would that be? I don't know if Winnie, Rima, or if, oh, sorry.
Is this is anyone's game?
Anyone's game.
All right, so I think for me, and this is something that my sister and I were kind of talking about briefly after we had kind of a little bit of a debrief about what the section today was going to be about, is that, and I don't know how to say this without sounding maybe condescending, but it's interesting that when you come into this kind of a situation, the professionals, you guys know what you're talking about, but we may not necessarily understand all of the jargon and the medical terms and things like that. And so when I was talking about earlier about the overload of information sometimes, and kind of having somebody there to advocate for you and to kind of ask for clarification on certain things, I think that would be one of the first advice that I would give, like one of the things to make sure to have put in place, so that it would drastically improve the overall experience between patient and doctor, or patient and medical team, and even like between patient and their family members, so that when they go back to relay information about their condition or about the procedures, that it's being given perhaps maybe in layman's terms, so that everybody kind of is on the same page and has access to the same information, has an understanding of all that information. Because as much as I like to watch House and Grey's Anatomy, there's only so much that's gonna bring me in terms of my knowledge of medical terms. And so listening to the doctors earlier, which have fascinating data and things like that, unfortunately, most of that goes right over my head, which is something that I did, like I said, if it wasn't for my husband kind of pushing to ask the questions and for clarifications, would have kept going over my head, and I would have had clarification on. And so perhaps that might be one of the things I may suggest.
Thanks very much. Any other of our patient partners who want to chime in?
Yeah, it's Rima here. So of course I had donated my kidney here in British Columbia, although the care was fantastic. I think if I were to reflect afterwards, I felt a bit of almost like, it was that same sort of, even though everything went successful, I did feel a bit of lack of, it was almost like a bit of it was a weird roller coaster ride. So I think just a little bit more attention and care post transplant, more so when we got home, I think would be very beneficial. Oftentimes I was feeling a bit, I didn't know what to feel. And so I think the post care once we got home, I think if that could be a little bit more, little bit attention put on the donor, I think that would have helped my situation out a little bit more. Now looking back.
That's a really interesting comment, Rima. I think one of the things that you mentioned about post-care, and in my mind, this may tie into a little bit of the fear. There's a little bit of the fear factor of potentially of donating because you don't know what to expect. Do you feel like kind of if you had a more cogent post-donation plan or kind of something more comprehensive post-donation that would have potentially, or do you feel that that's something that potentially could alleviate some of the fears that are being felt in certain communities about donating?
Yeah, exactly. That could be it. It's hard to describe what I was feeling. I think you're right. I think it probably would have. I think it was probably a bit of fear, or fear of next steps, or all of those things, and maybe even just checking in and fear of how the kidney was doing within my sister's body as well. So there was just a lot of heightened emotion at that time. Now that I think back, and yeah, a little bit more attention to that, I think would have been great.
We have a question on Slido that I'd like to pose to the research team, and something that potentially you may have found in your preliminary results. One of the questions is, do money or finances play a role? Many people can't take time off work or think that it will cost them money to donate. Is this the case? So just some questions around the economics. I'll open it up to the researchers.
Sure, I can start to address that. So I think in the context of what we're looking at right now, that theme hasn't emerged as a massive as a massive area yet. But I think there's enough of a body of literature that exists prior to this, right? That we know that income matters. We know that financial barriers are a real thing. One of the challenges, as you know, when we look at that data and say, how do you fix that, has been there are programs to certainly supplement some of those things. And there's wage reimbursement and all that kind of stuff that we're trying to move forward on and do more in a more fulsome manner. I think my personal experience is that, it's kind of like what Rima described, right? The issues in the process that are flawed. It's hard to determine to what extent that deters people from donating, right? Because I think, in my experience, the people that have come forward and donated are so committed that they often will go ahead and do it anyways, despite some of the flaws in the system. And so, so it becomes a bit of a philosophical discussion to say, do financial barriers exist? Absolutely. Should we address them? 100%. Will addressing them increase living donation? I'm not sure. But that doesn't mean we don't address them. And that's kind of the ethos, I think, of the project as well, in terms of, when we're measuring the impact of some of this work. Are we going to say that it has to increase living donation necessarily? I don't think so. I think the output here is to make sure that we have a process that's going to be a better system, that's going to support people better. And the hope is that by doing that, you will create a culture of trust and a system that's going to actually encourage people who maybe are on the fence of donating to at least consider it in a slightly different manner. But more importantly, for the people who are wanting to come forward, they'll feel more supported during the process. So to answer your question, yes, I think finances do play a role. To what extent it impacts people's willingness to donate, I think, is still a bit of a question mark.
Thanks very much, Jag. We have another question.
Maybe,
sorry, go ahead.
On that, I think in our data set, we do ask about, or the decision balance questionnaire asks about concerns about finances. And so within our sample of 500-600 patients, we see that actually there is a significant concern, and also what had been discussed in the previous session as well by Dr. Waterman and Purnell. It seems that these concerns are not equally distributed amongst the racialized groups, and certainly ACB communities or patients from these communities seem to be a bit more concerned about some of the issues around medication costs or unknown costs, and also they are more concerned about the fairness of the system overall. So that is one thing. And also just wanted to bring back some of the data that Dr. Waterman presented earlier in the previous session, indicating that out of the 2,500 donor candidates who started the system, people who had better finances to start with, they were more likely to eventually donate. And that kind of points to the possibility that we hear anecdotally when talking to centers in Ontario as well, that centers who serve patients that are more remote and potentially less financially stable they say that many of their recipients would not necessarily even ask or accept a donation offer because they know how much potential economic or financial burden that would place on the donors, or donors would not even consider exploring this option because they know that they cannot even afford a few weeks of being off work. So I think, as you said, some people who are on the fence may be better able to explore this option. And again, I think that's what we try to do, is to enable patients to explore this option, hopefully free of any pressure, either negative or positive pressures.
Thanks very much, Dr. Mucci. I think we're a little bit over, but hopefully we have time for one more question. And one of the themes that came out in today's talk is the difficulty in sharing your personal story and sharing the need for a transplant. And so maybe a question to the panel. Lydia Joy, you touched on this in particular. There's a question about how we can balance respecting people's desire to keep their personal health information private, but also encourage people to share their story so they might be able to find a living donor. And I think that's obviously a difficult balance. People have discussed kind of the idea of having somebody champion the story for you. I'm wondering if you can share a bit more of what your research has been able to discover about this topic in general.
So it's a conversation we spoke about a lot, and I think the important thing is using channels that already exist. So we're trying to superimpose, what we've already said. We have social media campaigns, et cetera, to say, I need a donor, I'm suffering. We often like to plead to empathy in what our healthcare system uses right now, and if that's not in alignment with what some of the groups that we're working with do, then we have to see how is information shared, how is it done in a respectful way that people feel comfortable. And you're right, it might be that there's someone else championing on your behalf. It might be that there's a conversation that's had without sharing that personal information. There might be channels in which information don't feel as public. And so the conversation has been around, this goes back to if you're represented and you have channels and things already in place that are already community led and they feel like a safe space, that information can still be shared. I think right now what it feels like is like coming into this bigger institution when you're not seeing someone that's reflecting you and sharing your information there, or sharing it public, or sharing it in a broader social media, or the other things that are suggested. I think that's what is a deterrent. But if it's done and we create spaces that don't feel so othered, I think we can encourage those conversations.
Perfect. Thank you very much, Lydia Joy. Just Noor, any comments from your perspective with respect to that question about sharing personal information?
Actually, I think Lydia Joy did a really great job answering that. I don't think that I have much else to add. This has been a question that we've kind of been toying with back and forth within our team. And I think that I wonder if the patients and donors have any kind of additional comments to add to that. I'd be curious to hear their perspectives if we have time.
I think we have a few minutes left for a few final comments. Okay, well, thank you very much. So then I think if there are no further comments from our panelists, I'd like to thank everybody for being a part of today's session. I think it was really incredibly informative, and I want to thank all of those who tuned in at home, who participated today, who sent in questions as well. I also want to remind you that we have other sessions for Living Organ Donation Week that include a conversation with our coordinators from the kidney transplant program this afternoon. So please do tune in to that session at 2 o'clock. You can also find the complete schedule of events on www.livingorgandonation.ca. Just want to end the session by not only thanking our panelists, our patient partners, but also we're very grateful for the generosity of our founding supporters, the Astellas Pharma Company, the Kearney and Cahill families, as well as a big thank you to the Toronto General Hospital Foundation for their continued support. So thank you very much for joining. Appreciate your participation and for all of the insightful comments and presentations. Have a great afternoon.
Hi everyone, this is Christy and I'm here to guide you through a short yoga practice. We're gonna do a little bit of movement and a little bit of relaxing and hopefully incorporate a little bit of meditation in. My biggest thing for you is to just let go of any judgment you have towards yourself. If you have no experience with this practice or if you have years of experience, you're still going to benefit from moving your body and trying to relax the mind a little bit. So we're just here, do what you can, and hopefully you will get some benefit. And maybe if you don't have this as part of your practice, you will start to incorporate this practice into your daily life, because it is very beneficial, especially during this time and this we're under a lot of stress and there's a lot of uncertainty in the world. So this can be a very calming and quieting practice for both our bodies and our minds. So thanks so much for participating in Living Donor Week. I'm happy to be a part of it, and I hope that you all get to take something away and learn something new. So for this practice today, we're going to start on our backs in our Shavasana. So just really nice and relaxed, and we'll start working with the breath a little bit and then start to move. So you're going to come all the way onto your back. And just let your body start to settle. Let your feet fall away from one another, arms by your side, palms facing up or down. It's up to you. Just begin to draw your awareness into your natural breath. You're not trying to change your breath here. We're just noticing the breath. And one thing our mind does not do is shut off. So even when we're sleeping, our brain's working, and it is impossible to not think. So this practice, you're not gonna stop your mind from thinking. You're not gonna stop the thoughts from coming in. But what you can learn to do is just let them come and go, and let them not distract you, and just allow them to come and go as they please without you paying much attention to it. So we'll start that by doing an intro to meditation, and this is how I learned to meditate, and it's just by counting the breath. So in yoga, we breathe in and out through the nose, so we're going to start from the belly and inhale, and in your head I want you to start to count to 5. Good, and exhale, count to 5. And another thing you can do, just keep breathing through this. If you don't want to count, you can put your hand on your belly and focus on feeling your belly rise with the inhale and fall with the exhale. And now let's see if maybe you can start to extend your exhale to 6 or maybe 7 seconds. Good, and we'll start to get some movement into our body, wiggle our fingers and our toes. Begin to circle through the wrists and ankles. Rock your neck from side to side. Good, and we'll start by drawing one knee into your chest, and you can wrap one or both hands around if you wish. And just start to get some stretching in the hips. And you can follow that by your opposite knee. And if you want to rock from side to side. And we're going to make our way up to seated position. So you can crisscross the ankles and just rock and roll yourself up, or just come on up however you see fit. From here, moving into our tabletop pose. So coming onto all fours, You want your shoulders stacked over top of your wrists. Knees stacked underneath your hips. Fingertips spread nice and wide, slight micro bend in the elbows. So here you have a neutral spine. We're gonna move through 4 rounds of our cat-cow. So this is really great for the spine. It both flexes and extends the spine. So we'll start, remember, breathing in through the nose. If you can, inhale, start to tilt your pelvis towards the ceiling. Let your belly drop and lift your head. This is your cow pose. And start each movement from your hips. As you exhale, scoop your tailbone under. Begin to round out through the spine, head down last. Good. Think about moving 1 vertebrae at a time. Inhale, tilt your pelvis towards the ceiling. Let that belly drop. Exhale, tuck your tailbone, round through the spine, 1 vertebrae at a time, head down. This is your cat pose. 2 more. Just go ahead, use your own breath. Come into your cow pose. And move into your cat, nice and slow. Last round, cow. And move into your cat. Good. Bring your heels together, sink down towards your heels. You don't necessarily have to reach your heels. Stretch those arms forward and rest your head, if you wish, on the mat or the floor. This is your child's pose. Soften those shoulders, 3 breaths. Good, coming all the way up. We're gonna move into a little core exercise. So there's a lot of different ways that you can modify this for your body. So this works on core and it works on balance. So stay in your tabletop, and if you wanna sink back and just shake out the wrists, you can, especially if you're not used to bearing any weight on the wrists. Can be a little bit uncomfortable. Okay, so back to our tabletop. So we're starting on the left side. So we're gonna extend the left arm. And if this is where you get today, then be very proud and just be grateful for this. So next step, try to avoid kicking anything behind you. That right leg will come out. So we're balancing our body. We wanna ask the core to do a lot of this work. So you're gonna pull up on the belly, draw your navel towards your spine. This starts to activate the abdominal muscles. 5 breaths here. You can stay here for the 5 breaths, or we can take some movement. So you can inhale, bring your knee and elbow to touch. Exhale, extend. You can move through 4 more breaths, or you can start to pulse that back leg. This will help with the glutes. So 3 more breaths, or you can, if you're just trying to work on your balance and you feel really unstable, put your both hands down, or you can just have 1 arm out. 1 more breath. Inhale. Good. Exhale, come back to your tabletop. We're gonna sink down into a child's pose, so you can come into a different variation where you bring your knees apart if you wish. 3 breaths in child's pose. Let those shoulders be nice and soft. Good. Coming back to our tabletop, working on the other side. So this time, right arm comes out, left leg comes out. Good. So again, you can stay here, work on your balance, pull up the belly, draw navel to spine, or inhale, knee, elbow touch. Exhale, extend 4 more breaths, whatever you're doing, if you want to pulse that back leg. Or again, any combination of these activities. So you can stay stable. Again, no shame, no judgment. 2 more breaths. Last one, inhale. And exhale, bring yourself back to your tabletop. Again, we're taking child's pose. Stretching those arms forward, just let yourself melt. If you want to rest on one or left ear or right ear, you are welcome to do that. Good, so we're gonna come back to tabletop. This time we're gonna come all the way down onto our bellies. We'll do a little bit of a back bend. So this is great, especially if you spend a lot of time working at a desk where you kind of tend to be hunched over a lot during the day. This is a really good counter pose for that. So come all the way down. Your arms are bent. You want your thumbs in line with your shoulders. And the key here is to try and soften those glutes. They do have a tendency to sort of tighten up here, but I want you to try and just get them nice and soft. So you're gonna come up to your elbows. You can move your elbows further away from you if you wish, or if you're feeling any sensitivity in your spine. And this is it. We're just gonna look forward for about 20 seconds. Let those shoulders be soft, soften those glutes. And we'll give our back, the backs of our necks, a nice little stretch by just looking down. Soften those glutes. Try to soften the muscles in your face. 3 more breaths here. Good. Come all the way back down. Use your hands, press yourself back up to your tabletop, but swing your legs out to either side. We'll come onto our backs and make our way down to our backs, all the way down, nice and slow. And working a little bit more with the spine, nice gentle twist. Knees are both bent, and just drop your knees over to the right hand side. So a gentle twist of the spine. If this feels like too much, then you can bring your knees farther away from you. If you want a little bit more twisting of the spine, you can bring your knees closer to your chest or your elbow. Shoulder wants to lift off, that's totally fine. If you can, bring your gaze over to the left side. And if both of your shoulders are able to come down onto the mat, then just start to soften them here. Your arms can really do anything, be anywhere. If this is too uncomfortable for your neck, by all means, any position that's comfortable for you. We're sitting here for about 3 more breaths. Just gonna let that spine twist, decompress. Again, counting that breath. If you find that your thoughts are just flooding back, bringing to mind one thing today that you can be grateful for. Very good. So coming out of this twist nice and slow. Bring both knees back to center. And we'll just drop them onto the left-hand side this time. Again, if that right shoulder comes off, that's totally fine. If you're able to get your gaze over towards the right shoulder, if not, again, totally fine. Hands can be anywhere comfortable. And then again, just start to come back to the breath through the nose, letting your body start to soften. Allow your tongue to fall from the roof of your mouth, helping those muscles in your jaw to relax. Very slowly starting to come out. Bring both knees back to center. And we're going to finish our practice in butterfly, recline butterfly. So if your hips are really tight, this is really good for them. So you bring the soles of your feet together and just allow your knees to fall away from each other. So if this is too much, you can lift your bum and then place your hands underneath, palms facing down, or you can bring your feet further away from you. So making sort of a diamond shape, this actually will start to target the low back instead of the hips. Whatever is most comfortable for you here. And I want you to place your left hand on your chest and your right hand on your belly, allowing your face to start to soften all the way from the crown of your head as you exhale. Let each muscle throughout your body start to soften. Maybe starting to count your inhales and exhales, restarting that meditation practice that we started the class with. These last few moments are for you. So just give yourself permission to let that body go. Very slowly, very gently, just start to extend both legs, coming into your final posture, your Shavasana. Arms by your side, palms facing up, feet falling away. Last moment here. With gratitude, start to wiggle your fingers and your toes, bringing your awareness back into your body. Circle those wrists and ankles, rock your neck from side to side. Slowly starting to open your eyes again. We'll do one full body stretch. Inhale, reach both arms overhead, stretch your toes forward, hold this for 5, 4, 3, 2, 1, and then sigh that out, let your body go. Rolling over onto one side, using your arm as a pillow. And then with that free hand, pressing yourself up to your final seated position. The most comfortable position for you, it doesn't have to be cross-legged. You want your shoulders nice and soft, arms resting comfortably. And just turning your focus inwards with love, with gratitude for yourself. Thanking yourself for practicing. And we'll inhale, reach both arms overhead. Exhaling our hands down to heart center. The goodness, the light, the love inside of me honors the goodness, the light, the love inside of all of you. And namaste. Thank you so much for taking the time out to practicing with me and just being here for this week with all these amazing speakers. I hope that you all have a wonderful day, and love and blessings to you all.
Hello, everybody, and welcome to In Conversation with the Kidney Transplant team. And I'm Bill Armstrong. I'm a live donor kidney transplanter that you can submit your questions on slido.com using the event code PM1. Today's session is being recorded, and it will be available on the Center for Living Organ Donation's YouTube channel. Before we introduce our esteemed panel, I'd like to tell you a little bit about me and my backstory. I was born with a solitary kidney, and 3.5 years ago, it became apparent that I would require some kind of intervention. That would be either dialysis or a transplant. And I think I was more concerned about dialysis in terms of the impingement it would be on my lifestyle. And I decided, if it were ever possible, that I would go for a preemptive surgery and avoid dialysis entirely. And luckily, the cards stacked in my favor, and I was able to do that. So on the 27th of June, 2019, my lovely partner of 33.5 years decided to donate one of her kidneys to me, her husband. It was an act of love and extraordinary generosity. And Michael, you said to me that I wouldn't be the same, that my life would be changed forever, and you were right. And one of the great things that it did for me was I finally understood the power of generosity, and that generosity can change the world. And one person's life has changed, and 5, by their family's life has changed, by 10, by 1,000, by 1,000,000. And so that's my story, and I'm sticking to it. And I'm very proud to be here, and I'm very proud of the team that looked after me and my wife and my family. And I want to thank them here publicly today for everything that they've done for us. It is the gold standard. I would recommend that everybody pursue this if possible. So what we're going to do now is we're going to ask our panelists to introduce themselves and their occupations, their titles. And BJ, we could start with you. That would be wonderful.
All right, good afternoon, everybody. Welcome. My name is BJ Realabit. I'm a registered nurse in the role of a clinical coordinator here at the Ajmira Transplant Pre-Kidney Program at Toronto General Hospital. I've been nursing for the last 17 years with my main clinical experience, both inpatient and outpatient, in the transplant domain. And I've been an assessment coordinator here for the last 3 years. I've worked both in the Toronto transplant centers, as well as spent time in the Vancouver, at the Vancouver General program in BC. And I'm happy to be with you all today.
Who's next, Michael?
Hi there, my name's Michael Garrels. I'm one of the transplant coordinators here at Toronto General as well. I've been with the program since 2006, and my main role is working with our patients that are on the waiting list, waiting for a deceased donor transplant, as well as a role with the living donor program. I look after the recipients that are going through the paired exchange program and things like that. So, and been involved with transplant in general for close to 20 years now. Prior to Toronto General, I was with the Trillium Gift of Life network since 1999. So been involved in transplant and kidney transplant specifically for quite a long time now.
Great. Julie?
Good afternoon, everyone. Thank you for attending today's session. I'm Julie Sissel. I'm a registered nurse. I graduated 32 years ago. The majority of my professional experience has been with the transplant program. I started working at the Toronto Western Hospital 31 years ago, actually, and I transferred once the hospital amalgamated into our large multi-organ transplant program around many years ago, actually. So I've been in this position with the kidney donor assessment team, and I've been working in this role for the last 15 years, assessing any donor for the potential recipients that are being evaluated at our facility, and also assessing the donors for Sick Children's Hospital.
Great. Okay. So Leslie, let's go to you next.
Hi, everyone. Welcome. My name is Leslie Williams. I'm the nurse practitioner working alongside this wonderful team here, in particular with our medical director, Dr. Singh. I've been nursing for about 17 years as well. Predominantly, I came from an oncology background. I recently joined the kidney transplant team about 2 years ago when I was working as a nurse practitioner in the inpatient setting with the recipients. And then almost a year ago, I joined the living donor group as well.
Great.
Okay. My name's Moira Corus, and I'm a nurse at St. Hospital, and I've been a nurse at St. for the last 33 years, mostly in nephrology, dialysis, urology, and more recently in transplant. I've actually been in transplant since about 1996 consistently, so a long time. My main role right now is working up transplant recipients and liaising with Julie and Melinda, the donor coordinators at Toronto General Hospital, who are working up our donor teams. I have a very small role with the post-transplant patients. I'm also happy to be part of this group today.
That's fantastic. Is that everybody, or are we missing one person? That's it, right? I believe so. Okay. Okay, so now I'd like to move on to some of the questions and some of the categories. The first one that we'd like to tackle today is the history of the program. And I'll direct the bulk of this to Julie and Michael. We're going to start off the starter question. The obvious one, I suppose, is how did the program start? And what did it look like compared to how it is now? So jump in, folks.
When I was working at the Toronto Western Hospital, it was a combined unit. So it was a urology unit. It was also a heart transplant and kidney transplant unit. And within about a year of my being there, so about 1990, 30 years ago, it was recognized that we could develop a larger program with more experience and research activities by combining the different programs that we had already existing at the Toronto General Hospital. So at that time, a number of my colleagues came over from the Western. We opened up a small unit. I think it was somewhere close to maybe 16, 18 patient bed unit. And we brought together all of the transplant programs from the Toronto General Hospital. So we became a multi-organ transplant unit at that time, focusing on kidney transplant, liver transplant, heart and lung transplant. And we've continued to develop over that time. We had a small staffing population, and as our number of beds grew, we expanded beyond the third floor of the Gerard wing of this hospital. We moved to the 10th wing of the Eaton building, and then subsequently moved to our new home here in the Peter Monk building.
Michael, do you have something to add to that?
No, that's a pretty good history of the program. Over the last number of years, we've really been focusing on, managing the listed patients. We're getting more and more referrals. So, it's really expanding the existing program, making sure that we're utilizing all the resources we have, really focusing on some of the living donor transplants, and then, looking at some of the innovative programs such as paired exchange. A while ago, we were doing more cases like desensitization, ABO incompatible transplants. So really looking at the continuum of care and looking at when the best time to do a transplant is, and really focusing some energy on increasing numbers of living donor transplants.
Over the years, have you noticed that people coming to you, possible patients, they know more than they did 15, 16, 20 years ago? Do they ask more questions? Are they more informed, or are they still, because it's very confusing the first time you enter that world, do they know more than they used to know?
I think we're trying to make more resources available for people, so they are coming in more informed. I don't know that anybody's studied, are they more informed now than they were 15 years ago?
Right.
But we're trying to make things accessible to people, both, looking at eliminating some of the language barriers that are out there, which is a big factor. In the current era with COVID, making things available online, investing resources in doing those sorts of things. So, again, transplant has changed a lot in the 50 years it's been around, 50 plus years, and it'll continue to evolve as needs require.
Right. Okay. When was it decided that there would be separate teams for donors and recipients, and why was that decision made? And Julie, maybe we can flip that over to you to start.
Sure. When I came in and assumed the role as the donor coordinator, I had an administrative assistant assigned with me. And at that time, I took over the portfolio. We maybe had 12 donors and 12 recipients. And so the role of that coordinator was to assess the donor and recipient simultaneously. With our ethicist looking at other programs and how they proceeded from this perspective, many of the other programs, Canadian and European, American, they all had separate teams, so there would be no bias or conflict of interest. So shortly after I commenced my role, I would say within 2 years, so maybe 14 years ago, they went ahead and separated the teams, and then I solely focused on the donor.
Right. TGH is the top transplant hospital in North America and in the top 10 hospitals in the world. And can you sort of, Michael, connect the dots for me between the top rating in North America in transplants and the program that you folks are involved in and have developed from the start? What's that connection?
Well, I think it's a commitment from the hospital level to be a leader in research, in teaching. So we teach nursing students, we teach physicians, we teach internationally, and it really is a hospital focus on those things. And transplant fits very well with that. We train a lot of physicians that go and open programs or support programs in other countries and other places, and are really leaders in those types of things. So it's really a hospital-based focus, and overall with the multi-organ transplant program, the focus is, using all that combined knowledge, because while every organ is different, there are also similarities, and there are focuses that we can, utilize each other's learning and knowledge to make everyone better.
That's great. Thanks, guys. Moira, I'd like to pass the baton to you and have you chat about from the pediatric perspective.
Sure.
Based on what we've talked about so far.
Sure. So we started doing transplants at SickKids in about 1969. And so we just celebrated our 50-year anniversary last year in September. And during that time, we've done about 500 transplants, a lot less than the adults, I know, but it's a high number in terms of pediatrics. And we're certainly one of the biggest hospitals, or do the largest amount of transplants in North America. We typically do between 20 and 24 transplants a year, which about 40% of those are living donors, something around that anyway, about 40%. We also used to work up the living donors for our recipients when I first started in the program, but as Julie mentioned, about 14 or 15 years ago, we also split the teams for the same reasons, conflict of interest, and making sure that there were donor advocates and their team were advocating appropriately for their donors. And so now, since that time, Toronto General do all of our donor workups, and we do the recipient workups, but obviously we have to maintain good communication between those two teams.
How many of the donors, the living donors for children, are their parents? I'm assuming it must be the vast majority, right?
Yes, exactly. A lot of parents, but sometimes it's aunts or uncles, sometimes it's members in the community. Sometimes there's good reasons why parents can't be donors, and so often it is other family members.
One last question, because I'm a twin. Have you ever had a situation where a twin is donated to a twin? Because the match would be pretty good.
Not in pediatrics, just because we obviously our donors have to be over the age of 18. So we wouldn't take a young donor, but probably maybe Julie or Michael could answer that one for the adult program.
Julie, Michael, did you hear the question? Yeah. Twins?
Yeah, it's something we'd certainly consider. There are many factors that go into who is and is not a candidate as a potential donor. So, whether or not the underlying renal disease is genetically related, those types of things. But we wouldn't rule out somebody, and you wouldn't automatically be accepted just because you're a twin. But yes, certainly twins have been used in the past for the reason you mentioned, is if they're identical twins, then the match is there. But there's a lot of factors that go into whether or not that person would be a suitable match or not.
And honestly, I don't recall us ever having a twin donate to a twin. In my 16 years of experience, it doesn't come to mind, surprisingly.
Off the top of my head, I don't remember one either. That doesn't mean it didn't happen, though.
Right. I also want to mention just again, if there are people out there watching who want to submit questions, that's slido.com, event code PM1. Just thought I'd jump in there if you don't mind. Okay, thanks guys. We're going to move on to another topic, and it's entitled Myths About Kidney Transplant / Contraindications. And this is directed to Leslie and Julie. First question that I'd like to pose to the both of you is, what are the most common misconceptions or myths that you hear?
I think the age of an individual being a contraindication to proceeding is one of the most likely things that I hear from individuals. They feel that they maybe they're 30 years old and their 50-year-old parent shouldn't come forward, or maybe it's a husband and wife pair. They're both in their, say, early 70s, and the husband might be the potential donor but feels he's too old. Certainly, we would need to review the donor health history to determine someone's suitability, but age is a relative contraindication. We have proceeded with doing the initial testing on someone who might be by others considered to be unsuitable to proceed. And there are a small number, but a number of individuals that do go through our evaluation process and are found suitable despite their age.
Right. Leslie,
I would agree with Julie on that one.
Yeah. Can you put some meat on the bones of that a bit?
From, I guess, the way our roles work, usually in the beginning, when the health questionnaires are submitted, Julie and Melinda and myself would sit down with Dr. Singh and see if there's multiple donors that come through, which one would be more suitable to proceed at that time. Not saying that the other ones are not. If there is something on the health questionnaire, for example, if they disclose that they have type 2 diabetes and are on insulin, that would be unfortunately, you would not be able to donate. Or if they said that they've been treated for melanoma, that would be another absolute contraindication. But, if someone said I had a remote, benign thyroid nodule that was a low indication for it being malignant, and I'm not actively followed for it, that's not a hard no. We would again say, okay, how about we get your notes and the pathology and whatnot, and Dr. Singh would review it, and in some cases may have to speak out to the team. But those types of ones where people would assume, if I had a cancer 25 years ago and I'm not actively being treated, depending on the type of malignancy it was, we would say, we could talk to your oncology team and see if it's in your best interests that you could proceed with donation. So there are a lot of nuances when it comes to going through those, which is why sometimes it might take going through the first set of preliminary exams and tests to see if the totality of the person's medical history and chart says, I think it's okay for you to proceed. Whereas in other cases, something might reveal itself where we would say, it's not in your best safety.
Right. And what are the contraindications that people are most surprised to hear when you tell them whatever that is?
I think one of my recent ones that I had is a person had a confirmed diagnosis of type 2 diabetes and requiring treatment. And I think first it was the initial shock that I'm diabetic, because they felt relatively healthy, didn't have any sort of overt signs of diabetes. However, going into it, they did have a strong family history of diabetes. So there was a conversation of, well, if I was treated with insulin, could I still go about donating? So it became a conversation about, for example, diabetes being one of the causes of kidney disease in the future, and being able to maintain your own health in a diabetic state. So I think one that just came off my mind was that recent one that I had.
Right. Okay. What are some? Sorry, Julie, go ahead. Go ahead.
Yeah, I was going to say, sometimes the initial donor to be assessed might be found medically suitable based off of the information you've provided on their health history, and they may present with normal preliminary blood, urine, and ECG findings. There may be a small concern on that testing, but not enough to rule them out as a donor. And then based on additional testing through the evaluation, that initial test, in addition to another concerning result, might determine that person's unsuitable over the long term, or unsuitable over a period of time until maybe they've had some dietary modification or lost some weight. So there could be a reassessment at a certain point to be determined in the future. And it's never at any one certain test that we decline an individual. We can never say it's the preliminary blood and urine testing. It might be the CT scan. It might be the treadmill stress echocardiogram. So it could be any test in the process that we might find that person unsuitable.
Have you ever had a thing where someone's GFR's lower than the threshold? They improve their diet, they come back, and they're above it because they've changed their lifestyle, and they resubmit, and they become a donor? Has that ever happened?
That would be uncommon for us to see. We look at our program guidelines for safety based on their estimated GFR, and we also look at the guidelines provided by Canadian Blood Services for the kidney paired donation program. And what we do are a series of blood and urine tests. We review those results, and if it's still unclear, maybe during the 24-hour urine collection, maybe someone didn't follow the instructions and have a proper assessment of that 24-hour urine collection, we might go on and ask them to repeat that test, or we might go on to have them do something called a renal scan, which would be the gold star method of determining their overall kidney function. And based on review with Dr. Singh, we make a determination. And there's always second opinions offered to any individual that's declined by our program. And we would suggest a second opinion at St. Michael's Hospital if they wanted that.
Okay, great, thank you. What are some contraindications that you wish were more widely known or understood? When do contraindications become complicated? History of cancer, etc.
I think cancer in itself isn't a contraindication until we see the actual reports, the surgical reports, the chemotherapy, radiation, and subsequent follow-up from the practitioner that follows the patient, and that we have a letter of confidence from that oncologist, the cancer specialist, saying that they feel it would be safe for this person to proceed with the evaluation, subsequent donation, with little opportunity of that cancer reoccurring or being of concern. I think the biggest issue with the health histories that I've been currently receiving, we're seeing a high volume of individuals coming forward that are in the upper limits of suitability based on their current weight. And so that would be something, if someone's wishing to come forward as a potential donor, if they could either reach out to Melinda, myself, my colleagues within the Living Donor Assessment Office, and we could discuss their current weight and whether we feel it's suitable, they provide the completed health history.
Okay. The pediatric perspective, once again, from Moira, do you have something to add there?
Sure. I just wanted to, I guess I just wanted to go back to the question about, what is the kind of most common myths. And often people think that that an adult kidney won't fit into a 2 or a 3 or a 4-year-old. So they're actually sometimes surprised to learn that that we actually prefer to use adult kidneys in those small children, because they have much more reserve than in that kidney, as as hopefully it lasts a lot of years. And in addition, kidneys don't grow with the recipient as they grow. So if a child does receive a kidney through the deceased donor program from a small child, then that kidney is not going to grow with them. So if they're 4 at the time they receive their transplant, then maybe the donor is 5 or 6, then that kidney is going to stay at that small size. It's not going to grow with the recipient. So that's one of the things. I think, a lot of times people are ask questions about the matching part of being a donor. And although, of course, they have to be compatible in terms of blood group, there's not a need to be matched in terms of with bone marrow transplant, for example, like looking for an identical match. So people we need to have donors match the recipients in terms of the recipient not having antibodies against the donor, but it's not very difficult in some cases. It's very difficult in others when the recipient has a lot of antibodies. But for most children who don't have a lot of antibodies, finding a match is actually fairly easy in many circumstances.
Right. Interesting. Thank you. That's a great answer. We're going to move on to preemptive transplants. We'll direct this to BJ and Michael. First question here is, why are preemptive transplants preferred, gentlemen?
Well, I guess I can start to answer this question. So really, in terms of preemptive transplants, obviously, we do want to try to minimize and avoid the risk of being on dialysis. So whether it's the infection risk or cardiovascular risks of being started on treatment, we definitely want to avoid that. We do, try to balance that with having a transplant and also sort of the immediate short-term risk, as well as, the surgical immediate risk, as well as the risk related to immunosuppression and being on that long-term. So it is a fine balance. So ideally, we would definitely want to have a patient avoid the risk of dialysis. But one of the myths I would sort of add to this conversation is that we do have many patients currently in assessment, and it is very challenging at times to get someone their transplant before they need to dialyze or start renal replacement therapy. So obviously that's the ideal, and we definitely strive to do that. But we do never want to put a recipient, for example, in a situation where they're going to be medically compromised and unsafe to proceed with any surgery at all. And so ideally, we would definitely try to get the patient transplanted preemptively. But there are also long-term risks with being the amount of time you're on immunosuppression, for example, and the risk of being on that immunosuppression related to infections and things like that. And so, yeah. Mike, do you have anything to add to that?
Yeah, when we're looking at preemptive transplants, as Moira put it, some people are a little bit more difficult to match. In the adult world, we do see things like blood type incompatibility. So if you have one donor and the donor is not compatible with you, then we're looking at something like a paired exchange program, things like that, which may take a little bit more time to get you to transplant. So again, if we have somebody who's medically ready to go with a cleared living donor, that gives us that opportunity. And doing a transplant before needing dialysis also helps to maximize the positive benefits you get from transplant. And preemptive transplants are predominantly done with living donors. So again, maximizing the potential benefit to the recipient in terms of how long those kidneys last, adding to life year expectancy, better overall outcomes with that. So there are a lot of positives with doing preemptive transplants. So that's why we try and do it as often as we can. But as BJ said, there are a lot of moving parts. So if you need multiple donors before we find one that is actually a suitable match or medically suitable to be a donor, that all takes time. And some people's trajectory from recognizing that they have renal failure to when they actually need renal replacement therapy sometimes is accelerated or happens faster than we predict. So we don't have tools that can tell us to the day or even to the month necessarily. Everybody's situation is their own unique experience, and we can try the best we can, but it doesn't always work out the way we want.
And I think it's important to point out too the need for the recipient referrals to come at a point that gives us enough time to evaluate the recipient and their associated donors. If someone's being referred to us and their kidney function's down to 10 and they're starting to feel symptomatic, it's very, very unlikely we're going to be able to complete the donor and recipient assessment and have that transplant occur before that person needs to start dialysis. Also, with donors, there is often the chance that the donor might be found medically unsuitable and will need to go on to the next donor in the queue and evaluate that person. So the earlier the donors come forward as well, and the earlier the donor takes the onus on themselves to get the evaluation commenced, then things move along quickly. The initial part of the donor evaluation, we send the donor requisitions for blood, urine, and ECG testing at the local lab. And only once we've received all of those results and they're all suitable, do we move that donor along to hospital-based radiology as well as consults. And so often I may have a recipient contacting my office to ask why their donor isn't continuing the evaluation. And I know that the donor has the requisitions, hasn't completed that testing, and that's the delay in the process. So again, this is in part why we keep the team separate, so there's no bias or conflict of interest. And I only speak with donors, and the recipient team only speak with the recipients.
That's a great answer. What steps should someone take if they're hoping for a preemptive transplant?
So I guess I can answer this, from the recipient point of view. It's really doing your best to share your story with your family and your friends as much as possible. I know the Center of Living Donation in the last 2 years have definitely put great efforts in terms of being able to teach patients how to have this conversation. We know it's difficult. We know it's very stressful. And it's really, they've given patients strategies to be able to share their story in an indirect way, knowing that this ask is not necessarily explicit. It might just be telling them, a trip to dialysis and sort of what their daily experiences are. It's also looking outside of your immediate family and the different social circles that you might be able to tackle. Potentially, doing a sort of, whether it's a media plea or sort of not an advertisement, but just sharing your story with people at work or in a community group. So in terms of finding that living donor, really trying to exhaust all resources sort of within your span of control, and using the resources we have here at Toronto General to be able to, sort of try things out. I know we provide scripts to patients as well that they can use with their families or the different groups that they would hope to approach. Again, to try to make that as least stressful as possible. And really try to make that awkward conversation a little less awkward.
Right. If I can just jump in with my 2 cents worth as well, as I was being worked up so that I could possibly be a preemptive procedure for me, I paid incredibly strict attention to my diet. I did everything to the letter of the law that I was told to do by my renal team. And I think it really helped me in terms of my phosphorus, my potassium levels, my blood pressure. I had a monitor. I took it twice a day. I exercised. I just tried to stay as strong as I possibly could so that I could hold on, because I was at anywhere from 9 to 13. That was the zone that I was in, and I stayed there. And I think partly, and I'm not patting myself on the back, I stayed in that zone because I really paid attention. So I'm just putting that out there to people who are listening, that I think it helped me.
Yeah, and Bill, I guess just to stress that point, really what our focus is from the recipient end is really to encourage the patient to follow the recommendations from their family doctor, follow the recommendations from your kidney care team, and really do your best to really optimize yourself before transplant. We know the outcomes after transplant are much more successful. You'll have a quicker recovery, hopefully, in the event that you really try to do the best you can right now to set yourself up for success in terms of your health.
Yeah, that's a great point. Okay, we're going to go to the ask, and we'll explain what that is. You guys can explain that, what that is in a minute. But the question is, what do you tell individuals who are ready to start looking for donors, and how do you suggest they go about the ask? And so if we can just explain to the listeners, the viewers, what the ask is, and then answer that question. Anyone can jump in, that would be wonderful.
I can take this question. I guess really the ask is in terms of, telling people that you're in a situation where your kidneys are failing and you are looking at potentially as a transplant as a potential treatment for your kidneys, end-stage kidney disease. And really a living donor transplant is potentially one of the options along with deceased donation, right? And as I mentioned before, it's really sharing your story in terms of your experiences, how you're feeling, your trips to and from the hospital potentially, or your assessments. And again, it doesn't necessarily have to be an explicit ask in terms of, going to an individual and saying, can I have your kidney? It's really about sharing your story and sort of, indirectly telling them that there is an option of living donation, that there's resources available to learn more about it. And really in terms of living donor transplants, really being the best and most effective treatment in terms of treating end-stage renal disease is an option that patients do have. And again, like I said earlier, in terms of looking at your immediate family and outside of your immediate family, work, social groups, church groups, things like that, to be able to really explore all and exhaust all of those options.
Great answer. And anyone else want to add to that? Or can we move on? Okay, Moira, can you once again pipe in about the pediatric perspective in what's been talked about here?
Sure. I'm just going to go back again to the preemptive transplant question. And in terms of preemptive transplants with kids, the same, so a lot of what's already been said applies. But in addition, of course, the kids are going through growth and development. So going on to dialysis first has an impact on that. It decreases growth and they really don't grow very well while they're on dialysis, and obviously can't necessarily attend school in the same way. And so development is also affected, and very much dietary restrictions are very tough on children. So that can be difficult. So we do aim for preemptive transplant as well, and we think that outcomes are certainly better with the preemptive transplants. In terms of looking at for a donor and the ask, as it were, I mean, I think the biggest message to me is educate yourself about the process. If you're going out to talk to your family and friends, you need to know what the process is. You need to understand what it is that is involved in being a living donor and what the process is to be assessed. And so, find that out first, and then be able to tell that in your own words to whatever community you decide you want to get that message out to. So whether it's a church community or a sports community or even just amongst your own family and friends, making sure you have a kind of concise way of telling your story, as it were, on behalf of your child. Normally, in our situation, it's the parents that are telling on behalf of the child. And if they're, thinking of using social media or something like that to get their stories out, there are lots of information. Like we have this one pamphlet, which is about social media, and it doesn't say you should use it. It doesn't say you shouldn't use it. It just gives you good things to think about as you might be thinking to get your story out there. And there's also another couple of really good resources about the big ask from the Kidney Foundation. It's like a pamphlet called The Big Ask, or The Big Give, as it were. And so it has, you know, about 5 really good points that it takes you through in terms of what to do if you want to get your story out there.
Fantastic. Anyone want to add anything more to this section? No? We're good? Okay. We're going to move on to the kidney pair donation program. We'll direct this to you, Michael. And first of all, what is it and when did it start?
All right. So kidney pair donation program is one of the ways we get around when we have a potential living donor that may not be compatible to their recipient for some reason. So it initially started as a way to get around blood type incompatibility, and mostly with recipients who are blood group A or B with a blood group A or B potential donor. So, you know, donor A gives to recipient B because their blood type match and a cross-match match, and donor B gives to recipient A. That was the original paired exchange premise. So that program was developed in Canada here in Toronto General 2004 between here and St. Michael's. We had a joint program with that. That operated for a number of years. And then in 2009, the current rendition, which is run by Canadian Blood Service, which is actually a national program, came into effect. So between 2005, when they did their first paired exchange program in Canada, and 2009, when CBS took over, we did about 16 paired exchange transplants nationally. Since 2009 till now, I think we're over 700 with the national program. So the success of that program is absolutely astronomical. So here, BC, Ottawa General, we all did some work with paired exchange prior to that, and it all helped us realize there are limitations with doing this in small numbers. You needed large enough numbers to make it effective. So it is a very strong tool in terms of being able to allow people that have an incompatible donor. And we actually use it a lot now for people that are cross-match or have antibodies to their potential donor. So it's not just blood type incompatibility.
Yeah, and let's talk about the contradictions and the misnomers that are out there about the matching process vis-a-vis blood types. Can you talk to us rather, about a little bit about that, Michael?
Sure. So, you know, you don't have to be an identical blood type. You need to be a compatible blood type to donate. The second part of matching is people have antibodies, and the three main ways people develop antibodies, so a recipient to a donor, is through pregnancy, through previous blood transfusions, and through previous transplants. There are other people that have some antibodies that we don't know exactly why they have. They may have been exposed to something in the past, like a transfusion that they just either don't remember or weren't told about, didn't know about, those types of things, or maybe viral related. We don't entirely know. Those are fairly limited numbers of people. But if you have antibodies to your donor, it increases your risk of rejection, things like that. So we're trying for low immune risk, live donor kidney transplants, which are associated with the best outcomes. And that's why we're, we encourage paired exchange where it's appropriate. We're also now looking into things where, we may be able to get around an age difference between, so if you have a fairly young recipient, but a little bit older donor, we know that, sometimes that age mismatch may affect the recipient. So if we can give that older donor to a different recipient and get a younger donor for that recipient, that might actually be a better situation for them. So sometimes, even though you're a blood type match and your cross match is fine, we may still suggest that paired exchange is something you consider. But it's also important to remember that with a live donor transplant, even an older living donor is probably going to give you a better outcome than a deceased donor transplant. So we can still, it's not always that we say you have to do this, but it sometimes is an option for people. So it is a very strong tool for facilitating transplants.
What are the challenges of the program on an ongoing day-to-day basis for you and your people?
Yeah, so with paired exchange, there's a lot of moving parts. So it's not, often we're doing what's called chains of transplant. So it's not donor A to recipient B and donor B. It's now donor A to recipient B, donor B to C, and you may have 5 and 6 pairs involved. So there's a lot of moving parts. One part of the chain, if it breaks down, then the whole thing has to be reformatted. So there can be times where you have 2 or 3 or 4 proposals before you actually get to transplant. It does take several months to work out all those logistics, make sure that everything's fine. Travel can be involved usually by donors. Sometimes we have to ship kidneys, which can be challenging as well, making sure that we can get those. There's a lot of logistics that are involved in the paired donation program that aren't part of a straight living donor transplant.
Right. So. Fantastic. Thank you for all that information. That's fantastic. We're going to move on now, folks, to the Slido questions. And Courtney's going to jump in here and guide the ship. So thank you, everyone. It was wonderful. Brilliant.
Thanks, Bill. Okay, so our first question here is, how long does it take to determine if a person is compatible to be a donor?
It's Julie here. I'll give a response. So the first step in the donor evaluation, we receive the donor health history to determine their suitability based on the responses they have to the medical questions, surgical questions in that document, amongst others. We ask them to provide a copy of their blood group. We give them a requisition to do so. And the recipient program has the recipient blood group on file. So we compare the two. So we could determine blood group compatibility at that time. From that point, if the donor is suitable on the health history information, we move ahead and have the donor do blood, urine, and ECG testing at the local lab. Following those results being reviewed and determined to be suitable, the person moves to the next step, which includes a blood test at our hospital. And this blood test tells us about the genetic markers for that potential donor, and we compare that specimen to the recipient specimen to determine if the recipient has antibodies to that particular donor. So if the recipient has antibodies, that would be an incompatible pair, and we would need to look at one of these specialty programs, such as the kidney paired donation program, to accomplish the transplant. The other issues that may determine if a person's compatible with the recipient, again, as Michael alluded to, there may be an age difference between the donor and recipient. So someone might want to consider the kidney paired donation program for a better match. And sometimes there's a large mismatch in size between the donor and recipient. And again, that might be a consideration for the kidney paired donation program to have a better size match.
Great. Thanks, Julie. Let's see here. So at what point, I feel like you kind of answered this just now, this paired donation question. At what point in the journey of kidney failure should the paired program be considered? Okay. Next, can the donor and recipient share medical information when going through testing?
Absolutely. We encourage them to have an open conversation. And as again, we keep the team separate, and so I could only share the donor information with the donor. So it's really vital for the donor to be responsible for the information that myself and our donor coordinator, Melinda, as well as our nurse practitioner, Leslie, and Dr. Singh have shared with that donor, and that donor shares the information with the recipient. And that keeps the recipient up to speed as to the happenings and what to anticipate in going forward. There might be a donor that does not want to share their information, and certainly that's fine, but we just can't be crossing over the confidentiality of that donor and exposing the information they may not want shared. And I wouldn't be speaking to the recipient. I would defer them back to the recipient coordinator. And the recipient coordinator does not have access to any of the donor's information as well. So they would not be able to comment on the specifics of the donor.
Thanks, Julie. For this question here, I would just ask this person, this is definitely a great question. We have a session tomorrow in conversation with psychosocial and ethics. So I think this might be a great question for tomorrow if you want to submit to that, the code for that session is PM2. So moving on, donor and recipients, if working, have to use vacation time or leave of absence without pay. Very difficult for those who do not have financial support from a family member. Is this being addressed? I guess this, this kind of has to do with pre-laud. Can anyone speak to maybe some of the supports that are available through that program?
The pre-laud program is put together by the Ministry of Health and Trillium Gift of Life. It looks at a total reimbursement up to $5,500. The donor is responsible for keeping any receipts associated with their evaluations, such as travel, hotel, flights if they're coming from out of country. And they put those documents forward to this group, and the group determines how much they'll reimburse the donor for. When there's difficulties with financial support, sometimes a workplace might ask us for a letter, which we'll provide. And maybe based on that letter, they might be able to cover that donor's time off of work. Some companies have a much stronger support of potential donors, and we're willing to reach out on behalf of that donor to help support the financial coverage.
All right, thank you. This might be a bit more of a comment, but only kidney transplant patients know what they go through: suffering, pain, dialysis, search for donor, financial crisis. It is traumatic. For outsiders, we have no injury, no marks. Ask us, why did God save us? Please request the government and health fraternity to look seriously into our lives, please. Thanks for that comment. Why are donors tested sequentially? My wait time for transplant was an emotional roller coaster, not only for me, but for my family.
When we're looking at donor testing at our facility, we evaluate one donor at a time. There might be other facilities that have a different way of operating their donor evaluation. Our program has a very remarkable turnaround time in having a donor assessed, and we want to offer equity to all potential donors across the board. We only have certain resources available to the program, whether it's testing spots or assessment spots, say with the social worker, and we need to use those assessments so that we can take care of the population equally. At any given time, we have somewhere between, say, 240, 260 donors in evaluation, and we're able to get a donor fully evaluated with less than 2 months' time. And if we were assessing multiple donors for one potential recipient, we would not be giving other potential donors a fair chance at undergoing the evaluation.
Okay, thanks, Julie. Anyone else can feel free to jump in as well. Julie, I just don't want to make you feel pressure to answer all of the questions, but thank you. What questions should a kidney transplant recipient ask of their donors before they register to be a donor?
I can take this question, Courtney. Really, in terms of the recipient ask, really it's more if they want to learn more about it, to be able to direct them to succinct resources, to be able to learn more about the donor process. We don't want the recipient sort of trying to get more health information from their donors, because obviously if they're not entitled to that information, and really to sort of protect the donor process, we encourage the donors to seek out the resources we have available, really independent of the recipient. And what I always tell our recipients is that they, even though it's important to know a little bit about the process, they don't need to necessarily feel the burden to have to know or be an expert around the whole transplant process or the donor process. And that's why we're here. And so really to direct their questions to us as sort of a first go-to if it is a possibility.
Can one donate a kidney into the paired program to speed up the wait time for the recipient with a EGFR over 20?
I can take this one. So if your EGFR is over 20, you're probably not ready to receive your transplant yet. BJ talked about this, as there is a balance between doing a transplant prior to needing dialysis and doing it too early, which increases your risk of having immunosuppression for a longer period of time. So there are some circumstances, and right now it is not part of the paired exchange program, but it is something that's being talked about, is whether or not a donor can donate in advance, and certainly that is something that is being talked about, but is not part of the program right now. So in general, we wouldn't have a donor go and donate before their recipient is ready to receive a transplant. We wouldn't want to do that. And sometimes it can be many years if a person has been cleared for transplant, but their GFR is around 18, 20, they have no symptoms. You know, sometimes it can take 2 or 3 years before their kidney function declines enough that a transplant's actually indicated in that time period of time.
Okay, thanks, Michael. What complications can occur from being a living kidney donor?
The complications are very unlikely to occur. There can be complications either associated with the surgery or from the anesthesia. If there was anything that would determine there could be a complication either at the time of kidney donation or at some point following the donation over the course of someone's life, we would not be going forward with that donor. We would be declining them. But again, the surgical complications are no higher than potential risk than other surgeries an individual may have. And we would be reviewing them on multiple occasions with the donor through our nurse practitioner, the director of our program, Dr. Singh, as well as with the surgeon preoperatively. And as putting it out there as well, if anyone's ever interested in being a potential donor and has any questions, they could certainly contact myself or my colleague, Melinda Shell, and we'd be willing to answer those questions. We could set up a telephone call and certainly provide any feedback that someone might need to help reassure them about this process and going forward and the safety of it.
I would just like to add as well that during the medical evaluation, when Dr. Singh sees potential donors, if there is something that comes up through their medical evaluation that may increase certain risk factors, she does have a detailed conversation with them about them. So the donors are aware at the time where they consent to move forward with donation if there are certain risk factors that need to be noted. Dr. Singh does go over that with them.
Great, thank you, Leslie. This is an interesting question. How many transplants can a person have?
I can answer that question. So there's really no limit to the transplant as long as there is a place where we can put the kidney in. So some people have, had 2 and 3, and we have assessed people for as many as 4 transplants. So we need space to put it. But the more transplants you have, the more likely you are to have had antibodies develop over that period of time. So you may become more difficult to match over time. And each, over time, the amount of immunosuppression you have can lead to other complications. So it's a matter of, are you healthy enough to get the next kidney transplant? So that's why we try and make transplants last as long as we possibly can by following you throughout the course of the transplant, having you take your medications, do your follow-up blood work, those types of things. So the better we take care of the kidney and the longer we can make the first one last, the better off you are overall. But there's no specific number of how many you can have. It's whether or not you're healthy enough to get it and we have a place to put it.
Great, thank you. So we're just coming up on time here. So maybe we'll just make this the last question. And then for everyone who still has a question in Slido, you can go back and check Slido and we'll respond to make sure that you get the answers you need to all your questions. So for this final question, will the recipient recover faster than the donor?
I guess I can take this last question. So I don't know if you're speaking directly around sort of the anticipated length of stay. So for a recipient from a living donor surgery, we typically quote for, a 5 to 7 day length of stay, sometimes a week to a week and a half. Obviously, it depends on the condition of the patients going into surgery and sort of any undue sort of unexpected complications that happen during the hospital stay. So it can vary, but those are typically the sort of average length of in-hospital stay for both the donor and the recipient. The donor is about 3 to 5 days if all is well. and everything goes as planned.
Awesome. Thank you, BJ.
That was great. You people were great. So, thank you for joining us today. It was fantastic. A big thank you to all of our panelists, our superstars, also to those who submitted questions and everyone watching at home. We really appreciate your participation in live donor kidney transplants. Just a reminder to tune in to tomorrow's session, afternoon session, and it is in conversation with psychosocial ethics teams, moderated by non-directed liver donor Heather Badenoch. And finally, we are exceptionally grateful for the generosity of our founding supporters, Astellas Pharma Company, and the Carney and Cahill families. And thank you to Toronto General and Western Hospital Foundations for their continued support. And I hope everyone enjoyed this webinar as much as I did. Thank you very much.
Thanks, Bill.